can't remember past are condemned to repeat it, and to draw the lessons from the history, to find a worthy ideal heroes, and decide and predict the future. History has been divided into various eras. There is a prehistory before the writing, then the ancient history up to 1500 BC, then Middle Ages 500 to 1500 AD, and modern age from 1500 AD, and then the contemporary age. In prehistory, if we go, we get the examples of healed fractures in prehistoric human bones, suggesting setting and splinting have been found in archaeological records. The oldest surgical amputations were carried out 31,000 years ago. In 6500 BC, skulls found in France show signs of rudimentary surgery called trepanation, which involved drilling of the hole of the skull. In China, instruments resembling surgical tools have also been found. And various records have been found in Egyptian pyramids. And in India, Sushruta, who is the father of Indian surgery, and also contributed in form of Sushruta Samhita, which is still there. And ancient Greek, Hippocrates and Galen are the known. In ancient history, Nibavia archaeologists have discovered bronze instruments with sharpened obsidian resembling modern-day scalpels, knives, and griffins. The Code of Humerani, one of the earliest Babylonian code of laws, itself contains specific legislation regulating surgeons and medical compensation. So these are various records which are available. Coming to Bharat's contribution, way back 3000 BC, trepanation and broken bones were found in the Indus Valley civilization. Teeth discovered from Neolithic graveyard in Mergra had signs of drilling. Sushruta Samhita describes in detail the examination, diagnostics, treatment, and prognosis of various ailments, as well as procedures on performing various forms of cosmetic surgery, plastic surgery, and rhinoplasty, which are still practiced. And he has been recognized as father of surgery, and now even his statue has been established in Royal College of Surgeons of Australia. In Sushruta Samhita, there are 184 chapters, 300 procedures, 120 instruments, and various techniques. And besides that, there are chapters on ethical practice and surgical training too. There is a philosophical foundation of Ayurveda in Sushruta Samhita. There is a tridosha theory and surgical indications. And there is an integration of surgery with internal medicine. There is emphasis on hygiene, ethics, as well as holistic care, which we all feel that we need now in our era also. And the 5 chapters, they are divided as various sutras, and there is a last chapter of the Uttan Tantra. More than 1100 diseases have been described, various medicinal plants, and instructions of performing surgeries, including 3 types of skin grafts, and reconstruction of nose has been described, and forehead rhinoplasty, which I have already told, and this can be regarded as golden age of surgery, which is documented. And the rhinoplasty has been described as a free graft in detail, and these basics are still followed. And during the 8th century, this Sushruta Samhita was translated to Arabic, and then it made its way on to Europe. The Arabic translation, which is known as the Kitab Shahe Shun al-Hindi or the Kitab-e-Susrund. Sushruta is the best known for its approach and discussion of the surgery. The first English translation of Sushruta Samhita by Kaviraj Kunjalal Bhishmagratna was published in 3 volumes between 1907 and 1916 and were reprinted in 63 and 2006. There are other texts also in India, Charak Samhita, Bela Samhita and Harita Samhita. But these texts are found to be incomplete or in some corrupt form. And Charak Samhita is considered one of the 2 foundational Hindu texts survived from the ancient India. Along with various techniques and therapies to cure disease, it is described one of the importance of the diet, hygiene, prevention, medical education and teamwork of physician, nurse and patient necessary to recover the health. And at that time, Takshila was the center of excellence for teaching, and several Buddhist texts have also been discovered. And these cosmetic surgery have also been described in detail in these texts. And various formulations are still under clinical trials, which were formulated then by Ayurveda in cosmetology in present days era. Various elaborate description of surgical instruments is given in the Sushruta Samhita, and a detailed description of 121 types of surgical instrument is available in Yantra Vidhi Adhyay and Shastra Vidhi Adhyayas. And these have been described in various shlokas, and they are classified also according to the various shlokas. And Sushruta says that they should be of proper size and their end should be rough or polished, and they should also be strong, well-shaped, and should possess the firm group. There was 3 broadly classified 6 types of instruments: Swastika Yantra, Sandesha Yantra, Tala Yantra, Nadi Yantra, Shalaka Yantra, and Upayantra. And these are further classified into different subtypes, and various description of this is still available. And in Swastika Yantra, there are 18 angulas in the length, and the ends are shaped according to the faces of various animals and description. So these are some of the pictorial representation of the instruments which we use in some form, and they resemble our instruments which we use today. These are the tooth forceps-like instruments which we use today. Then there were Tala Yantras, scoops, various types of the Nadi Yantras, various types of examination tools which we use today. Then irrigators like instruments known as Vrana Yantra, Dakonda Andra Yantra. Then dilated types of instruments known as Nirudra Prakashna Yantra, Syringa Yantra. Then cuppings were available. Then Vasti Yantras were available. Then examination of the mouth were available. So these types of, even the methods of controlling bleeding has also been described in the whatever technology they had. But in Upayantra, there are those similar to yantras, but they are inferior to the yantras, and these includes several types of threads, which were used, and different types of clothes were used, and even the clothes and vastra have also been described in those eras, which we have evolved in course of time. Nakha, mukha and bala means regarding hairs, we have also been described in detail in these. And their different types of functions of yantras have also been described in detail. Then Shastras, there is a description of 20 Shastras which have been described. And there are 4 types of edges of the instruments, and how these instruments are sharpened, that has also been described in detail in form of mantras. And we need to know, have the knowledge of Sanskrit to understand these words, but they have been translated. So these are various types of instruments which resemble the present day instruments which we are using nowadays. Various types of needles have also been described in detail in these mantras. The other contributor which is known is the Jivaka. He was the renowned physician and surgeon in ancient India, best known as the personal physician to the Buddha and the king Bimbisara. His primary contributions span innovative surgical methods, public health advocacy, and integration of medical practice with Buddhist ethical principles of compassion. Charak, besides giving more importance to the medical part of the treatment, he also, there's a Charak Shapat, he devised that, which gives the oath, which is more comprehensive than the Hippocratic oath which we take in our medical practice. Nagarjuna, he is believed to be an alchemist who worked extensively with mercury and promoted the use of chemical treatment rather than herbal and vegetable mixtures. He explained the circulatory system in detail and referred to blood as Rakta Dhatu, developed several specifically formulated compounds with medicinal properties known as bhasmas, according to whom Vigraha, Vyar, Vartika and Rasaratnakar are the 2 key words in the realm of medicine and alchemy. Bhagbhatta and Madhavacharya were again, these were the people contributed in around 7th century in the field of surgery and medicine. So the Jivak, he is credited to perform many surgeries, including craniotomy, abdominal surgery, fistula treatment, hydrocele surgery, and foreign body removal. And all this, they also believed in holistic care as well as herbal medicines. Buddhists also contributed in field of public health.
2 more minutes.
And these systems stressed on the empathy which we need in our medicine system, and somehow or the other it is lacking in present day era in many fields. And we must know that professionalism is the basis of medicine's social contract with society, and professionalism demands placing the interest of patient above those of the physician, setting and maintaining standards of competence and integrity, and providing expert advice to the society in matters of health. So we have to build empathy. So this empathy has to grow in our training and our care to the patients, and we need to have a balanced approach and have the optimal use of technology. At the end, I would like to invite you all for our annual conference of IAGS to be held in Mumbai next year from 12 to 15 February. It will be a combined meeting with the ELSA spring meeting also. Thank you very much.
Thank you, sir, for a wonderful presentation. Next, I'd like to invite Dean Edward Klinger, Vascular Emergencies, what surgeons should know.
This one, right, sir?
Yep. Yes.
Do you need a pointer? Shall I get one?
If you have one. Good morning. My name is Dr. Dean. It says I'm a vascular surgeon, but actually I was trained as a general surgeon, and 50% of the work I do is general surgery. So I'm real happy to be here amongst a bunch of general surgeons. This is my home. I pretend to be a vascular surgeon when I'm back in the States. Thank you for inviting me. How do I proceed? This one? Oops, don't touch. This? Right, so I'm from the United States. Let me see, where's the pointer? Anyway, the red dot on there is Milwaukee, Wisconsin. Wisconsin is, Nepal is probably 3/4 the size of Wisconsin. The northern part of Wisconsin is all woods and lakes. There's about 10,000 lakes in the northern part of Wisconsin. So we're very lucky to have a bunch of water. The Great Lakes, I'm going to try this. Yep, Great Lakes. They say 10% of the world's fresh water is in those lakes in and around our area. So we are very happy and lucky to have fresh water. And that's the hospital that I work at, and my office and clinic is in this building. Kind of a big place. So what am I going to talk about? I'm going to talk about peripheral vascular injuries and occlusion. I'm going to talk about emergencies, really. When to operate, approach to repair. I'm going to talk a little bit about compartment syndrome. And then lastly, being a general surgeon, I want to make some comments about acute abdominal pain. So vascular trauma, when do we intervene? I'm going to talk about there's hard signs when you say, oh, have to operate. And there's soft signs where you're going to say, gee, I wonder if I need to operate. I'm going to talk a little bit about how to intervene and the instruments that we use and the complications that we can come upon. So arterial trauma, it's a big thing. I mean, it's a major source of morbidity, mortality. If you don't get it right, things don't turn out well. Time is everything. The more the delay, the worse the outcome. So when do we intervene for vascular trauma? Hard signs. Okay, when you need to or you have to intervene. Well, if it's actively bleeding, well, that's a no-brainer. Of course you have to operate. Expanding hematomas. Patients will usually complain of pain if there's a hematoma and it's still bleeding and it's still expanding. They'll complain of a lot of pain. If there's a hematoma and it's no longer bleeding, they usually stop complaining of a lot of pain. They'll just get, it hurts. So expanding hematomas. Ischemia. Well, obvious, if there's no pulses and the leg is cold or the arm is cold, you need to intervene. And if there's neurologic deficits, the nerves have been injured. If the nerves have been injured, most likely the blood vessels have also been injured. Active bleeding, what do? Well, you pack, if there's an open wound, you pack it tight. If there's a blood vessel, you put your finger in there. If you got your finger in there, what do you do next? Well, you call for help, you get suction, you make sure the operating room's available. Don't be too proud to ask for help. Ask for help, ask for help. Can't do it all yourself. Tourniquets. can be life-saving. Now, frequently we see people with using a belt, you know, and pulling it tighter, but actually what you can do is just take a loop, you know, of anything, cloth, a shirt, whatever, and you put a stick through this loop and you wind it and you turn it tighter and you turn it tighter and you turn it tighter until the bleeding can stop. You can do that out in a remote area. You can do it in an emergency room in your hospital. Tourniquets on a leg or arm, up to 4 hours, 2 to 4 hours can be on there without really causing any permanent damage. If there's an open wound, don't go putting clamps in there blindly unless you absolutely have to, because you're going to injure something you don't want to injure. Expanding hematoma, I briefly touched on this already, but just apply pressure to the area. You can put a tourniquet around it. Just put pressure on it. Call the operating room and let them know you're coming. And then I'll talk more about it, but how to actually do the operation. I'll expand on this in a little bit, but you get proximal and distal control. If there's no injuries elsewhere, once you have control, you can give them heparin because, you know, to prevent clotting new places. And you'd say, well, they're bleeding. Yeah, well, I'm not telling you to always give heparin, but if the artery's injured, you can give heparin to prevent further clotting. And I'll talk more about the use of a C-arm in a little bit, and angiograms. Ischemia, well, this is an obvious hard line. You know, you don't feel a pulse, something isn't right. If there's a dislocation, you reduce it. If there's a fracture, you fix it. Because you do have time in this case with ischemia, a little bit of time to get things right. Then you have to ask yourself, am I going to get an angiogram before I explore or not? Me, I'm old school. I'm an old guy. I can figure out in the operating room the problem. I don't have to have a fancy CTA or fancy angiogram ahead of time. I'm old. I go, oh, there's no pulse there, but there's one here. The problem's in between. Oh, the problem's there. You can figure it out in the operating room. If you wait too long for a CTA, they'll lose function of their arm or their leg. So plan your operation, get it in your head, start planning your operation. Here, I just talked about this. Do you need a preoperative angiogram? No. You can figure it out. You can use an ultrasound or just use your finger. Now, this is the harder one, the soft signs, right? The hard signs, they're bleeding, well, gotta operate. Expanding hematoma, gotta operate. Ischemic leg, gotta operate. Well, what if you don't know? So we call these the soft signs. So there's a hematoma, but it's not expanding. Do you need to operate? There's a history of blood all over the place. Do you need to operate? Don't know. If the nerves are injured, well, there's a good chance the vessels are injured. So in 35% of these people, where there's sort of a soft sign, you're not real sure, 35% of those people will have an arterial injury. And the way you kind of will know is with an angiogram. But a soft sign is different than a hard sign. Hard sign's an emergency, boom, gotta do something now. Soft sign, you gotta figure it out. Well, how can you evaluate somebody where you're not sure if you need to operate or not? Well, ankle brachial index is one of them. Ankle brachial index, well, vascular surgeons kind of know this, but you measure a blood pressure in the arm, and you measure a blood pressure in the ankle, the posterior tibial and dorsal pedal. You just take a regular old blood pressure cuff and you measure it. And you take a Doppler, you get it from OB or wherever, and you listen to the sound. And if that ratio of the blood pressure of the ankle to the arm is less than 0.9, it's abnormal. Okay, normal would be as blood pressure in the ankle is the same as in the arm. So if it's less than that, it's abnormal. All right, so then you have time. You can figure out if you need to do further investigations. And what are those? Well, you can get an ultrasound or duplex scan, look for the injury. Or you could get a CT angiogram. or if where you work has none of those things, you can transfer them to a place where they can do those things. What I have seen here in Nepal over my many visits is people here are very, very, very good at ultrasound. So you guys are smart. You can figure this out. Well, what do you do once the injury's found? Keep your cool, all right? We're surgeons. We're general surgeons. General surgeons can do everything. We can put intestines back together. We can put, chest tubes in. Guess what? You can fix blood vessels. Keep your cool. Think about it. Be creative. The key, though, is exposure, 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 exposure. That's the key also in general surgery. It's the key also in vascular surgery. Don't try to fix a blood vessel through a little hole. Make a bigger hole and a bigger hole and bigger. Whatever you need to do to see it. You are there to save their life or save their limb. What you do if there's bleeding, you get proximal control, and I'll show you these exposures a little bit. And once you stop the bleeding, you can get an angiogram if you want, and I'll talk about that. If there's bleeding, well, how do I want to put this? If there's a bleeding point, say a hematoma or actively bleeding, you make your incision proximal, okay, above it. Let's say I'm bleeding here from my arm at the antecubital fossa. You make an incision here, get control, down here, get control, and then you attack the bleeding point. That's what you do most often. If the artery is occluded, make your incision where you think the problem is, okay? So it's a little different. For occlusion, you attack right where the problem is. For bleeding, you kind of try and get proximal and distal control first. And again, I'll talk a little bit about angiograms in a moment. So exposure and proximal control. If the bleeding's up in the axilla, you can get control of the axillary artery up here just below the clavicle. Okay, you come through the pectoralis major, you pull the pectoralis minor over, and boom, there's your axillary artery. Put a clamp on it, you got proximal control. Distal control you can get down here. Make the incision big enough. Brachial artery, well, this is obvious. You can just make, if they're bleeding, proximal, distal control. You don't always want to go right where it's bleeding because it bleeds and you can't see. And this is what I just said. Watch out for the median nerve. Median nerve sometimes looks like the artery, so just be a little careful. Femoral artery, that's an easy one. Now you just kind of make your incision up in the inguinal canal area and get proximal control, put a clamp on the artery. Now sometimes what I'll do, or many times what I'll do, is I'll get control there and then control below, and then you can give them heparin and clamp above and below and then attack where the artery was injured. If you're not 100% sure where to go, you can shoot an angiogram. Okay, you just simply put a needle into the artery, clamp the artery, put a needle in, inject dye, and using the C-arm, you can get your angiogram right there in the operating room. You just, as you're injecting the dye, you use the C-arm and use fluoroscopy, and you watch the dye go down the artery, and you say, oh, there's the injury. I can fix it. Oh, 2 minutes. I can do it. All right. What does it look like? Sometimes it's a disaster. Tools, here I just talked about this. You put a needle in the artery, get some dye, use a C-arm, so you can get an angiogram anytime in the operating room. You don't have to have it before. Embolectomy, so that's a catheter with a balloon on the end, and you push that through the clot and you drag it back and pull the clot out. And again, like I said, you attack the artery where you think the occlusion is. When you go to repair an artery, here this is an artery that was injured, and this is a vein patch that's on it. So you can use artificial material, but the best to use is vein. You can use vein from the same limb, or you can use it from the opposite. Don't intervene when it's like that. That's ridiculous. The vein, you can ligate. You can almost ligate it anywhere. Don't worry about the vein. Anticoagulation afterwards, just give aspirin. Aspirin's adequate. Don't have to give heparin. I'll skip over fasciotomy because I have 32 seconds left or whatever. But fasciotomies, don't do all that special stuff and then forget to do a fasciotomy if need be. So here, being a general surgeon, I'm just going to talk about the 5 causes of acute abdominal pain. Someone will say, well, I'm sitting there eating my Dalbot and all of a sudden, boom, I got severe abdominal pain. In my head, I think of only 5 things. 5. Acute mesenteric ischemia. They threw an embolus to their bowel. Boom. Hurts all of a sudden. Horrible. Perforated vessel, okay, ruptured in the aorta, ruptured mesenteric vessel. Boom. Sudden onset of pain. Perforated viscus. They perforated your diverticulum or ulcer. Kidney stones can cause acute abdominal pain. Usually a little different though. It'll be more in the flank or passage of a gallstone. Now, of these 5 things, perforated viscus, they'll have peritonitis. Kidney stones, flank pain, okay, they won't have peritonitis. Passage of a gallstone, they won't have peritonitis. Mesenteric ischemia, they'll be rolling around in the bed uncomfortable as all get out. They can't get comfortable. Causes, right, will be embolus, or the other is a volvulus, if they've torched their bowel and it's now ischemic. So that's about it. And then I went on in more detail, but I guess my time is up. Hopefully you've learned 1 or 2 things. If you have, I've been successful. Thank you.
Thank you. What's the next one? Next one, the speaker is Dr. Pierce Dahl. They will be talking about medical legal issues in contemporary medical practice.
We are facing lots of medical issues these days. I try to present this presentation when I went to the Nepal Medical Association, was asked to have a meeting, and I asked them, where is the fault? And no one was initiating that where is to improve from ourselves. Everyone was protesting against the Consumer Act. They are only focused on the Consumer Act. But where we should focus, we don't know. So I went to some literatures. I went to the website of the Supreme Court, and I finally decided to present 10 cases, but due to time constraint and the documents we call the Purna part, when the Gen Z hooliganism occurred, all the documents were destroyed, burnt, and I could not retrieve from the website, and I couldn't went to the Supreme Court to get all the documents to make a solid presentation. I'm going to tell something about top 10 killers of the world. What is that? World Health Organization says, can you imagine? The most top 10 killers of the world. It says, medical negligence. It focused out on the medical negligence. And I have put some papers, news over here. There are lots of things. Doctors are charged for the compensation. Lots of death due to medical negligence. Are we aware of it, all these things? Should we know something about it? What is the major cause? And we are searching all these solutions. We are searching the solutions on the medical insurance. We are searching on the legal lawyers. There are lots of things. And insurance companies are coming forward. We are here to protect you. We will save something to you. Is it the ultimate destinations of a surgeon or a physician? What do you think? To say something, today I am going to present only the court verdict, and there is only few impression of mine. The situation is, you have already seen in the newspapers, in the media. But what the doctor used to say, we have spent crores for our study, and the court is asking us, we are spending crore, and the court is asking us to pay 10 crores. Is it justifiable? People started to say like that. But will this make us the way for the solution? There are lots of things. There is dilemma. When we talk about the medical ethics, we have to tell everything to the patient. When the patient, you never know how the patient is going to respond to you. Medical negligence or the medical malpractice, it is well written in the Nepal Medical Council or in the Consumer Act or something like that. There are lots of laws, governing laws. We have lots of governing laws. I'm not going to tell all the details. The governing laws, it has been more than 60 years to even present Consumer Act. I will tell about all these things if you are interested. When 2017 it is Bikram Sambat, if something mishappens, you have the penalty of 50,000 or 5 years imprisonment. Now, you demanded the new law, it is unlimited compensation now. When we demand something, we have to know the consequences of the law. If you don't understand the consequences, if you don't think about the consequences, then lots of problems may arise. There are also opportunities due to law. I don't only blame to the laws and our demands. There are also opportunities. Opportunities to improve ourselves. Not the protesting the laws, not protesting the verdict, but to improve our. Nepal Medical Council also says something about the medical negligence and the malpractice. It is very vague. I'm not going to tell everything on the how it is. Everyone we know the things. This is the news. The court has given the verdict to impose the 2.5 crore as a fine to the doctor. And there was a lot of chaos in the medical physicians, in the medical field. Factors determining the compensation, it matters who you treat. If you treat a billionaire, then the compensation may be billions. If you treat a simple person, the compensation may be in thousands. It doesn't matter about the complications. It matters on the persons to whom you treat. Socio-economic background of the injured party matters for the compensation. I'm going to present some scenario. Many of us has already been suffered from this case. It is a scenario of Beer Hospital, long back. The cholecystectomy was done. Cholecystectomy was done, and surgery was successful. But the patient suffered from the abdominal pain. It was not recovered. According to the patient, it is on the court's description. Patient came frequently to the hospital, but doctor failed to relieve the patient. And she went somewhere in the India and got treated. When the case was filed, doctor said, the time has already gone. हिजो पनि प्रेजेन्टेसनमा सुनेको थिएँ, हद म्याद. When the patient is suffering, there is no time limit. Patient is still in the treatment process. So anytime the patient party can sue you. It was gone to the district hospital, then the panel court, then the Supreme Court. Where we miss in this case? There was a stone in the common bile duct, and we missed. But the surgeons never told that the radiologist did not detect the stone, or sometimes it may happen. But we were focused on the hard math. So we should learn all these things. We should discuss in our forum about the cases, court cases also. We have started to discuss all these medical legal cases in the. Now, I'm going to tell about something, Consumer Act or the doctor's duty. The court doesn't say you have done the good things or right things. It asks for you whether you fulfill your duty, responsibility or not. What does that mean? This is the another case. I'm telling about the another case. Someone came for the medical certificate. The hospital was very well planned. It took a declaration from the patient, I have no any medical issues, and the hospital asked some investigations. Ultimately, it provided he is fit for any physical work. And he went abroad to work, but at the same time, the patient got the asthma. And he was deported back. And he gave, doctor was at fault because he did not told me I will have asthma. And the court decided to give the compensation to the person. The doctor said, I have done everything. Patient did not tell about the past history. It may happen to anyone else. But court said no. And there was other expert's opinion. The expert says, yes, there was some environmental changes and patient got the asthma. And the court said, when you are the expert, why you didn't tell the patient that changing on the environment, you will get the expert. So you will be fined. And court decided to fine the certifying physician. Failed to inform about the future. You failed to inform about the future. Who can? We are not the astronomer. But we have to tell all these things on a big forum. The court says it is a experimental or scientific science, but you have to satisfy the patient. If you fail to satisfy, then you will be fined. There are lots of, the time is very short, so there are lots of cases. I'm going to tell another case in a short. It is a case in the Prasutigriha or tertiary care center. There was a vacuum delivery, and the baby was delivered with some defect. There was a crowd move, and the doctor said, I will give you some compensation. The case should be dismissed. But the patient party went to the court and filed. All the experts says it is the right procedure, but the doctor has already confessed that he will pay something. Then the court said, there is something wrong, so he should be fined. So there was a fine. I will not tell all the details of these things. Fail to listen and to confess. In a pediatric hospital, someone gave the ceftriaxone in double dose, and there was some complications. Patient says they got some deformities. And the court fined to the hospital and the doctor. I will move little. In an accident was happened, there was on call. On call was not present on the hospital. On duty was present, but the hospital ticket was on the name of the consultant. So he was fined.
Time is over.
Okay, I will not present on the case 5. There are lots of cases. I was only planned to present the 5 cases. There are some also interesting cases in India, but there is judicial something, it was rational verdict was there. But the things are coming up in the India also. The cases are more in Nepal than in India, if you compare the population and all these things, but it is rising. If you fail to agree, or duty or responsibility, or maintaining the standard of care, then you can file. The court says, you cannot say there was lots of people. You cannot say, I do not have the time. You cannot say anything. If you have agreed to do the duty, then you have to fulfill the standard of care. If you don't maintain the standard of care and quality of care, anytime you can be fined. There is no excuse for you. No. You have to maintain your standard. You have to maintain your quality. I couldn't show you the picture, there is two paths. One is you can protest. The law should be changed, which you cannot do. But always you are demanding to change the law, which is mostly difficult. I don't want to say the impossible, very difficult. Other thing, it is
Thank you,
possible,
Dr. Dal.
but you have to
We had
change the practice.
we had
Thank you.
discussed this matter
Thank you.
yesterday in B hospital.
It was
Very
incomplete, sir.
elaborate one. Thank you.
The next topic will be the team building in surgery. Welcome, President Assistant Romeo Kansaga.
उसकै ल्यापटपबाट गर्ने यता त कपी गरेर छ हम
दस मिनटमा कहाँ हुन्छ यो त हुँदैन 15 मिनट
यो
प्रेजेन्टेसन
हजुरकै हो
होइन
यो यसकै टाइम हो यस
So good morning, everybody. And on behalf of the Society of the Surgeons of Nepal, I would like to welcome you all for the 16th International Conference of the Society of Surgeons of Nepal. And today I'll be talking about something which will be relevant to all of us, and especially for our juniors. So team building in surgery. So I've been working in a surgical team for the last 20 years, and we're having around 8 to 10 members now working together in different fields of surgery. So I think it is one of the important aspects in surgery. A slide. The next slide is change one. Okay, so what is a surgical team? The surgical team is a multidisciplinary group of people who work together to perform surgery. It may, with each member having a specific role to ensure patient safety and to achieve the best possible outcome. So, in global perspective, WHO says that teamwork is the key to safety. And in countries like ours, which is low and middle income countries, we face resource challenges and we face a lot of challenges, even in a team. In Nepal, we have different types of practice. One is a government practice, another is practice in medical colleges, another is private practice. So there are different types of teams in all of these three different institutions. So before we used to hear a little story about the Aesop's fable, that a single stick breaks down very easily, and if it's a bunch of sticks, if it's a team, it'll be very difficult to break down. So why we need a surgical teamwork? So now the trends are changing, the healthcare trends are changing, and we have to change accordingly. And now surgery is a multidisciplinary approach, and we have to enhance patient safety in surgical care. And there's some economic burden. And now the patient's expectation, it's not like whatever you do, the patient will accept. Their expectations are rising. And also about the doctors, we need lifestyle change and work-life balance. So these days, as we just heard from Dr. Piyush, that adverse events are not permissible. We are subject to a lot of violence as well as court cases. And if you stay just like that, you'll not be able to improve. So you need to upgrade ourselves. Before there was open surgery, now laparoscopic, now we have to upgrade ourselves into robotic surgery. We have to keep on changing. So the team helps us do that. So what will the team do? It will increase your efficiency. You can share knowledge among your team. And the stress is decreased when you have a team. That is if you have a good team. And we have a better workforce. You will have more free time. You'll improve in your academics. And there'll be more learning opportunities for your juniors and as for you as well. And since there's a team and many of them can attend to the patients, there'll be increased patient satisfaction. So there'll be less medical legal aspects. And monetary management is also important, that if you are sharing your money amongst your team, you'll have to pay less tax. So that is also one of the important. It's better to give it to a young surgeon than to give it to the government, I suppose. So for the young surgeons, what is there? There's been more job opportunities. They don't get a job. If they go alone and start practicing, it's very difficult for them to rise up. But if you enroll them into a team, so it will be better for them to get a job. And if you are in a team, you can do surgery in multiple locations, and you can do surgery of your choice. You don't have to be doing, if you are doing a GI surgery, appendectomies will be done by your juniors, and you can do Whipples and liver resections as you want. So that is also an opportunity. So what is the disadvantage? So you have sometimes reduced autonomy and ability to navigate disagreements. Some people may disagree with you. You cannot do whatever you want. And you may have less personal care for yourself. So practicing alone. So personal autonomy and decision making is yours. So it's your choice. Whatever you want to do, you can do that. Maybe you'll have some higher income, or maybe not. So initially, if you are building a hospital, there'll be more financial risk and higher startup. And you can get a direct reward. But the disadvantage, you'll be isolated. And there'll be difficulty in managing your time. And also some tax issues. So surgeon, as we all know, is the captain of the team. He's the leader most of the time. So most of the surgeons, what we think about surgeons, they are more decisive, they are well organized, they are practical, and they are hardworking. But it's always not so. Some of the surgeons, they are very arrogant, they are egoistic, they are greedy. So it's not always that what we think is always like that. So who are in your team? So there may be surgical colleagues from different departments, and there may be anesthetists, nursing, surgical assistants, and other management staff. So today we'll be talking more about our surgical colleagues. So nowadays it's a multidisciplinary approach. So even if you go into GI surgery, you do a MCH, there are a lot of people who will be doing only hepatobiliary, colorectal, upper GI. One of them may be just interested in only hernia surgery. Some may be interested in ERCPs and minimally invasive surgeries. But even now, it's becoming more organ-specific and even procedure-specific. So with a team, you can have someone doing only hernias, laparoscopic hernias, or other one doing only just inflammatory bowel disease, or some doing only cancer work. So that would be easier when you divide it in a team. It's always very difficult to choose the right person. If you have a wrong person in the team, one bad apple will spoil the whole lot. So it's very much necessary when you choose the team member, you choose the right person. So first thing I consider is the attitude, not the skill and the knowledge. I think they should have a very good attitude towards the patient. They should be able to work together as a team. And also when most of the juniors, they come, they learn, and sometimes they form their own teams. So you have to let them go, and you have to let them go cordially with a mutual understanding. So nowadays, a lot of corporate hospitals are there, and they'll hire you and they'll fire you. So, but with a team, you have better strength. It's difficult for you to fire the whole team. And when you are there, you are doing your OR, somebody is looking after the OPD, somebody is looking after the ward. So as a team that you are coordinated. And even if you are not there, the show will go on. So maybe you are sick for a few days, if some other person is taking care of it. And even if you are not there for the ORs, sometimes some other people are taking. And training opportunities are more. So you want to go for training for two months, you can go. The training team will take over for that time. And even for me, I'm the president of the Society of Surgeons of Nepal. I have been out for a lot of these days, but my team is taking care of my patients. So that is important. So it should be mutually beneficial for the juniors, for all the members of the team. And there's more patient counseling. You can't be, if you are working in 2-3 hospitals, you can't be present there for the patients every time. So the patient is demanding these days. And then what? So for the patient, they want to see you every time they call you. So patient counseling is more. Yet some of your team members will be counseling the patient. And you'll have better surgical results. You have lots of hands, better people. You'll be training yourself with a senior surgeon who knows the know-how better, so you'll have better surgical outcomes. And just we talked about medical legal aspects. Documentation is very much important. So with the team, you'll have better documentation and less medical legal problems. So another important thing is family time. What do we surgeons do? We work, work, work. We don't consider about ourselves. So we'll have more time with the family. Somebody will take care of the cases when we are gone with our family. So we need to spend the money that we earn. It's not we don't take money down to our graves. So sometime we need to take a vacation with our family and we need to go abroad. So that is better with the team spirit. And some of the people want to go very fast. And that is also sometimes. We have no rest and lots of stress. So with the team, as a leader, you have to be inspirational to your team. You have to create opportunities for them. You have to give them a job. And when you have newer members in your team, they have newer ideas. Your ideas might be stagnant, but they'll come up with newer ideas and you'll develop yourself with newer innovations. And a new mind is always better, I suppose. And they want to do, when you are just finishing your MS or MCH, after that you want to do something more. And once you are already after 15, 20 years, you stop doing something new. So the newer minds will give you, and they'll have a learning attitude all the time. And sometimes you need time for your personal hobbies. Maybe you want to play the guitar, or you want to go for skiing, or you want to go something. You may not have that time. So what surgeons do? Only work, work, work. There's almost no social life in some of the senior surgeons, or some even for the junior surgeons. So they want to earn, and that's all. So you'll have some time for your personal hobbies. So there's a freaking 39-year-old doctor dies of heart attack. Lots of surgeons do die of a lot of stress. So there's no time, we have no time fixed to eat. We sleep whenever we want. We wake up, any calls, we go. And there's lots of studies saying that surgeons die faster. We don't exercise. We don't care about ourselves. So as one Dalai Lama said, we work so hard to earn money, spoiling our health, but later spend all the money trying to stay healthy. So that's one saying. So we have to think about that. And as a team member, we can avoid burnout. So as a team and as a mentor, we have to plan and when you have a good assistant, when you have a good nurse, and when you have a good team member who can rescue you also sometimes, so then the surgery, the stress becomes less, and you have less burnout. So the core components of high-functioning surgical team is leadership, situational awareness, clear roles, team orientation, adaptability, backup behavior, and all these. So we'll be talking about in each. So leadership. Main thing is the leadership. When you are a team leader, you have to take care of your team as well. You have to think about their needs. You have to think about their different aspects. So you have to coordinate among them. You should assign them tasks. You have to give them what they want. And you should also give them psychological support. And if there is any complication, you have to support them at those times. And there should be a very good communication amongst the team members. So there should be situational awareness. Team members should maintain a shared understanding of the patient's condition, surgical progress, and changes in the environment. The mutual monitoring allows the rapid recognition and response to the unexpected challenges and emergencies in the team. So you should specify clear roles, what your team member is going to do. That should be started from the beginning. Later on, once they are spoiled, it's very difficult to change their habits. So when they join you, you have to clearly state that you will get what will be your role. So, and sometimes you need to adapt. Surgical teams must be flexible. Sometimes you may give them a different role, and you may have a different strategy. And so this is also very important. So you need to have a backup behavior. Team members proactively should support each other. They should offer assistance not only during surgery, but in other aspects of life. When there is a big problem, medical legal issues also, you'll have to support themselves. You got it 10 minutes, okay? 15 minutes, sir? Okay. So Dr. Sudhir was telling, I'm only getting 10 minutes. So if there is 70% of the complications come due to communication failures. So the team must collaborate so they are, and have good communication skills. So the ongoing team training, you should always keep on training your team. They should always have training opportunities for yourself as well as for their team members. It could be technical or non-technical skills. And there should be shared goals. A unified focus on patient safety and surgical quality binds the team. All members hold themselves. So there's a multidisciplinary collaboration. There should be collaboration with the anesthetists, nurses, and other team members as well. And we should take the guidelines. So for the junior colleagues, becoming a team, it's an opportunity for you to work with someone who is well known. You should go into a good team, then you will have a life set. So there will be adequate exposure. You should give them adequate exposure. Maybe just a person who's done his MS, he will need to just go in for an appendectomy or some basic laparoscopic surgeries like cholecystectomy. And for seniors, maybe they'll have to have very big exposures. You have to give them good environment to train and to work. And you'll have to also give them training opportunities. You have to send them for higher education. You have to give them chances. You have to give them chances to operate. It's not only the monetary matter. It's also the work environment and what you give them. And also, according to their work, their pay scale also should be high. And also, I told you that sometimes you have to let go of the people. If they want to go somewhere else, you have to let go cordially. So as a team leader, you have to lead with humility, and which will empower the team. So this is our team, and it's already grown from here. So thank you very much, my team members and all of the delegates who have come here all the way from different places in the world as well as from different places of Nepal. Thank you very much. Okay, if there are no questions.
Thank you, Dr. Rome, for your wonderful presentations. So next we move on with a presentation by Dr. Deb Goyal, KATHMANDU Healthcare. Good morning, everybody. Thank you, Sunil and Romeo, for having me here once again. This is my 27th visit to Nepal for academic reasons. And it all started with my honeymoon in 1994. And then Professor M.L. Shrestha invited me first time. And since then, no, I'm not, because it's my wife thinks that I have another family here in Kathmandu. I visit so often, and Sunil has to click a photograph every time and send that I am on a podium. So this is a very unusual phrase, Quo Vadis. It's a Latin phrase which comes from the Christianity literature when Peter was fleeing Rome, when persecution was becoming very, very common. And on the way back, on the way from Rome, he met Jesus. Jesus was on his way back to the Rome. And that's when Peter asked him, Quo Vadis, means where are you going? And Jesus replied, I'm going back to Rome to be persecuted once again. So that's how all it started. So let's have a look at where our healthcare is going, especially in the developing worlds. And I have some disclosures that these are entirely my views. I'm not on any high moral ground. I may be guilty of some of the things that I shall be mentioning in my talk. These are some of the novels and the books which I read and got inspired from. So let's look at, we always say the government has a major role to play. It's very important, and ideally health for all is something which a state should look after, and that's why we pay taxes. But you will be surprised, all over the world, the health which is controlled by the state is in misery, and developing world obviously is not an exception. If you look at the budget allocation all around the developing world and in developed world, they differ so much. In India, it's only 1.5 to 2%. Nepal is better than India, 4.9%. I was looking at the Pakistan, which was less than 1%. But if you look at China, it's the largest, around 8.3%. So this is where we stand as far as budget is concerned. If we concentrate and focus on primary healthcare, then I think things can change. But unfortunately, most of the developing world do not have resources to focus on primary healthcare. They straight away go for tertiary healthcare. If we start teaching the values of health in the school, I think we'll solve a lot of problems. There's a lot of discrepancy and mismatch between the rural and the urban infrastructure. Whenever the figures come in the papers and they say the need of doctors per population is so much, and what they talk about is the whole country, but unfortunately everybody wants to come to the urban cities and metro cities. This is a big sore point. There are no clear-cut guidelines in developing world. Still, we depend upon live-related donors rather than deceased donors because there are a lot of problems and a lot of regulations which are not in place. If you go to the China, you will see that there are reports of prisoners being killed to get the donation. And obviously, this cannot happen in any democracy. The government should start campaigns at a large level, like in our country, we have started for Beti Bachao, Beti Padhao. Something like that should be started for organ donation. In my opinion, donations should be mandatory. There should be religious counseling. There should be job incentivization rather than giving monetary incentivization. And there should be reservation in education for the children, for people who are donating their organs. Day before yesterday, this was a very interesting article in Times of India in our country, which says that people are orchestrating road traffic accident to get the organs, because you are on a donor list. Your relative or the near dear ones is on the donation list, and there is a scarcity of the donor, and then you orchestrate road traffic accidents to get the donor. So Supreme Court has directed the government to evolve a model transport norms. This is from yesterday's newspaper. There's a big mafia going on in the pharma industry and the trials, generalists, and I think it is something which we need to understand before we interpret any literature, before we prescribe any medication. FDA, you look at this, people sitting on the panel, they vote, but what are they doing behind the chair? So I think this is a big cartelization there. And if you talk about the literature, we always teach our younger colleagues, in God we trust, all others must bring data. But if you look at these three names who have been the chiefs of the reputed journals, they are on record. The medical profession is being bought by the pharma industry. Half of the scientific literature may simply be untrue. So it is no longer possible to believe in published clinical research. And I take no pleasure in this conclusion, which I reached over my 2 decades as an editor. This was said by Marcia Angel, who is the NEGM chief editor. So again, I'm not saying, or I'm not proposing that all literature is corrupt or we should not believe literature. What I'm saying, we should apply our mind. We should not just blindly believe the literature. Obviously, all these journals have their income from reprints, trials. It is actually, if you look at these figures, up to 50% of their income comes from the reprints. So any pharma industry can say to a journal that I am going to buy 5,000 copies of your journal if you print this trial. And I mean, this is what is an open truth to everybody. How do we interpret literature? You read, what normally most of the people do is read the conclusion of a printed article and make an opinion. If you really torture the data long enough, it will confess. And you need to reduce the sound in your mind. You need to reduce the noise in the literature to understand the literature, what the author is actually saying. I'll give you a small example of a very famous trial, like a Lotus trial, which was a famous trial where they compared the PPI with the fundoplication. And they said that at 5 years, most patients achieved the same result. So basically what they're saying, you do not need to do a fundoplication. You can give PPIs to all these patients. Now, if you look at the limitations of Lotus trial, the trial was fully funded and sponsored by the maker of PPI. Not only it was funded, they designed the trial, they collected the data, they analyzed the data, and they interpreted the data, and they helped the authors to publish that result. So how do we believe in that literature? And the population which they chose was people with mild esophagitis, which are not the candidate for surgery anyway. So again, you need to interpret with your open eyes. Spurious medication today is a real problem in developing world, and there's a lot of media attention we have seen. This is a parallel industry. Similarly, unfortunately, because of the lack of the good medical education, there's a mushrooming of private medical colleges without any control on their quality, without any unregulated and non-standardization. You will be surprised to know there are certain medical colleges where the faculty is not there, it's only online teaching, and similar group of people are teaching probably in 20 medical colleges. So this is something which we need to look at. Most often, doctors are the ones who are blamed for any corruption in the medical field. But believe me, they are the smallest fish in the sea. There are bigger fishes to fry. What should be taught in the medical education? Compassion, as Sunil was saying. Relevant aspects of the medicine, how to deal with the patients, business of the medicine. There is no harm, there is no shame. We are often, feel guilty if we make money. No, if we are making money ethically, there is nothing to be feel ashamed of. We should be told how can we control the business of medicine, medical legal aspects and ethics. These are some of the important points which we need to teach in the medical education. Surgery, everybody learns. Someone learns in early, somebody learns late, but that's not something which is today. Art of touch is disappearing. It will be astonishing if you see some of the clinicians that they will consult a patient, they will see all the reports, but they will not touch the patient. That is something which we need to continue to do, and we cannot let it be lost. Alternative medicine, as has been told in various lectures, that we have such a rich legacy, and I think we need to continue with that. I'm not saying that we should be aware, but we must respect alternative medicine. We should understand the limitations of each field and choose best for our patient. There is no harm in telling your patient, I do that quite often, that this particular disease will, in my field, will require surgical intervention, but maybe you can try homeopath, maybe you can try Ayurvedic if you can get some benefit out of it. A relationship between doctor and patient was like a god and devotee, which has changed to litigant and defendant today in modern world. And it is, it's just a representation of how our society is deteriorated. There is a trust deficit between doctor and patient. Any patient coming to you and handing over his life to you, handing over his body to you and saying that I am under anesthesia and you do whatever you want to do with my body is a great responsibility for a surgeon, and it's not a small task. We should respect that. Consumer Protection Act obviously has changed a lot of things. Can a consumer be a beneficiary of an altruistic service? That's the question which we need to ask. Our associations and councils have unfortunately failed us. They lack authority. They have failed to enforce code of conduct. There is no fear. We do not self-regulate media. People and state will do it. So I think it's high time that we do it on our own. Wrong is wrong, even if everyone is doing it, and right is right, even if only you are doing it. This is the principle we should follow. Unfortunately, cut practice is something which is very, very rampant in developing worlds. There are unindicated surgeries being done in a lot of places. These are some of the media reports of hysterectomy rackets where young women were, subjected to hysterectomies when they were not needing it. Phantom surgery, again, is a reality all over the world. We know this famous case of Dr. Panos from New York. These are some of the advertisements we found in rural area. If you understand Hindi, you can read it. They're saying that we can put life back into a patient who is already dead. That's the kind of, they really tarnish our image. And this is a certificate of a guarantee card given by one of the surgeons after a hydrocele surgery. And he says that this hydrocele will never come back, and if it comes back again, I will operate free of cost. Challenge for the younger surgeons: how do I seek patients? I'm not allowed by the law to advertise. And it's a really challenging thing for the young surgeons in a competitive world, that how does he do that? How does he attend conference? He's not supposed to take any benefit from the pharma company. So these are some of the challenges. Media has not obviously helped us. They are in the habit of sensationalizing news. They do not project good work done by the government, hospitals, and the doctors. They always criticize. Social media, again, is an uncontrolled media. You can write anything. Corporate hospitals have revolutionized healthcare. They have brought cutting-edge technology to the patients of our society, world-class infrastructure, but they are criticized for obviously increased cost. Profiteering is something which should be avoided. Immoral versus legal. A syringe which they procure for 35 paisa is sold for 15 rupees. That's just an example. So organizations should be built to last. They should not be built for short-term goals based on profitability only. Core values and core ideologies should be, the patient should be first, and value-based incentivization, not volume-based reward, should be given to the patient. Healing as an art, medicine is a profession, but healthcare is a business, and all business need not be unethical. Dr. G.V. Rao is going to talk about technology, so I will cut this. Insurance, again, there is a cartelization, lack of transparency. So to conclude, my friends, I would say we are in a noble profession. We are constantly under scrutiny from society, media, and government. We are seeing deterioration in ethical practice in healthcare, which is in correlation with what is happening in the society at large. We doctors need to be aware of wide spectrum corruption in pharma and published literature. Interpretation of data has to be accordingly. Government needs to increase healthcare budget so healthcare infrastructure can be rampant to rapidly both urban and rural areas. Organ donation should be made mandatory, and well-thought incentivization should be given. Corporate hospitals should take into cognizance of mismatch between procurement cost and MRPs. Health should be subsidized for poor people with the help of universal insurance. Though healthcare industry has gone too far ahead in ignoring human values, there is always a way to return. The question is, are we ready? Onus is on us to strengthen this very trust by acting ethically, transparently, compassionately, and at the same time, safeguarding yourself by documenting what you are doing. There is no room for complacency. History will not forgive us. We cannot afford the luxury of doing nothing when very foundation of healthcare is being endangered. Not every doctor is a predator, and not every patient is a litigant. There are more good doctors than bad doctors. There are more good patients than bad patients. And this is a famous Invictus poem. And I'll just say, I am the master of my fate. I am the captain of my soul. I have no doubt in my mind if I want to be reborn as a surgeon. Thank you very much.
Thank you, sir, for your wonderful presentation. I'd like to invite Tim Mitchell, training the surgeons of the future.
Duplicate ma गर्नु पर्छ यो होइन डुप्लिकेट गर्नु पर्यो होइन होइन यो उसमा मात्रै गयो कि एउटामा मात्रै आयो भइदिनु त्यस्तै एकचोटि हेर्नु त्यसो एकचोटि हेर्नु तपाईँले
Good. Well, good morning, everybody. And can I say, first of all, what a great pleasure it is to be here in Nepal for my first visit. And thank you to all of you for the great welcome that myself and my wife, Claire, have received. I'd like to thank very much Dr. Kansakar and the organizing committee for inviting me. And congratulations on a fantastic conference. Some very interesting sessions this morning, and I shall touch on some of the issues that we've heard about already. We heard about mentorship. I'm going to talk about training and the importance of mentorship in that. And it was wonderful last night to see Dr. Sharma with his own mentor, Professor Ui, and then one of his trainees, so 3 generations together. And I think that really speaks to how important mentorship and the team working that we heard about from Dr. Kansakar. He talked about the attitude of surgeons. We're not a mountainous country in the United Kingdom, but we do have some surgeons with attitude sickness. And I think we also heard earlier about learning from the past and learning from mistakes. So I'm going to talk about training the surgeons of the future. This is our wonderful building in central London, which you're all very welcome to come and visit if you have the opportunity to come to the UK. We like to date our history back to 1540. If you're from the United States, that's a very long time ago. If you're from this part of the world, it's very recent. I do understand that, but that's where we date our history back to. So what do I mean by surgical training? We've covered some of these issues already this morning. We think about the basic knowledge that's required, basic science, the understanding of the principles that underpin medicine and surgery, and also the clinical aspects of surgery. In addition to that, the skills, and we tend to focus very much on the operative skills when we think about surgical training, but it's already been mentioned this morning, the non-technical skills are really important. And we heard earlier about the importance of empathy and how we deal with patients and how we work together in surgical teams. And in addition to that, we also have to have a good clinical judgment. So it's not enough to have the understanding of the basic science, of the clinical skills, and know how to operate. It's about how to apply those principles, when to operate, and of course, many times when not to operate. And also those professional behaviors that underpin how we function in a clinical environment, how we work together in teams, and how we deport ourselves. We heard about those earlier. Back in 2018, the Royal College of Surgeons of England produced this document, The Future of Surgery. And this was looking into the future as to what surgery might look like 5, 10, 20 years ahead. And we're starting to see some of these come to fruition, particularly in the United Kingdom, but other countries in the world will be on a different part of their journey. But this is what the future will look like. And although some of these things may not be widely available here in Nepal at the moment, they will be as time goes by. And we're starting to see the use of genomics so that we're able to personalize care for individual patients, particularly in the field of cancer, very well developed now in breast cancer, an understanding of the genetic basis of disease and how that affects how the disease develops and how it can be treated. The development of robotics, which of course is of great interest to surgeons. We know that surgeons love their toys, and having a new technique is often embraced by people, but it's really important that we use robots appropriately. Well established in the UK now for urology, particularly for prostate and kidney surgery, starting to be used increasingly for colorectal surgery. But it's really important as a surgical community that we develop the evidence base that supports the use of these techniques, and we don't blindly use them in every circumstance. We've seen that happen many times in the past. I remember when lasers were introduced, everybody wanted to find a use for the laser in their particular surgical field. I'm an ENT, ear, nose and throat surgeon by background. Even people were using lasers to take out people's tonsils, which by the way is a really bad idea. Artificial intelligence, we'll hear a little bit more about that later this morning. I've heard a lot of talks about artificial intelligence. I think I've heard more talks about artificial intelligence than I've seen people who know what they're talking about when it comes to it. But it clearly is going to have a dramatic impact upon our personal and professional lives in ways that we probably can't easily predict. Some will be good, some may not be so good. Time will tell. The other elements there, 3D printing is being used in some fields, particularly reconstructive work. My colleagues who do maxillofacial surgery, using it to determine the exact nature of their surgery when they're doing resections in the face and reconstructing the facial skeleton. And we've heard about teamwork. And remarkably enough, this report even predicted there would be a global pandemic. And of course, that had an incredible impact upon the delivery of healthcare around the world and has probably slowed down the introduction and adoption of some of these new technologies. But what is clear that this will also have a huge impact upon surgical training, because the trainees of the future and current trainees will need to be able to embrace these new technologies, not just established surgeons. And we have a particular difficulty in the UK with access to training for robotic-assisted surgery, partly because it's controlled very much by the robot manufacturers, but also because established surgeons are wanting to learn the new techniques, and that's making it more difficult for those in training who will be the robotic surgeons of the future to gain those skills. But it also means that the surgeons of the future will need to understand how these technologies work, and they may not know them in great detail, but they may need to understand how to interact with the people who do understand them in order to make best use of them. And so it's important, therefore, that we encourage the trainees of the future not only to be well trained in surgical techniques, but how to interact with other disciplines. But throughout all that, we must also make sure that the empathy and the ethical approach to dealing with patients is not forgotten, that we are not mere technicians, and the human side of surgery and medicine will be ever more important. But there will also be other techniques that come in, I'll talk about this in a moment, that will enhance training. So the use of augmented reality and virtual reality will also change the way that we're able to train the surgeons in the future. And it may be, and this was touched on earlier, that we need to think about the selection process of the people that we bring into medicine, who we train in surgery, because some of the requirements that they will need for the future and that adaptability may not be the ones that we have selected for in the past. A few years after the Future of Surgery report, this further report came out, and I'm very proud to say that this was entirely conducted by surgical trainees in the United Kingdom. The Future of Surgery Technology Enhanced Surgical Training report. And it really looked at how technology can be used in order to improve surgical training for the future. So its recommendations were, first of all, that the workforce would need to be upskilled in these techniques, and that surgical innovation would be absolutely crucial. But the other important aspect, in just the same way that we need to evaluate new surgical techniques, we should evaluate new teaching technology. So whether it be augmented reality or virtual reality, we shouldn't just take on these things as gimmicks because they seem attractive. We should actually look for that evidence base that they do indeed improve learning. But throughout all this, we need to make sure we have clinical champions who are the ones who are driving the innovation and driving the changes in training. This is just an example of urological cases in the UK, and as I've said, there's been a dramatic increase in the use of robotic-assisted surgery. I know you're just starting on your robotic surgical journey here in Nepal, but you will follow the same curve. You'll just be a little bit further shifted to the right in terms of time. And it's really important, as I've said, that we make sure that everybody has appropriate access to the right training and that these new technologies are introduced appropriately. At the Royal College of Surgeons, we've produced this publication, which is available freely through our website, as to how robotic-assisted surgery should be introduced in a way that's appropriate and delivers the right sort of care for patients. And the relationship between clinicians and the manufacturers, it's just been touched on in relation to Big Pharma, is really important. I'm a cochlear implant surgeon, and I've therefore, over the last 20 or 30 years, interacted with the manufacturers who produce cochlear implants. I believe that they act in an ethical way, but we should not forget that fundamentally they are businesses looking to make a profit, and therefore the drivers are slightly different on both sides. But that relationship and interaction between surgeons and manufacturers and industry is really important Industry needs surgeons because they need access to surgical patients in order to do the trials that will confirm that their products are of benefit. And equally, surgeons need the manufacturers to help them deliver the care that they are wanting to provide. And so they have an understanding of how the technology can be best applied. So here's an example of a training facility in London, which is set up to allow surgical trainees to have the ability in a simulated environment to make use of, in this case, a Da Vinci robot, so that they have familiarity with the equipment before they're using it in the operating theatre. And that's really important. And in my view, in the United Kingdom at the moment, we do not set aside enough time either for the trainees or for the trainers to have this type of training away from the workplace in order to be best placed to deliver care appropriately. I've touched already on the non-technical skills, and we heard about that in an earlier talk. This is a really important aspect of the delivery of surgical care, as I've touched on. It's increasingly recognized. There are now many courses available that talk about non-technical skills and human factors, and we shouldn't overlook those. So in order to deliver good surgical care, we need a mixture of all these elements. We need to have the cognitive skills, we need to have the basic knowledge of our subject, but the other aspects, interpersonal skills, the personal skills and technical skills, are also incredibly important. This is a photograph of the training facility in our college in London. It's busy pretty much 6 or 7 days a week with training courses going on. And here we see one of the most common courses that's conducted for our surgical trainees early in their surgical careers, our basic surgical skills course. These sort of courses are invaluable to give them the building blocks for their surgical career. And we've just opened this immersive space. This is a space in which we can simulate a range of environments, either in hospital or out of hospital, used for surgical trainees, but also for other disciplines. It can be used for emergency workers, ambulance teams, firefighters, but also allows team working, and we can mock up an operating theatre and bring in a whole surgical team to make sure that they're working together collaboratively for the best interest of the patient. So we see this photograph. This is from some years back now, 10 years back. The idea that we might have these immersive patient simulators, something probably from science fiction we'd have thought then, and probably still actually from science fiction. We haven't quite got to this stage yet. But I have no doubt that in the future we will see increasingly technology being used not only in surgical practice, but in simulation in order to train the surgeons of the future. So in summary, surgical training involves these 4 elements as I've touched on. There's the need for the basic knowledge, the skills, both technical and non-technical, the judgment to apply those knowledge and skills, and increasingly important, those professional behaviors, interaction with colleagues and in teams. And we will see all of these changing in the future, but as has been stressed already, the most important thing is that we maintain that empathy and ethical approach to all that we do. Thank you for your attention, and delighted to be here. Thank you.
Thank you for a wonderful presentation, Tim Mitchell. Now I'd like to invite Professor KD Joshi, Establishing Plastic Surgery in Nepal, My Journey. Sir.
2 announcements before we go on to the next talk. Tea is being served. If anybody wants to have tea, there's no official tea break. You can go and get your tea and come back to the hall. Likewise, lunch, there's no official lunch break, but it will be between 12:30 and 2, so get your lunch in between. Now, this is part of our new talk that we've started, and this is the second time we're doing it. Because I'm the scientific chair, I thought I need to mention this. We are honoring the senior surgeons of Nepal, especially those who were torchbearers and people who actually established certain specialities in the field of surgery in Nepal. This is a special lecture dedicated to Professor KD Joshi, who's a very senior teacher of ours, and he has been very instrumental in establishing the burns and the plastic unit in Nepal, and we consider him the father of plastic surgery. I request you, sir, to deliver your special lecture on the history of plastic surgery in Nepal. Thank you very much.
So यो एन्ड सो गर्ने भयो हैन मलाई पनि
Good morning. My topic is establishing plastic surgery in Nepal. We have a picture of Susuta, and someone earlier talked a lot about him, but he started in his own way, small way, plastic surgery. He devised the forehead flap or nose construction, and he did a variety of surgery. As you can see, the number of instruments that he has made goes into more than hundreds. And I think the number of 100 procedures less. He did more than 300 procedures. And he wrote this book, Susta Samhita, where if you know Sanskrit, you can go and read it. He started the surgery, and two of his famous quotes was, "A bungling surgeon is a public danger, and theory without practice is like a one-winged bird that cannot fly." And beauty lies in the eyes of the beholder, and the famous father of surgery, Hippocrates, lived in the 5th century BC, and he was exposed to a lot of wars, battle around Greece, and he emphasized clean the wound, irrigate the wound very thoroughly, and that's one of the basic tenets of his surgical treating with his many, many disciples that he had. My journey started after my MBBS. I did my MS General Surgery in All Institute under Professor Azam Prakash. And there was no plastic surgery in those days in All Institute. And Professor I.K. Dhawan used to do interest bits of reconstruction. And one of the reconstructions I remember in our monthly meeting was reconstruction of the jaw. And he brought two pedicle flaps from the abdomen and put it in that area. And when he presented in the monthly meeting before a big hall, people laughed because it looked very grotesque. But then we have come very far after those. And after I did my MS, I went to Southern Hospital also for a short period. And we had Dr. Gupta, who ran a very big department of burns plastic in Southern Hospital. And then afterwards, I went to Maulana Azad Medical College, work as a registrar. And Dr. G.D. Goyal was my consultant, and he was a general surgeon, a very good general surgeon. And over 6 months, I worked in the plastic surgery department in Maulana Azad. And this is also a big hospital in Delhi. And it has more than 2,000 beds. All Institute has more than 2,000 beds. Southern has more than 1,500 beds. But then after this short exposure in Maulana Azad, my interest in plastic surgery revived. And this ethics in surgery do no harm. Primum non nocere means do no harm when you are doing surgery. And early surgery in India, Ayurveda, you had Charak and then Susruta, they were disciples of Dhanvantari. And much surgery started. And when I came back to Nepal, I had to work 10 years outside Kathmandu. You could not come to Kathmandu Valley without working at least 10 years. My colleagues and seniors, they all worked outside Kathmandu Valley before they were eligible to come and work in Veer Hospital. Veer Hospital happened to be the only tertiary hospital in those days. And Dr. Gongal was the health department, and he planned to develop subspecialty. And few of us went out of the country to develop, learn, observe subspecialties. And in Kanti Hospital, we had Keshav Bahadur Rajbandari and Nan Thapa, who were treating children. Kanti, in this slide, I only want to point out one thing, that as a surgeon, you want to get good results, good wound healing, gentleness is very, very important. And I was posted outside Kathmandu by the Director of Health. And the first posting I had was in Butol. And I worked for 10 years in various Anchal hospitals, regional hospitals, as a general surgeon. And there was no Humvee knife in those days. And we used to take skin out with blades, razor blades. It's a very frustrating experience. And and Butol, there was no anesthetist in those days, and in Butol. And I had a friend, Dr. I.C. Biswas, who was an eye surgeon, a very good friend of mine, who used to use the EMO. I don't know how many people here have seen the EMO being used, but he initiated the anesthesia with ether mask, and then he used to connect the patient to the EMO apparatus. And that's how we used to do a lot of surgery. Gallbladder, thyroid, these were our general surgery. And then I went to Nepalganj. And there Dr. Yantam YMS Pradhan was the director. And sometimes he used to come to theater, and in the same way, he used to pour ether and give anesthesia. And then went to Pokhara, Gandaki Regional Hospital. I am sure many of our guests will be going to Pokhara, and you get a lovely view of the mountains from. And every day I used to wash my face, come out the quarter, and the beautiful picture of Machu Picchu peak used to be there, and I would brush my teeth and enjoy the view. And in those days, the problem of burns, deformities, congenital trauma, and these were tackled by general surgeons. And on and off, I used to get visiting surgeons from all over the world, and we used to work together. I learned from them, and we used to get a smile train, on and off smile train. They used to go to teaching hospital, Veer Hospital, leprosy hospital, armed people hospital, and gradually I was lucky. Armed people hospital, Gorkha, we had a British anesthetist who came and spent time in Pokhara Hospital. And then I was chosen to go to England for training and learn burn plastic. And I first started in Birmingham, Worsley Hospital, Regional Hospital, West Midlands. And for 6 months later, I went to Manchester Whittington Hospital. And these are big burn plastic centers. in these regions. And before I went to this hospital, I did 1 month in Royal Infirmary, Edinburgh. And the residents who worked in these hospitals in England were qualified, and they had a fellowship, and microsurgery had started, and they used to do it regularly. And the big thing was what I enjoyed was the BAPS, British Association of Plastic Surgeons. They were very active, and they used to hold international meets, at least 4 meets every year. And I had a chance to go to many, many big cities, and for 2-3 days, these conferences would occur, specialized in hand or some general plastic, and it was fun. Good wining and dining, and besides, you could see, I went to Oxford, Radcliffe, and I took a couple of hours to go around and see the famous colleges in this Oxford Street. And in Radcliffe was a hand meet, and we had famous hand surgeons from the world coming and talking. In India, I went to 2 or 3 conferences and big gathering in India, Delhi, Banaras, and many couple of other centers, and very, very, now you have hundreds of plastic surgeons coming and attending this meeting, and good discussions. I went to one of my teaching to the juniors is that you must read, you must travel. By travel, you see places and you meet people, and that is the education itself. And I had the opportunity to go to Rothschild Hospital in Paris for 1 month. To Rothschild, the famous hospital, has been named after a very rich man, and it's next to the Bastille, and walking distance from the Bastille. And I spent 1 month there, and my problem in Paris was not understanding the language. But then you see these French surgeons working, and that itself was a big education. And in this slide, I just mentioned, universally, I had the opportunity to meet Dr. Golden, watch Dr. Golden do a cleft lip surgery, and it was a treat. This was in Whitney Hospital. Then I had a chance to go to Toronto General Hospital, and there I saw a general surgeon excising the breast cancer, and his friend, his colleague, prepared tram flap down there. So the team was fantastic. And the end result of this tram flap breast reconstruction was a treat, marvelous. And I saw a lot of rhinoplasties, mammoplasties, facelift, tummy tucks, etc. And then another place I visited was Singapore General Hospital, another big hospital with burns and reconstruction and cosmetic surgery. They had 4 consultants, and they used to do a variety of surgery. And saw a lot of augmentation mammoplasties in this hospital. Then after working 10 years, I was allowed to come and work in Veer Hospital, the main tertiary hospital in Veer Hospital. And at that time, while I was working, Dr. Ram Prasad, he was a good friend of mine, was a director. And there was we had a private ward, 2 floors private ward. 3rd floor was empty, a big hall was empty. And he asked me whether you want to start burn plastic. I said, why not? And then we constructed burns plastic on the 3rd floor. And I remembered Birmingham Worsley Hospital, and they had divided the burn ward into cabins. And it was self-contained theater, dressing room, and this is the same plan I did. and I constructed like this. And we had 10 acute burn with 3 ICU beds, 2 operation theaters, and 1 dressing room. Ideal burn and plastic burn ward. And I was able to send 3 or 4 nurses out for training also, Germany, Australia, and India. And I was yet to get a resident to help me. And the postgraduates used to come and rotate and spend some time with me. I didn't have any plastic surgeons to help me. And it's all fun, challenging and fun. And then I got a chance to visit many plastic surgery conferences. And one memorable one was Newfoundland, St. John's, Newfoundland. We spent 5 days of conference in the island there, St. John's, Newfoundland, and you meet all the famous surgeons from Canada and outside. And I had a chance on coming back to send a friend of mine for training for anesthesia to Germany. He came back after training, but he went back to the general surgery. And then gradually, many other hospitals started plastic surgery department. And teaching hospital has now a big department being run by Dr. Isro Lohani. Now I'm told there are 40 plastic surgeons working in various hospitals. Most are confined to Kathmandu. I'm told 2 or 3 have gone outside Kathmandu, are working outside. And young plastic surgeons these days, they're doing a lot of cosmetic work. And they are lucky in that respect. But in the government hospitals, burns, congenital deformities, injuries, hand injuries, and cancers still form the main workload. And postgraduate program, MCH program, has been started in 2-3 centers in Kathmandu. Bees Hospital, Teaching Hospital, MCH program, I think 2 plastic surgeons have been produced in this program. During this time, I was also working many years. I used to go to Dhulikhel, Banepa. This lies outside Kathmandu. And they had a beautiful hospital on top of a hill. And that was constructed by Dr. Ashok Panskota. I used to do once a week and do mainly burn contractures. And this hospital was orthopedic hospital, and it was famous for doing a lot of clubfoots. And the patients came from all over the world. They did not pay anything, and they were mainly poor patients. After I left His Majesty's government, I was lucky to join another teaching hospital, Kathmandu Medical College in Sanamangal. And there, a senior plastic surgeon, Dr. Sambhunath, was already there, a wonderful chap. And we worked together for a few years. And bless his soul, he's no more. But we worked in a 20-bed acute burn and reconstruction surgery department. And when I left, Dr. Amir Badar took over. And as things have not changed, priorities is burn care and survival and giving function. And then I had a chance to work for many years in Kirtipur. Kirtipur, just outside the university, and Dr. Shankar Rai and Kiran Nakarmi, very, very proficient plastic surgeons, and they have started a hand surgery, plastic surgery, hand surgery course, and lots of cleft palate burns, both acute and chronic, are being done there, and hand surgery is very busy. We had a few hand surgeons visiting there, and Dr. Kiran Nakarmi is been trained in hand surgery and doing marvelous work. Microsurgery has been started there, and a couple of other centers, these hospitals started microsurgery, and things are developing. And they have two young plastic surgeons, Dr. Bishal Karki and Dr. Mangal, very good surgeons. And so gradually, in the last 30, 40 years, things are developing. And in Veer Hospital, Dr. Piyush Dahal has opened a burn plastic department. He's got many people working under him. And he's doing microsurgery also. And he started MCH program. So God bless all these people who are working. We started with very little. And few things from 1970, when I joined, started doing general and plastic surgery. We worked. We didn't complain much. And the director, when I went to meet the director of health in 74, as I said, you go to Butol. I had never heard of Butol. I had not been there. I said, yes, sir, I'll go there. I went in my luggage. I worked for 2-3 years in Butol Hospital. We started without anesthetist. And Dr. Fateh Bahadur Mullah used to come and pour the ether sometimes. And similarly in other hospitals. And this was a challenging thing. One of the things I started in Veer Hospital was using sea buckthorn oil. I don't know how many people it's called Dalechup in Nepali. It's a berry that comes from the mountainside, Mustang area, and that's used as a general tonic. And someone told me it's very good for treating wounds. And I said, oh, I tried the burns. So in my burn ward, I got the nurse to prepare the gauze in this sea buckthorn salt solution. And I tried it. But then, as usual, the sea buckthorn was not available. It has come from Mustangs, way up there. And I was not able to come out with definite results. But sea buckthorn is used as a general tonic and high energy. It gives a lot of energy. And in this slide, I have written catastrophe, an opportunity to learn. We've had some big disasters. One of them was earthquakes, a couple of earthquakes. And in those days, a lot of trauma cases, we had the chance to work during this period. So we were lucky wherever I went. I had sympathetic nurses, ward boys, and assistant, and they used to come and help. And very sympathetic. I'm grateful for them. Some of the pictures that we used to do many, many years back. So someone had to tackle these problems, and it was fun, challenging, and the results these days being done by young plastic surgeons must be more. So these are the type of burns we used to get. And my friends here, my colleagues here, all been tackling these problems, and not in the end. So someone has to do them. And so these are the pioneers. You have a picture of Sir Harold Gillies, the father of British plastic surgeon and a great teacher. And Ralph Millard worked with him in thing, and they have written 2 books. And Millard himself was a great plastic surgeon, and he worked with Gillies for 1 year, and Gillies was a very tough taskmaster, and he didn't have an easy time. But Ralph Millard went back to Miami, and he's made a name for himself. And we have the Millard. So others are Blair, Brown, and Byers, and so these are the 10 commands of Millard. And do not covet your neighbor's plastic unit, nurses, flaps. instruments cartilage. And truth, beauty, the idea of plastic surgery these days used to have a, you reconstruct, the ending should be beautiful. That should be the aim, to have beautiful. And so these are people who helped me. They came from all over the world. And Paul Cycle, the hand surgeon from London, I think. And so I had a chance to go to these various countries and learn plastic surgery from these people. And meeting Kesha, father of Nepal surgery, and cosmetic surgery, as I have related here, is become popular among the young plastic surgeons. And liposuction hospital in Paris was famous for Ilus started liposuction in the hospital where I was there for 1 month. And these are huge developments that have taken place. And all right, this is Milad, and this is Paul Tessia, first surgeon. And what's the future? There's no limit. Yeah, that's the future. Thank you.
We are running out of time, so we're going to be very short. So we're not going to be distributing the certificates and the mementos. All the speakers, please collect your mementos and your certificates from outside the hall. And the chairpersons, please collect your certificates outside the hall. Now, before we end, there's been a request by one of our senior friends, Professor Majid Chaudhry. I would like all of you to stand to give a standing ovation to all the senior pioneers of the Southeast Asian countries. Due to some internet error, Dr. Dinesh Nath Gongol, who's a household name in Nepal, his name has been misplaced by his son, and I think Rajesh too deserves that ode. So Rajesh Gongol, but more than you, your father, Dr. Dinesh Nath Gongol. Secondly, I would like to honor our senior, Dr. Kiri Joshi, for taking this great step of establishing the plastic surgery, and I'd request the president to read out the certificate.
The Society of Surgeons of Nepal duly recognizes your contribution to the establishment and development of plastic surgery services in Nepal and identifies you as the division of plastic surgery in Nepal. Your visionary leadership and your adherence to academic and surgical excellence has been the backbone behind the glorious history of surgery in Nepal, presented to Dr. Keshav Das Joshi from the Society of Surgeons of Nepal.
Thank you, thank you.
Thank you, everyone. You can be seated now. We're going to start our first oration. So just 2 minutes and we're going to start the oration. Sir, no. You introduce who the orator is. You will bring him up. Sit him down.
यो अनि ढिकाइ तल राखे भयो अहिले
Gentlemen, we now move to the prestigious B.N. Rana oration. Ladies and gentlemen, it is an honor to introduce Professor Gundu Venkat Rao, one of India's foremost surgical gastroenterologists and the director of AIG hospitals. He leads GI surgery, minimally invasive, robotic, and transplant services, and has trained over 100 surgeons in advanced GI surgery.
No, sir, you sit. You gotta sit. Up, down.
So, the Society of Surgeons of Nepal duly recognizes your academic excellence and unparalleled surgical journey and hereby awards the distinguished L.B. Thapa oration to the B.N. Rana oration to Dr. G.V. Rao on the day of 21st November 2025. Sir.
Our president, Dr. Romeo Kansakar, will share a few words on our orator.
So, Dr. G.V. Rao is a leading Indian surgical gastroenterologist and director of Asian Institute of Gastroenterology Hospitals and Asian Institute of Gastroenterology Hyderabad, an internationally recognized center for excellence under his leadership. The institute expanded into a 1,000-bed tertiary care hospital, offering advanced GI care, academics, and research, and actively collaborating with global APAN networks. He heads GI surgery, minimally invasive surgery, GI oncology, robotics, and transplantation services, and oversees one of the world's largest GI training programs. Having trained more than 1,000 surgeons, he organizes major national and international conferences and is widely published with over 250 scientific papers and 104 textbook chapters. Dr. Rao has performed over 20,000 complex GI surgical procedures and 18,000 endoscopic procedures, pioneering techniques in minimally invasive and hybrid endoscopy. He co-invented the no scar surgery technique and is globally recognized for performing the world's first transoral endoscopic appendectomy. He has conducted numerous live workshops worldwide and contributed to developing innovative surgical simulators and a robotic nurse system in collaboration with IT Hyderabad and IICU Bangalore. His research contributions include breakthroughs in hepatology, pancreatology, inflammatory bowel disease, and diabetes. He played a significant role in islet cell transplantation and research on pancreatic disease mutations. He supports rural healthcare initiative through the telemedicine projects and screening programs in Andhra Pradesh and Telangana. His efforts aim to improve access to emergency care, reduce maternal and infant mortality, and promote early detection of GI diseases. Dr. Rao has received multiple prestigious awards, including the B.C. Roy National Award, Pride of Telangana Award, Economic Times Inspiring Doctors Award, JC International Outstanding Young Person Award, and honorary fellowships from several international surgical societies. He serves on numerous national and global committees related to GI surgery, endoscopy, and training and innovation. Under his mentorship, more than 200 surgeons have completed the DNB Surgical Gastroenterology Program, which consistently secures top national ranks. He has been instrumental in curriculum development for MCH DNB programs and remains active in academic leadership, research, and public health awareness. Dr. G.V. Rao for the oration. Thank you very much.
Thank you so much. At the outset, let me thank the President, the Executive, and all my friends from Nepal for the honor of this podium this morning. What an honor it is to be standing before the August gathering here. Thank you so much once again for the honor. And thank you so much for empowering me to do this B.N. Rana oration, one of the most prestigious oration of the Nepal Surgical Society. And I'm truly honored, humbled to be delivering this before this August gathering this morning. What am I supposed to talk today is on artificial intelligence in gastrosciences. Some of you may believe, some of you may not believe artificial intelligence, but I'll make sure by the time I finish my talk, I think I'll convince everybody that AI is going to stay here and AI is going to be the next in thing in clinical practice. We are talking about, is it enhancing clinical judgment and management in current day clinical practice? A strong disclaimer from my side, I'm not a coding person, I'm a surgeon, not a software engineer, not a basic scientist. Scalpels is my specialty, not syntax. And I'm talking about artificial intelligence basically because I come from Hyderabad, where Hyderabad lingo is the first language and coding is the second language in Hyderabad after Bangalore. And we have a center of artificial intelligence and innovation in our own hospital at AIG. And why am I talking about artificial intelligence? Basically, I'm trying to compete with my mentor, Dr. Reddy, who is a super genius. His IQ is about 130 plus. I'm an average human being. My IQ is about 100. I understand that the IQ of artificial intelligence is about 135 plus. So if I have to stay competitive in current day clinical practice, I'm not a super genius, so I have to depend on artificial intelligence to make sure that I'm in par with what is happening in the world. Gastrosciences is all about clinical judgment and clinical care and understanding the disease biology. And clinical judgment is a dynamic cognitive process to make evidence-based decisions. It is a combination of scientific knowledge, personal experience, reasoning, and intuition to assess patient's condition, identify needs or problems, and develop appropriate actions to achieve satisfactory outcomes. Now, there are several limitations for this, and clinical judgment is based on several of these factors as in today in clinical practice, and these are inconsistent, and it fluctuates due to personal burnout, situational pressures, or age-related because IQ decreases with age. Gastrosciences has got several challenges as in today in diagnosis, choosing appropriate therapy, determining individual responsiveness, and predicting future disease course and guide appropriate treatment. These, as in today, are supported by natural intelligence-based equations, and these seem to be yielding positive results in about 50% of the patients, and in the rest 50% it is either overestimated or underestimated. Now, a provocative statement, medicine seems to define natural intelligence equation-based management, and can artificial intelligence overcome the challenges that we have in current day clinical practice? Also, we need to understand the disease, and disease understanding is disease biology, that is the omics, genomics, epigenomics, transcriptomics, you name it. And instead of understanding each of these, we have to understand omics as a whole, and it is called as multi-omics. And the limitations of multi-omics as in today is enormous data, heterogeneous, and analysis is time-consuming and conflicting and is variable reporting. And this AI helps in overcoming the challenges that we have in current day clinical practice, wherein it is able to integrate large heterogeneous data set from different biological layers, uncovering patterns, predicting outcomes, and enabling personalized medicine. And also, I'm a science fiction buff. I follow science fiction very closely, read them, because I see that a lot of what we talk about artificial intelligence today is already shown, predicted almost 2 to 3 decades back. Example of this is the COVID pandemic. Actually, even before the COVID pandemic struck us, a decade back, there are several movies which showed how the disease can start, how it can progress, how it can be prevented, how vaccines can be made, and what are the limitations of practice. Phenomenal thing that has happened. And also, There are several science fiction movies that came in to show about omics. We thought omics is a new concept in medical practice today, but 1960s itself, they showed this concept of omics in science fiction movies as to how this personalized medicine can be taken, will be the future in medicine. As in today, gastrosciences seems to have everything that artificial intelligence needs. You have large data set from the electronic medical records, imaging modalities providing huge data from endoscopy, radiology, and multi-omics providing huge data. I'm not going to say how you make algorithms. Ultimately, we write algorithms the way we diagnose, prevent, treat, and follow up these patients. And why are we talking about it? Basically, India's contribution seems to be very high. We stand number 3 in the number of publications coming in artificial intelligence in medicine. Phenomenal contribution, basically because of the IT support that we have in 2 cities in India, Bangalore and Hyderabad. A movie called Predator came in 1960s, 70s. For the first ever time, they showed the concept of blue light, which is used to pick up camouflage structure. Phenomenal movie. I think we copied this into endoscopy slide. We started using narrowband imaging on endoscopy, wherein blue light is used to pick up lesions which are not there on conventional white light. Limitations of narrowband imaging, we added artificial intelligence to this. Now, you can see this, it maps out the lesion, as in today, helping us targeting biopsies. So white light, narrowband imaging, and artificial intelligence seem to be advancing so high that we are able to pick up lesions, mark out the lesions, and start targeting biopsies. And again, a work done from our own place, actually, routine colonoscopy, picking up polyps is difficult, actually. We're enhancing the pickup of these polyps by enhancing these polyps. Okay, on the left is the white light, and the right is the AI-generated colonoscopy, which is enhancing the polyp. And if you further magnify, you should be able to see the histology in this. And a step forward, we have this endobrain scope that has got a microscope and artificial intelligence incorporated into it. So you take the scope and touch the lesion, it will tell you whether the lesion is neoplastic or non-neoplastic. Phenomenal thing. So we are avoiding a biopsy as in today. So by putting in a lesion, we are able to make a diagnosis on table about a benign or a malignant lesion. I'm not saying it is avoiding biopsies, but it is helping us targeting biopsies today. Let's step forward. What we do in surgical practice is called this confocal microscopy that is coming to clinical practice now. Now, if you take this diagnostic laparoscopy, you have this peritoneal nodules, pick it up and put it on this microscope. It gives instant pathology in less than 2 minutes. And the images are absolutely similar to the H&E stains. So a lot can be avoided in the operating room. Your frozen section biopsy time is lessened, operating time is lessened. You don't have to wait for the negative biopsies to come in. So this is what is called as in vivo scope, and the advancement of this is that we are able to see the procedure, diagnose on table, and do procedures on table like this advanced EMR and ESD procedures done. Now, this is an ESD being done with artificial intelligence. Again, for a no-voice endoscopy, it is easy. But you can see this, a trainee surgeon endoscopist here as he's doing, it alerts, it enhances the vessel, it alerts that these vessels need to be coagulated to proceed. That is the beauty of artificial intelligence. If it's not coagulated, it is likely that these things are going to bleed. On the left, you can see that it requires prophylactic coagulation. The moment you coagulate the vessel, it will allow you to proceed for further dissection. A step forward is what is happening in my own place, actually. 6 months later, if I come back, I'll show you this. We have this intelligent staplers now. We have incorporated this confocal microscopy in this. So the next time we put a stapler on the stomach or the colon, it will tell us whether the margins are positive or negative. So a lot of R1 and R2 resections can be avoided by using these intelligent staplers, which is incorporated with pathology at the same time. 6 months from now, if you come, I'll show you this stapler, which will be available in the market. Capsule endoscopy, right now, you know that actually you swallow the thing. We cannot maneuver the thing because it has to go down spontaneously. A lot of things have changed. Now it is AI assisted. We are able to read the thing dynamically right now. And we have a very recent advancement that we showcased very recently called the pill board, which can be maneuvered with a joystick from outside. And the capability of this is so extensive that we can start targeting lesions, taking biopsies with this capsule, injecting medicines, and maybe in future, we'll have some personalized therapies for some small bowel diseases in future. Likewise, in liver diseases, we are able to do a lot of things. We're able to identify various lesions. Even without a biopsy, we are able to predict which of the patients going for transplant will do better, which will not do better. We are able to pick up better donors as in today. We are able to differentiate between different hepatobiliary neoplastic lesions. And for fatty liver, one of the commonest modalities is to do a fibroscan as in today. This is a very expensive thing. I think it's available in Nepal. Now, we've devised an algorithm in our own center, which is absolutely, it's a cheap, it costs, about 100, 200 rupees, just an algorithm written. And we have seen that the accuracy of this algorithm in predicting is absolutely similar to the fibroscan that we have. So we have this AI algorithms that are written to make sure that the technology becomes cheaper. And also we have this algorithm written in my own hospital for early sepsis detection. Every single patient in the hospital is on the EMR records right now. So all the parameters are fed into the system. It is alerting us which of these patients are going to a septic shock. The biggest thing that has happened is actually we alert the surgeons, the endoscopists, the clinicians are being alerted. The number of code blues in the hospital have dramatically reduced in this with the introduction of this, and we are able to salvage many of these patients. Likewise, in endoscopy, it has started predicting CBD stones. It has started predicting post-ERCP pancreatitis. It has started predicting which CBD stone is going to be difficult to remove. It has started predicting how much of radiation that the endoscopist is getting exposed. And all of you know about the SPY scope that is used for spicolangoscope. The bites that are taken with the SPY scope are very, very small, and the biopsy rates are very minuscule. In the sense, actually, the biopsy rates in the scene of 60 to 70%, but when we include artificial intelligence, the accuracy goes on almost about 90%. Phenomenal thing, actually. So I think we'll see more and more of this. We have started using this in clinical practice as in today. Subsequently, we all see this movie called Predator 2 came in, actually, where they started using infrared light for the first ever time to pick up camouflage structures. Phenomenal thing, actually. Nobody thought that we surgeons will acquire this technology into surgical practice. We brought ICG into clinical practice, infrared ray, and we're using ICG. Now we're using it to pick up nodes, to check up the vascularity of the anastomosis at the end of the thing, and several other things is being done. Now, AI, ICG, it is helping us better delineate. You make sure that you are in the better steps during simple procedures like bile duct cholecystectomy. So the number of bile duct injuries could be dramatically reduced when you start incorporating this. Again, actually, a laparoscopic Whipple is being done. Actually, that's a remnant of the pancreas. We anastomose the jejunum to the thing, and it could leak some time. Could be one of the factors is the vascularity of the pancreatic remnant, actually. Here, we used to go by the color, the feel of the pancreas. Actually, now AI gets into the thing, and it tells us the percentage of vascularity. Not only pancreas, it tells us the percentage of vascularity, the bowel that is anastomosed. So suppose if it's 80% plus, it means the chance of leak is absolutely low in these patients. Again, for HCCs, actually, ICG is being used right now on table to differentiate between well-differentiated, moderately differentiated, and poorly differentiated, basically depending on the fluorescence. Phenomenal thing, you can say on table, and a lot of decisions can be changed on table depending on how it is going to fluoresce. And we add a lot of molecular targets that are being added to this, and I think a lot of surgical decisions will be changed on table in future based on these studies. And again, an algorithm written in my own center that doing this, actually, this is for simple gallbladder. This is for basic surgeons. It identifies and it tells us where the cystic duct is, where the bile duct is, where the gallbladder is, so that you're in the appropriate plane. And a step forward is to show you this. Now, this is actually doing this major gastrectomy procedures, advanced procedures. It continuously alerts us that these vessels needs to be coagulated. You see the surgeon is continuously operating away from the thing, and it doesn't allow you to proceed till these vessels are taken care of. If you don't, it is likely that it could be catastrophic. You understand what I'm saying? So a senior surgeon can identify, but look, maybe a surgeon who's operating alone, difficult to the thing, I think it will help identifying this. Again, very recently we started this anterior resection, low anterior resection being done. And you can see the ureter continuously being shown with AI so that the injury to the ureter can be avoided. Likewise, we talked about white, blue light. Actually, we have this yellow enhancement which has come, whereas the yellow component of the light is, the fat is being enhanced. It is called yellow enhancement. And just to show you, this is white light laparoscopy, and then you switch to yellow mode, it enhances. IBD, it is able to pick up a lot of fat creeping because basically fat is getting enhanced. We are able to see subclinical strictures even before we see it cross-sectional imaging. And you see the difference between a white light laparoscopy anterior resection and an yellow enhancement procedure. You can be better in planes. You can be better, amount of blood loss is less. Tubular vascular structure identification is better, so that the morbidity, mortality associated with these procedures could be less. This idea was borrowed from this movie called Avatar, wherein for the first ever time they showed this concept of yellow enhancement in the eyes in this. And again, a project that is being done in my own hospital, I'm very happy. It's called Octopus. I showed you white light, blue light, yellow light. Now this project, Octopus, again, I can show you very soon. It changes colors depending on where you're operating, enhances structures dynamically so that you can identify structures. You have been better planes, and your surgical procedures could be very safe. I cannot show you the live video, but I can because of some conflict of interest, but the project is called Octopus, and I think I'll be able to show you very soon. Pancreatic diseases is able to differentiate between cystic neoplasms, various cystic neoplasms, and there's data to show that pancreatic cancer can be picked up well in advance, even before cross-sectional imaging can pick up pancreatic cancer in current clinical practice. IBD, a lot of things has been going on in IBD management, and we start actually our own data to differentiate between Crohn's and non-Crohn's disease. AI is used again, and again, a project going on in my own center. We talk about this inflammatory bowel disease patient undergoing total proctocolectomy with an ileostomy. Now here we have a continent stoma here. In the sense, it's like a cap on the bottle. So this cap fits onto the ileostomy side, so the patient can empty the bowel at his or her convenience, rather than continuously draining into the stoma bag. This is a continent stoma, that is, there is no artificial intelligence in this. But what we did was we put sensors into this device. So this device is connected to the mobile, and it tells us the pressure at which the patient has to empty the bowel. And as we keep adding sensors to the thing, it is likely that we can monitor these patients continuously, even from their home. It is something like the smart toilet that we're talking about, where as you keep adding the sensors, we can monitor these patients better. Again, it started predicting complications following major abdominal surgery. It has started predicting recurrences in these diseases. And the best part of it is actually what we talk about, integrating preoperative, intraoperative data to do this navigation surgery. It is slightly come later into GI surgery. It is already there in neurosurgery, basically because we deal with mobile structures. It has come slightly later. It is something like having a Google map on top of your pictures. This will tell us point A to point B, which is the least traumatic route, least vascular route, and which can give you more R0 resections. So a lot of these practices can change with the incorporation of this into clinical practice. Robotic surgery, as in today, myth that robo performs surgery. Actually, we have senior surgeons like Deep here, actually. So it's a myth. But as in today, it is aiding surgeons right now. It is not performing. And as laparoscopic surgeons, we see that there are 4 steps that we do. Your assistant shows you the lesion. You recognize mentally what to do. You decide what to do, and then you move your instruments. Now, AI is getting into each of these phases of surgery. It is able to show, it is able to recognize, it is able to decide, it is able to move with 95% accuracy. And the end result of this is the first ever cholecystectomy that is done totally by the system and not by the human being. If this were to continue, just imagine the fate of the surgeons of future. It's not going to be very far when the systems are going to take over. This system was trained for over 6,000 cholecystectomies, and this is done independently and no bile duct injury. And likewise, actually, phenomenal movies like this come actually showing the concept of space surgery. Actually, NASA has started this fellowship in space surgery for all the young surgeons here. I think you're interested in something phenomenal. I think you should take up this. We have registered one of our junior consultants for this. Hopefully he'll get this, and maybe we'll talk about surgery in space. Nutrition is one thing that is depleted in ICU. As in today, it is subjective, equation-based, and we have shown that we have alerts for every single thing in the ICU, but for nutrition. And it is shown that we are depleting these patients in the ICU that is responsible for the morbidity that we have, 30% being depleted. And we have this AI called as, which gets incorporated into this. Once we have this AI, it's called indirect calorimetry. We have shown in our own hospital that we are depleting the patient by 30% of nutrition. This is called iatrogenic nutrition, and this is what is responsible for the morbidity that we see in the patients. We also started monitoring physicians and surgeons about the ergonomic movement, because this is one of the commonest causes of the burnout. Actually, we started mapping them. And this is about AI, so diagnosis, treatment, and follow-up. And we get on to multi-omics. Fast forward, we talk about multi-omics. Now, what if every patient's biology could tell us precisely what treatment they read in real time? Now, this is what is about multi-omics. It analyzes and are used for risk prediction, early diagnosis, accurate diagnosis, and identification of biomarkers for various diseases. And it enables the creation of highly personalized treatment by analyzing individual, unique multi-omic profile. And as in today, it is able to make a big dent into cancer surgery. And anybody who follows this, actually, Sundar Pichai very recently came up with a statement saying, new AI helped find potential breakthrough in cancer treatment, paving way for combination therapies. That could have never happened with natural intelligence. And also, the uniqueness is that we are able to, the treatment procedure, patient can monitor their procedures, progress, recovery, therapies. They can compare themselves to the other people across the globe. And patients are becoming more aware of their diseases and the entire clinical options available. So the day is not very far. With all the limitations that we understand, it's not very far when AI will provide personalized treatment to cancer patients tailored to their needs with quicker recovery. And a lot of science fiction movies again showing this actually. Now, in addition to all these omics that we talk about, there are two other omics that we talk about. It's called surgeomics, that is you and I. These factors we determine. And clinicomics, that is the clinician's perspective. In addition to all the multi-omics, we should combine these things for betterment of these things. So the next thing is going to be all these omics that get integrated for personalized treatment, and it requires collaboration of clinicians, data scientists, and ethicists. And AI is not to replace biology, but it is decoding it as it is, faster, decoding biology faster so that we're able to take decisions faster. And we have the centers which start doing personalized therapy, wherein maybe you can start gene manipulation, gene therapies actually can be done in future. Whether you like it or not, AI is everywhere. It's like an oxygen for us. In this room, I think 80% of you must be following AI as in today. It's in air, it's lifeline. And the computational speed of this has become so huge that is getting faster and faster. And the system that is going to, the quantum chip that is going to come next 2 years is going to analyze data within few weeks or maybe months as compared to the decades of things that AI people have been doing. I thought I created this image of myself. I thought I should be 2 decades younger to see all this happen. But Sundar Pichai made this quantum below, and he tells us that all this can happen in the next 5 years. So I don't have to be like this to see all this happen. I think I'll be seeing all this in the next few years. So another beautiful example. Somebody made a beautiful presentation this morning about the evidence today. Deep, this is for you. As in today, evidence is published by 1% of clinicians. These are called innovators and researchers. And we have 9% of the people who propagate this. These are educators or early adopters. And we have these 90% of the people practice this blindly without asking any questions. AI has become the pace. The way in which we practice is no more a snail pace. It can enhance. And a lot of people like me who are in this 90% can get into this 1% if I get into AI. That is the beauty of AI compared to, and medicine could rapidly change this. The drugs are being discovered faster with AI, But surprisingly, AI is no different from natural intelligence. It has to follow the same thing. Bench to bedside, clinical trials, evidence-based pyramid is absolutely same. You write an algorithm, it has to go through FDA to get it approved. And there are some people, maybe some people here also, people think that AI makes people dumb. This is a little, it's something like saying alcohol causes cirrhosis and pancreatitis. Alcohol doesn't cause cirrhosis and pancreatitis in every patient. Alcohol in moderation, actually it enhances clinical judgment. So this is a paper, it's not a published paper. It is just an article that has come in the thing, but it is basically a social media hype of AI pessimists actually. So we have created, will this become irrelevant? Actually, there's no audio. This is Mira that we created in our own hospital. She is a medical information robotic robot, which answers all the queries of the patient when sitting in the outpatient, beautifully tailored to, it is updated to the best PubMed update that we have as in today. So it keeps answering each and every single question. So this we have as using it as a clinical assistant. People might ask me, why are you taking help of this? Tremendous help in counseling, actually, AI. You have a death in the hospital, 100 attendants sitting in front of you. First question you answer, second question you answer, third question, he gets irritable and you get irritable. That is where the entire catastrophe starts. AI, you take a Google map in your car, 100 times you take your devious course, it does not change the tone in which it will answer the thing. The tone is what is important, and AI is helping us to improve this. So the challenge, there's several ethical considerations about this multi-omics, actually, data heterogeneity, algorithm bias, privacy, consent for data, regulatory frameworks. Will hospitals, government, physicians purchase, license this expensive thing? Legally, who would be responsible for this? Who will validate this heterogeneous data? Who will quantify severity and extent of the disease? There could be some inconsistency like natural intelligence, and what if the system crashes or decisions are delayed in the entire process, or what your system is corrupted and hacked. Actually, recently, actually, you've seen, I think some major hospitals in Delhi were hacked. The system went down for almost 1 week. So corporate rivalry, anything can happen. Somebody can hack into your system. And people keep saying that artificial intelligence does not have a gender. You call about he, she, and it. It is information technology now. I personally believe AI is the gender for information technology today. It does not have a face, but it has got everything that natural intelligence requires. You talk about empathy, actually. You understand? Somebody was talking about empathy and human. I agree with that, agree. But evidence shows 40% of the doctors are Botox today. It means they cannot frown, they cannot smile. So where is empathy gone? So as more and more people get Botoxed, you cannot frown, nor that you can smile at the patients. And AI has shown that it can empathize better than human beings as in today. And as we embark on this AI journey, we are not just creating characters, avatars, and humanoids that simulate emotions, but we are fostering an undeniable intellectual connection and involvement with these. What happens is there is beautiful science fiction movies which show that what if these bioengineered humans replicants are indistinguishable from humans, and what if these program machines believe themselves as humans? And what if human consciousness merges with these machines? And what if I fall in love with the Mira that I created? My decisions could go haywire. So these are all the limitations of this, but the science fiction movies also tell us the limitations of this as to how these things can be overcome, actually. These are beautiful movies which show the limitations of the evil aspect of artificial intelligence. I hope something like this happens. We have chairs that can get all the data from the patient as in today available in market. I hope this can happen. Patient has a disease, lies down on the table, diagnosis made, treatment made, and the patient walks out. Absolutely possible. I don't think it's going to happen very, very soon. There are some people who don't believe in artificial intelligence. They feel that natural intelligence is the best. So for these people, actually, we have, I think, people who have natural intelligence, I think they can enhance themselves by having an extra hard disk in their brain. Quite possible. This movie shows that how an extra hard disk can be fixed to enhance the processing speed. People thought it's an absurd idea, but again, Elon Musk puts the chip in the brain. So whether you believe in artificial intelligence or natural intelligence or a combination of natural intelligence with artificial intelligence, this is the new thing that we cannot avoid. You're bound to be involved into this. So to conclude, disease management is complex, as in today, expensive. Improving clinical efficiency and optimizing healthcare resources is of paramount importance. Evolving advances in AI are promising with potential to revolutionize diagnosis, clinical care, detection of lesions, tailoring treatment, improving current survival, and predicting treatment responses. AI is helping us in identification of new association between variables, potentially leading to changes in clinical practice. Now, are we ready for the prime time? It is slowly getting into clinical practice. Some of these things are being done, but I think it's going to be very soon that these things are going to be legalized and we start using this in clinical practice. So get ready to living intelligence. See, we talked about natural intelligence, artificial intelligence. There's a thing called living intelligence as in today. So far we have the artificial intelligence that is around us. So we are talking about in future, AI is going to be on us, in all the wearables that you're wearing as in today, and in us, that is all the chips that you're going to get into the body now. You have to be wary about all this, and I'm sure in the days to come, we'll see a totally different way of management, whether you like it or not. Thank you so much once again for the patient here.
So thank you, Dr. G.V. Rao, for the wonderful presentation on AI. I think this is the way ahead for the future. And I think we should all give him a standing ovation. So we will come to learn about AI in AIG. So some of our students will be coming there. So thank you very much. He's got a flight to catch. So thank you.
Thank you so much, sir. Now we will be moving on to session number 2 for the day. I would like to request our chairpersons, Dr. Manohar Lal Shrestha, Dr. Satish Midha, Dr. Duminda Arya Ratne, Dr. Bhoj Raj Nyopani, and Dr. Rakesh Kumar Gupta to kindly come forward and assume the chair. And I request everyone to kindly go to Hall B, C, T, and E for the respective scientific presentations. And also, I would like to inform that the poster presentations are going on till 12:30. Kindly check it out.
Good morning, everybody. So from that fantastic AI, we move on to the real world also. So over to, this is a hernia session. So from our co-chairpersons, I now invite Dr. Devarshi Sharma, who is from New Delhi, India, will speak on newer techniques of ventral hernia repair. We all know that hernia has developed into a new subspecialty, herniology, and many advancements are taking place in field of hernia, and the terminology is getting complex. Every day a new name, nomenclature comes, and it is sometimes difficult to keep pace with it. So over to Dr. Devarshi Sharma for his presentation on newer techniques of ventral hernia repair.
Thank you for the invite and proud privilege and honor to be here among all of you. Thank you, sir, for your kind words. From the lectures on vision and the future, we come to the clinical part of the conference. Till this gets sorted out, I'd like to thank the organizers, Dr. Romeo, Dr. Sunil Sharma, and his whole team for inviting me and the whole Amasi group to be here among all of you. As rightly said, that ventral hernia, something is happening with the hernia groups, is that every 6 months we have a new procedure with a new name, with a new mnemonic, which is difficult to understand at times. All the procedures are same. Sometimes what happens is that somebody is doing from the top, somebody is doing from below, somebody is doing from the right, somebody is doing from the left. So you come across different structures and both are given the left, right, top and bottom, added names, B for the bottom, top for the T for the top. So this kind of thing is happening, but there are definite advantages and disadvantages of some procedures. One needs to know these procedures just for the sake that there might be a patient which a particular procedure is indicated. And to help your patient out, you need to know all these procedures. Knowing these procedures is the... will it happen? What happened? Okay. Right. Till the time they fix it up. We all have known open hernia surgeries for a long time. Then we have had laparoscopic repair of hernia, basically putting in a mesh. Suppose we have a hole here and you're putting in a mesh there. Long back, I met Carl Blank, who initially devised IPOM. The first thing he said that he's not very satisfied with the procedure, which he himself devised. Then once I spoke with Dr. Bittner, he said that I am still, if I have to have a ventral hernia procedure, probably I'll not do it, do an IPOM, allow the surgeon to do an IPOM on myself. So what has happened with IPOM is that over the years, the many papers came for the quality of life, many papers came for the post-operative pain, many papers came for the mesh-related complications, the mesh inside the peritoneal cavity, those issues came. But because of which, and along with that was the cost of the mesh. The cost of the mesh is something which nobody, many patients couldn't bear. And with that, the newer procedures came, right? So we already know, I think, about this, the magnitude of the procedure, magnitude of hernias, what we have. Almost every fourth patient undergoing a laparotomy turns up to be having a hernia. And the ideal procedure is still being awaited. This is what I was talking to. When we talk about the quality of life in hernia patients, in IPOMs, the long-term recurrence, pain, everything, we're not satisfied. We got a lot of studies in this in the last 1 decade. And this was something which came up very recently. In March 2025, that the problems which we are facing with the mesh intraperitoneally, along with the cost, and does the mesh causes other problems. So if we have other procedures where we can put the mesh, a different type of mesh, or at a different position. Right, thank you. So there always has been a different consensus to the position of the mesh. The mesh can be over the fascia, the mesh can be behind the fascia, mesh can be behind the rectus muscle, mesh can be just pre-peritoneal also, it can be intraperitoneal. All following the same theoretical law of the Pascal's law. With this idea in place, numerous repairs have been devised with the name of Scolas, the subcutaneous laparoscopic, subcutaneous only laparoscopic approach, the Milos, the R-ROM, the retrorectus repairs, the ETEP RS, the ETEP Reeves topaz repair. As I said, that we need to know these repairs just to have an ideal patient where we can be doing the procedures. Basically, if one has to remember what are the procedures are, they are divided into epiphyseal, means the only repair, the repairs which are done above the fascias. Then we have the sublay repairs or the below the fascias, which can be below the fascias in the form of the behind the rectus muscle, and some are periperitoneal or the intraperitoneal. These are the names which comes into it. The most commonly done pre-facial repair is the scolar repair, which is called the subcutaneous only laparoscopic approach. These are the other names of the procedures, and broadly all procedures follow a common principle. Now, what happens is that when we have a hernia, when we have a small umbilical hernia, there might not be a pathology or an incision at that only point only. It might be a long weakness. That is one thing. And these patients also can have a divarication of recti, which again is classified by the BS. There are numerous classifications which why you have a divarication. It generally happens in the upper abdomen because the rectus muscles tends to be a little away at the upper abdomen, above the umbilicus. Below the umbilicus, the rectus tends to come down medially. So when you have a patient with a divarication with an umbilical hernia, these procedures tend to do well. Now, how to do it is the position is the patient position and the surgeon's position is shown in the image on the left. And the image on the right shows the port position, which the 10 mm port is the blue one, and the two 5 mm ports, which are just above the 10 mm port. The 10 mm port is about 2 to 3 centimeters above the pubic symphysis, with the patient in the leg split position and the surgeon standing in between. The first is creation of the port. When you create this port, it can be done with an optical trocar, or it can be done using a blunt instrument. You can use your finger also to create that port. Use this S-shaped retractors also one can use it to create the ports. The first thing what is seen is this kind of an image, the initial space, and then one needs to put 2 5 mm ports which are above that level of the first optical port. These are lateral to the optical trocars and maybe 2 centimeters above towards the umbilicus. The instruments through this port do is that dissect the plane interior to the fascia. Dissect the plane. Once you dissect that plane interior to the fascia, you are left at the roof with the subcutaneous tissue and the skin, and posteriorly you have that fascia. Through that fascia, the hernia is coming out. One needs to be knowing that there should not be bowel in that hernial content. One needs to dissect that hernia down. After dissecting the hernia, you go up to the Jiffy sternum, laterally about 7 to 8 centimeters from the midline on both the sides, and create that whole space. And you end up with a hernia as well as the divarication of the recti at the top. This is what is the hernia is being dissected here. Right, this is the center with the hernia being dissected. Right, we go up to the top and you create this whole space. Once you have this space, one needs to suture the divarication using a continuous suture from the Jiffy sternum down to the pubic symphysis. And as you suture it down from above downwards, you can take the hernial defect also. Right, once you do that, ultimately, and then once you put a normal mesh. The biggest advantage of these procedures, all these intra-abdominal procedures, are that you have a layer of abdominal wall above the mesh and a layer of abdominal wall below the mesh. What happens is that the mesh gets incorporated into the abdominal wall properly. Number 1 point. Number 2 point is that you can put in a normal polypropylene kind of a mesh. You do not need a tissue adhesive preventing material mesh, which is a very costly mesh. You don't require to do that. So this is you can put in an uncoated polypropylene mesh. There is no risk of visceral injury. You can do these procedures in a very angry abdomen also in a patient where the previously some kind of inflammatory process had taken place. So in that also one can do it. But definitely these have a steep learning curve. While dissecting, you can injure the epigastric nerves, the small nerves which supply the epigastrium, those can be injured. And as you do a big dissection, there can be a lot of seromas. You might need to put in a drain, which is regularly put and which these drains can stay for a long time. Beyond that subcutaneous repair, you have the retromuscular repair. I'm talking about the two most commonly done procedures. This retromuscular repair is with one principle is that these spaces, the right and the left rectorectus spaces and the lateral spaces beyond the linea semillunaris can be made into one large space, and one can put in a very large mesh at that space. So if you dissect properly in the proper plane, get into the space behind the rectus muscles, between the linea semillunaris, which is the Reeves space, and below, in the suprapubic area is the stoppa space. That becomes the Reeves stoppas repair, which is called. And laterally, if one has to go beyond the linea semillunaris, you have to do a transversus abdominis release. So these retromuscular repairs are mostly named as RROMs, which is called the rectorectus only mesh, published by Dr. Kalpesh and his friend Samir. And also the similar kind of an approach which was published 6 months after RROM is the transabdominal retromuscular repair. So this is the publication of Kalpesh and Dr. Samir. So we know that the retromuscular space, the Reeves stoppa space, is the space between the linea semillunaris. The problem with this repair, it requires a little bit of ergonomics. It needs accessory instrumentations at times. One has to be well versed with intracorporeal suturing, and eventually this is a cost-effective procedure. Now, in this procedure, if the hernia is in the green, if you have a first image on the left, if the hernia is that green area, one can start from the top-down approach. And if the hernia is in the yellow area in the image number 2, you can do a bottoms-up approach. You can start from inferior to above. As I said in the first image, that the rectorectus spaces, the right rectorectus and the left rectorectus spaces has to be made into one in doing a Reeves stoppa space. So you get into the right rectorectus space or into the left rectorectus space, you have to move to the other side. That is called a crossover. You cross over from one side to the other. And then if you can repair it within the Reeves, between the linea semillunaris, which is the Reeves space, that ends up as a Reeves stoppa repair. And if you have to go beyond that laterally, that becomes a transversus abdominis release. These are posterior repairs, posterior compartment. I'll show you a video. The video starts with the port. This optical port is there, and you can see the rectorectus space, the section is being done. So this is the rectorectus space on the left side, and the dissection is being done. And this is the crossover. The crossover is generally either above or below the defect area. It has to be in a virgin area. It has to be in a virgin area. Some people, expert people, can do it in other areas also, but that area you will tend to open up the intraperitoneal. You'll go intraperitoneally. Once you make that incision there in the posterior rectus sheet, 2 millimeter away from the midline, you get into the falciform. You avoid getting into the falciform, stay on the top of the falciform. You see the pink shadow of the opposite rectus sheet, and you need to create a space, a posterior space behind the right rectus space. Here we are going from the left to the right. Right, the first space was made on the left, and then we are going into the right, and another port is being put there. So these two spaces, the right rectorectus space and the left rectorectus space, is being joined, and the hernia you're coming down to the hernia. This is people talk it as a volcano sign. You dissect both the rector space and keep the hernia in between. They call it a volcano. Too big a thing to be called for a hernia, I think, at times, I think. So you dissect the hernial sac. You have to be sure that there is no bowel content. You stay as medial as possible, because if you go lateral, you will have to repair that defect. If you go lateral, the defect becomes bigger. So in order to repair that defect, you might have to do an unnecessary TAR in these patients. So dissect this hernia down, go down to the stopper space, continue the dissection in the retrorector space, and then take care not to injure the nerves laterally and the vessels laterally. You can use your ICG here also to look at the vasculature. That is the white defect. You have a defect at the top and a defect below. Some people do give a concept, which I also believe, that you suture the defect on the roof first, because what it does, it approximates the rectus. The defect in the floor gets reduced. So another continuous suture using a V-lock suture. From the distalmost part to the proximally, and once you complete that, you do a posterior repair. The posterior rectus sheath, the right and the left posterior rectus sheath. If there is a tension in this place, while closing this, you might have to do a lateral release. This is what I'm repeatedly trying to tell you. The idea here is to close the rectus sheath so that the mesh which you will put it here should not come in contact with any intraperitoneal organs. So once it is closed, a normal mesh can be put here, and it can be fixed laterally as well as distally, and one can put in a drain if required. If not a drain, that can be kept that way. The advantages is that this is the sublay position of the mesh. The mesh gets incorporated. The recurrence rates are low. The pain scores of IPOM is also not there. It can be done up to hernias up to 8 centimeter in width, and beyond that you might again require a lateral release. The challenges again of these procedures is because these are space procedures. These have got a steep learning curve, and there is always an amount of denervation which is happening in the abdominal wall. The complications can be many, because as we cut the posterior rectus sheath, there are new things which are happening. We sometimes have a rupture of the posterior rectus which has been sutured if it is under tension. Postoperatively, when a patient is being extubated, you do a pharyngeal suction, you do that. At that time, the abdominal wall tends to contract. That very time, the posterior rectus tends to rupture. If that happens, the bowel gets directly in contact with that raw polypropylene mesh. That is a very dangerous complication which can happen. But newer things also people are seeing. Yesterday also I discussed with Kalpesh that we are seeing epigastric hernias, which we have a concept why these epigastric hernias are happening after these repairs. Then we have the other preperitoneal repairs, the intraperitoneal repairs among the newer procedures. It is not possible for a surgeon to know all of them or expertise it, but because several procedures have been devised, we need to know some procedures, because there might be a patient which will be properly indicated for the procedures that described. It is always better for the surgeon to have all these procedures in the armamentarium and characterize these repairs depending on the BMI, primary or the secondary hernia, presence of associated rectus defect, failure of previous repairs. Depending on what procedures it has, the surgeon should tailor it accordingly. Thank you very much. At the same time, I invite all of you for AMASICON 2026, which will be held in Calcutta in the month of August next year. Thank you very much.
Thank you, Dr. Devarshi, for giving us the details of repairs which are in vogue now. So I think we have been instructed by the organizers that we'll have question answers within 15 minutes. So
you can take a question probably, but my time was lost.
So we move on to the second speaker, Dr. Ishant Kumar Chaurasia. He's from Madhya Pradesh, young dynamic surgeon. We all know that even in this era, majority of the hernias are being done by open techniques. So we have to know what is the current consensus of open groin hernia repair.
So, good morning, everybody. First and foremost, a big shout to the organizers of the Nepal Surgical Society, and I'm very grateful for the invite. Hi, I'm Dr. Ishant Kumar Chaurasia, and I bring greetings from Mandsaur, the place of Ashtamukhi Pashupatinath, to the place of Pashupatinath here in Kathmandu. So, hernias. We all know that hernia procedures, especially the groin or the ventral repair, they have gone a steep, long changes, and various new procedures have come up. So are we forgetting the open hernia repairs? Young surgeons also are more focused towards different approaches of laparoscopy and now the robotics. So where does our traditional open hernia layout present? In this brief talk, I'll try to explain that even the open hernia repairs have undergone changes and beautiful changes, and that has to be followed up. But you should always remember that the real gold is never ever afraid of the melting pot. And so is the case of our open groin repairs. And by the way, I'll give a disclaimer for that. I'm myself a MIS hernia surgeon, but being a professor, I also teach my undergraduates and postgraduates the importance and the empathy of the open hernia repairs. The hernia surgery guidelines, it's very, very clearly said that when an open hernia has to be done, when a laparoscopy or a robotic repair has to be done, when a mesh-free repair has to be done, or when a mesh repair has to be done, whether anteriorly or pre-peritoneally. The guidelines are absolutely clear, but especially in case of symptomatic conditions or emergency or elective outcomes. Especially in elective, we all know that whether it's a primary unilateral repairs, which procedure has to be followed. When there's a recurrence or a redo repair, which procedure has to be protocol? Yes, in recurrence, a lap converted back into a lap by a senior surgeon is advocated, but by a young surgeon, it's an absolutely no. Similarly, in emergency setups, when there's incarcerations, we can go for an effective laparoscopy, but when the bowel or when the peritonitis happens, when there's a peritonitis, which procedure? Laparoscopy or open repair? We all should remember the hypocrisy thing. Do no harm. That has to be followed. There are setups when the anesthesia is not possible to give. Can we go for a laparoscopic repair or a robotic repair in these ways? Absolutely no. Yes, Lichtenstein repair has its own consults. It said that, yes, after a Lichtenstein repair, the most common thing the patient used to complain about is about the inguinal, the chronic groin pain. But yes, that has also drastically reduced owing to small modifications in the Lichtenstein repair. But the recurrence rates have remained the same, whether a laparoscopic or an open repair. The basic steps of Lichtenstein repair we all know is the same. So where has the modification come up? The modifications has come up especially in the mobilization of the cord, the placement of the mesh, the fixation of the mesh, and the closure. Here the modifications have come up, which has prevented the chronic groin pains that used to be the chief complaint following an open groin hernia repair. So amid modification of Lichtenstein repair is very, very clear and says that what has to be preserved and what have to be taken care of. Most importantly, the sac inversion, use of mesh, use of suture material, and previously we used to take the interrupted sutures, change it to the running sutures. Where and how, we'll show. Whether we do a mesh repair or non-mesh repair as per the hernia search guidelines 2018 or 2022, the recommendations is very, very clear. The talk is only about the chronic groin pains and the recurrences. That is absolutely same. And in the open repair, it has drastically reduced following the amid repair. Even when we compare the Lichtenstein with the open pre-peritoneal repair, the data says that the results have been equally acceptable. When we compare it with a lap endoscopic repair, yes, the chronic groin incidence is less during a lap endoscopic repair, but still, the first choice warrant is the Lichtenstein repair. And we all should remember that globally still, the open hernia repair is the most commonly performed surgery as compared to a robotic or an endoscopic repair procedure. The PubMed article is very clear using the amid hernia repair that the placement of this mesh, especially in the external oblique area and the inguinal ring, has drastically reduced the incidence of chronic groin pain because we have using an atraumatic measures, especially to mobilize the cord, which initially when we used to do the Lichtenstein repairs we were not doing it, and there used to be injuries to the regional nerves. That is being widely prevented using the AMED modification. Second comes into the frame is whether which type of suture material has to be used. So use of the absorbable suture materials has significantly reduced the pain, and it has been documented in a very nice literature by Morena Borati in the mesh fixation methods in groin hernia repairs. Now here's another thing, that is the TIPP repair. It is a transinguinal pre-peritoneal repair in open surgery, and it has also been associated with very less chronic post-operative pain because the mesh is placed pre-peritoneally, and hereby direct involvement of the regional nerves is avoided. And this is also, and since the exposure is less, the chronic groin pain of the inguinal area incidence is reduced, and this is well documented as a very alternative procedure in open as compared with Lichtenstein repair. So old will forever remain a gold. And the bailout procedure still remains our open procedure, and that has to be taken into account. So there is something very new in the town that is known as the combination of the tissue and the mesh, that is known as the tissue mesh repair. Now in this, as you can see that the mesh is fixed in the transversalis fascia area. We remember when we used to do a Lichtenstein repair, the only one autologous tissue was strengthened up. But in this repair, all the three tissues are strengthened up, thereby strengthening the hernia repair. The suturing is done constantly in the involving the conjoint tendon and the transversalis fascia, and the mesh is centrally hooked. Thereby, the continuous suturing goes up to the external iliopubic tract or even above the inguinal ligament, and the continuous similar running sutures has been taken aback. Thereby, a solid autologous reconstruction of all the three autologous tissues are happening. So this is usually what, in this figure, you can see that we used to do in conventional Lichtenstein repair. As compared in the TMC repair, all the three the autologous tissues are fixed up and thereby strengthening it. So the chance of recurrence also goes down. Yes, it is reduced to 1 to 4% and is further reduced. We are well aware when to do the Desardas technique and how Desardas techniques has evolved now and is accepted globally as or the shoulderized repair as well. Not go much into that. So what does the consensus say? See, consensus will always be biased. I am myself an MIS hernia surgeon, will always prefer an MIS repair, but consensus, and it will never be a ending argument because which method is superior. Why? Because there are various confounding variables to it. Most important is the own surgeon factors. Secondly, the history and obviously the size of the hernia, patient factors, and this wide area of techniques available. So which procedure is best? That will always be a debatable thing in hernias. Why? And since we prefer our choice of surgery, so definitely the results will array, and the meta-analysis will always be very difficult. We all are very great fan of cricket, we Indians, and we follow Sachin Tendulkar. And Sachin Tendulkar has, during a test match in Perth, widely said, what will happen when you found some situation where it is very difficult to bat. So hernias also lead up to many situations, which becomes very difficult to manage on the current table. Scenarios like contaminated or infected wounds, when there is stillage of the stool. Use of mesh is not indicated, but again, which procedures to be done in contaminated settings or bowel resection is required. Yes, a no mesh repair, we prefer for an open surgery. Incarceration with possible strangulation, yes. TAPP with a use of mesh has been advocated now, but if the bowel is not viable, it's an absolutely Bassinis or a Mackler procedure to be followed up. Recurrent cases. As we all know, if there's a recurrence after an open surgery, we have to go for a laparoscopy. If as per the hernia surge guidelines and the SAGES manuals. If there's the recurrence after laparoscopy, go for an open. But yes, if you are very well versed and very experienced surgeon in the field of, especially in the hernia, or rightly full Satish Mita sir said, and many of us senior hernia surgeons from India are here, Kalpesh Jani sir, Deborshi sir, Prashant Rahate sir, we all will agree that redo laparoscopy is possible, and we are doing now into redo procedures. Yes, a TAP redo can go into a TEP or ETEP, but yes, the procedures remains the same. But what if the abdomen is very hostile, not supportive? Then the bailout and the best procedure is still the open repair. Elderly patients, whether any procedures what we follow, but yes, the studies have come up and shown that there is absolutely no recurrence compared to an open or a laparoscopic repair, and open repair is much more preferred, especially in elderly. And there's a study that has shown as compared to lap endoscopic repairs. So what are the different literatures that say about it? What are the evidences saying? Go through any journal, go through any manual, go through the SAGES, we go through the hernia surge guidelines as we follow, the 18 or the 2022s. All are having a same conclusion, saying that there is absolutely no difference in recurrence as we compared laparoscopy to the open repair. We go through and all many other journals, even the Willy Online, the Lancets, they all have a very common interpretation that has come out of that yes, laparoscopic hernia repair has the advantage, but what is more appropriate when you are especially coming up as a surgeon, a young surgeon, open, because we have to see that no recurrence to happen. We follow the protocol. But after due training, under due supervision and guidance, yes, you can then go for a lap repair. Currently, the ultimate goal is the improved quality of life and the satisfaction level of the patients who undergo hernia surgeries. And there's been the current concepts that has been followed, and it has been well publicized over here. So it's a small TMC repair, which I tried to do in a emergency setup. It was a 75-year-old male patient, and I did the recommendation is not there for an open for the laparoscopic surgery. As you can see, the steps remain the same. I'm just continuing the tissue repair up, and you can see there's a big hernia that got obstructed up. And here I slightly used the amide level as well. I used all the techniques, thereby safeguarding and not to touch any of the regional nerves that are got involved, which can eventually lead up to a chronic groin pain, as I say, the Lichtenstein leads up to. Identifying each with all steps are same, that we identify each and everything. We identify the deep rings, the same method way. The sac was inversed. In the amide, as we inverse the sac, now we took running sutures going up to the deep inguinal ligament, up to the conjoint, and identifying everything absolutely in an atraumatic manner, thereby preventing each and every regional nerves. Yeah, I'll show. The mesh was placed exactly going into the inguinal ligament deeply, and I hooked it up. This is what the angle which was created. The fixation went continuously and double folded 2x3 choices as we do in the amide side. And the closure was done then. Thank you, and I bring greetings from Mansoor once again. And I all invite you to the India's biggest colorectal event to happen in the country next year. And we have tied up with the Southeast Asian Surgical Society, as well as with IRACAT, with the first time training live on pigs, where you can perform laparoscopic colorectal or the robotic surgeries and learn all about the staplers and everything. Thank you so much.
Thank you, Dr. Isan, for a very nice presentation. maybe we have one question from audience. Any question? So thank you. Thank you for your presentation. So next, I would like to invite Professor Kalpesh Zani to give his talk on peritoneal flap hernioplasty for loss of domain. Welcome, Dr. Kalpesh.
Thank you, Chairpersons. Nice to meet up with old friends coming after 1 year back to Nepal. I thank Dr. Romeo, Dr. Sunil, and all my friends here for this invitation. I bring greetings from Amasi. And Dr. Deboshi already mentioned, we welcome you all to AmasiCon 2026. It's going to be a big affair at Kolkata. So I'll talk about peritoneal flap hernioplasty. Ventral hernia open surgery is still the commonest thing that is performed for ventral hernia worldwide. And the gold standard is the rise stopa repair. But many times you can't, approximate the fascia in the midline and what to do then. Till now, the fallback used to be you do a sort of a bridging repair, which was not a very much recommended thing. So I have found this particular technique has really, changed the way I practice. So it's an interesting concept, and it's really, and you can do it with minimal resources. You can do it in any operation theater in the world with basic instruments. It was first published, or two teams that came across this concept almost simultaneously. One was from Scotland, Edinburgh, so it's known as the Edinburgh technique, Bruce Tullow and his colleagues. But they acknowledged that actually it's not, they had not invented it. Somebody else, they had already mentioned, described it. Da Silva in 1979, way back, had published a similar repair without using a mesh. They just added a mesh and developed the concept further. So they gave credit to Da Silva. At the same time, as I said, Peterson's team in Sweden, Malmo, Sweden, so it's also known as the Malmo technique or the Swedish technique, only a minor difference in which they would be closing the tissues. So we'll directly go to see how it's done. Now, when do you do it? It was developed for use in large ventral and incisional hernias where the facial defect is too wide for direct closure. You can't close it very safely, and then it's a sort of a way to get out of it. Obviously, when you are going to do it, you can't do it when there is presence. You need a peritoneal sac. It's known as the peritoneal sac technique or a hernial sac technique. And in such cases, when there's a laparostomy, there's no sac, you can't do it. If there's infection, you can't do it. So typically like this, you start off with skin marking. This is a wide defect, about 16 centimeter wide. So this is not going to come in the, I will not be able to approximate this as a midline. So pre-operatively itself, we start planning that you are going to do a peritoneal flap technique in this patient. So the first technique is raise the skin flaps. The original paper mentioned that you do not raise, you just raise the skin flaps till the edges of the defect. But then I found that, and we do a fair amount of these cases, I found that if you raise the skin flaps, it releases the tension a bit much more. So I raise a little wider skin flaps. Only thing is raising the skin flaps, you know that you have to remain right on the Cooper's fascia. If you enter into sub-Q, you'll damage the penetrating vessels, and that causes a lot of skin flap necrosis. So the technique of raising the skin flaps, it should be an absolutely avascular process. If there is any bleeding while you're raising the skin flaps, that means post-operatively you are going to land up with flap necrosis. Margins of the defect are identified. So that's the sac, hernia sac in the between. The entire peritoneal sac has to be preserved. So typically when you used to do open surgery, the first thing we would open up the hernia sac and excise the whole thing out. Now you have to preserve the entire hernia sac. If the skin scar is adherent to the hernia sac, you can even shave it off using a 15 knife and keep the hernia sac intact as much as possible, at least as much as possible. Sac is dissected away from the edges of the defect, and then you open up the sac in the midline. So this is there a pointer? Do we have a pointer? So this is how it looks. You open up the sac in the midline, so that's the A point, that's the hernia sac in the midline. The edges, then you make one cut B on the anterior surface of one rectus, and the other cut C will be on the posterior surface of the other rectus. And as you raise these flaps up, the C flap will go up, and that half AC, the peritoneal hernia sac, along with that little bit of a posterior rectus sheath on that AC will become the anterior layer now. Because as you raise it up, it will become anterior layer, while AB, will become the posterior layer. And now you'll have a very long flap where you can easily put a mesh in between and close the flap. So there is never any issue of not being able to close the tissues or keep the mesh away from the abdominal cavity. So this is how we make the cuts. Here the B cut has been made on the anterior surface of one rectus sheath, and the C cut has been made on the posterior surface of the one rectus. I'm holding the Babcocks are holding the rectus muscle. And for midline hernias, then you create the retrorectus plane on both the sides. So you get sufficient length there. And once you have, then you open up the peritoneal sac, since you already, for the posterior cut anyway, you have to open up the peritoneal. You do your normal adhesiolysis, whatever is there, reduce all the contents, get everything down. And you raise the flaps down. So as you can see, where we have put the cut on the A side, that flap has come down. Where we had put the cut on the posterior aspect, that flap has gone up. And you suture the posterior flap across to the lateral edge of that posterior flap to the edge of the incision on the posterior rectus sheath. So this has been sutured, and then you can put a wide, large mesh in that retrorectus space. And so this is this particular patient, I put about a 20 by 25 centimeter. You can cover up the entire abdomen very nicely. This is a normal polypropylene mesh. So again, low cost thing. And you cover it then with an anterior, suture the anterior flap across to the cut edge on the anterior rectus sheath. So this whole thing now, the mesh is completely extraperitoneal, and you've got complete coverage of the mesh ventrally also. It's not exposed to the skin and subcutaneous. So the mesh is completely covered. And then you do this is how it looks once you have closed the anterior sheath and posterior sheath both. Then you put for paramedian, you can also do it for paramedian hernias, but obviously for paramedian hernias, what happens, because the scar is, the hernia is right on the rectus muscle. So medially, you can only go up to the linea alba, while laterally only up to the linea semilunaris. So if required if you need more space to put a mesh, you have to do a crossover like we do for ETAP, same way you have to cross over towards the other rectus muscle side. And if you want to go laterally, you may have to do a TAR to enter into that plane to just put a large mesh. And the same thing you can do for lateral abdominal wall hernias. Now the issue with lateral abdominal wall hernias is that there are going to be 3 muscles there. And in which plane we put the mesh. So now we know very well that you cannot enter into the plane between the internal oblique and the transversus, because that has all the nerves for the recti muscle. So you will damage the nerves. So use the plane between the external oblique and the internal oblique muscle. The same principle, one cut on the anterior surface, one cut on the posterior surface. But when you're putting the cut on the anterior surface, it's okay. You are going to just cut the aponeurosis of the external oblique aponeurosis and enter into the plane between the muscle, external oblique, internal. But on the posterior side, you have to cut through 2 of these aponeurosis, the transversus and internal oblique, to enter into the plane between the internal oblique and external oblique muscles. What are the complications? These are Nielsen's. They had the largest. The Swedish people had the largest this thing, and they had a fairly good skin necrosis, superficial wound infections. As I said, that can be avoided if you do a good dissection in the correct plane. We always put a suction, negative suction Romovec drain in the subcu plane. After that, you can remove that after 48 to 72 hours and apply a pressure bandage post-operative. That will reduce your seroma formation and the fluid secretion and the wound infection. And fairly good enough. Recurrence was 1.3 in their series, 1.3%. And these are all complicated, very large hernias. So 1.3 is a very much an acceptable. And we have got a similar experience. It's been good, giving a very good this thing. And you can do even nowadays. Now we started off with initially where straightforward cases were there. Now we even started taking cases where we have last month only we did a case, this particular case, this had a Tanaka index of 28. Now you know when you have a Tanaka of 25 and above, that's a loss of domain. There's no way I'm going to be able to fit all those extra abdominal contents into the abdomen without raising the intra-abdominal pressure. And you can see the thickened, shortened recti muscle, which are both the lateral strap muscles are both quite wide apart. There's a huge gap of about 15 centimeters in between. So we decided to combine this with Botox. This is the, we do Botox about, this is the lateral margin between the, in the mid-axillary line, these 3 points we instill the Botox injection. So we take about 150 cc of Botox, 150 milligram of Botox, dilute it to 100 ml, and then 90, we put 50-50 on both the sides. You do it under, oh, the video is not running. Anyway, you have to do it yourself. This is me, I'm the surgeon who we put it yourself. So you should be knowing the sonography and how to see, differentiate the 3 muscle layers, and you have to instill at all the 3 points, you have to instill between all the 3, in the all the 3 muscles. So just, oh right, let's play. So you use a, keep a probe in one end and go ahead and just put it with the other, and here, this will show you nicely. You can see the needle coming through. I hope you can appreciate it. That's the needle coming through. You move the needle, you can see the 3 layers of the mother. That's external oblique, that's internal oblique, and there's transversus. I'm going right into the transversus first, then gradually withdrawing into, this is now into the internal oblique, and you keep on injecting the Botox into all the 3 points. Then you have to wait for 4 to 6 weeks. So Botox starts taking effect, and its maximum effect comes by 6 weeks, and then its effect starts wearing off. So you have to tell the patient before and that once you put Botox, it's an irreversible thing. You have to get operated between 5 to 6 weeks. So you then can't say, no, can we postpone the operation? So then you lose the effect of the Botox, right? And you can see what happened at the end of about 5 to 6 weeks. You can see the whole thing. You can see the lateral muscles, how stretched and thickened they are, and they are nicely stretched out. And the abdominal contents have already entered into the abdomen because the whole abdomen has become quite, lax and flabby. So this is the right time to operate these patients. And then we can do this exactly the same thing. We did a peritoneal flap technique and put a 25 by 30 centimeter mesh. There are people, of course, anything new comes, people are going to detract. And once there were, people started saying that you don't bring the recti in the midline. The recti are going to be wide apart, though you are covering the mesh. And skin flap necrosis was already raised. So this was a fantastic. Again, Nielsen themselves, they studied their own patients. They do the CT scan 6 months after the surgery. You can see at the time of surgery, the recti are wide apart. 6 months later, it was almost as if the entire recti had come in the midline. It was like a virgin plane. It was like a completely new linea alba form. And then, of course, that led to that. What caused this? And then other papers started coming, and they found that the hernia sac, it's not an inert. It's not a peritoneum. A peritoneum is just a single layer of mesothelial cells. A hernia sac, all those who are doing surgery, it's not a thin layer. It's a fairly thick layer. And then a paper came from Taiwan where they did those. They took biopsies of the hernia sac, and they found that it had a lot of mesenchymal cells, mesenchymal stem cells. And they used, it's a beautiful paper from Taiwan. It was published about 2 or 3 years back. You can just look up mesenchymal stem cells in hernia sac, and you'll pull that paper up. And they found that those mesenchymal stem cells of peritoneum could produce fibrin. The stem cells ex vivo, could produce fibrin, could produce chondrin, could even produce osteoblasts. So it was entirely new fibrosis, new linea alba, which was being created by that hernia sac, peritoneal sac that you are using to cover the, to create a new midline. So as I said, definitely those who are doing hernia surgery, this is one technique that one should always learn because it's a low-cost technique. You can do it in a routine operation theater with your routine instruments and using a plain, simple polypropylene mesh. Thank you so much.
Thank you, sir, for a wonderful presentation. And just a few comments on this. You miss a name, the Indian surgeon, Matapurkar. So he was next in, I think, 1990s. He published his series about the peritoneal flap hernioplasty.
Oh, okay.
And he got scolded with the person. So he published, after 10 years, he done a study on the rats about the peritoneal flap. So he excised the peritoneum and saw. So he proved that stem cell theory, I think around 1999.
Oh, that's great.
Yeah.
I'll try to look that up.
I think it's from New Delhi,
Okay.
India. That was one. Another is, it's a very wonderful technique to avoid the intra-abdominal hypertension, especially the context like us. Because if we see the large hernia, maybe sometime up to 10 to 20% require ICU admission.
Yeah.
Because we are worried about the intra-abdominal hypertension. So this is one of the wonderful technique, the peritoneal flap. We published the systemic review and meta-analysis on this here about 500 patients last year in the Journal of Hernia. Again, showing the same conclusion. Perfect technique. Just one question to you. What about the functional outcome? Because again, we are not opposing the two vectors.
Yeah. So again, in fact, the Scottish team had done they've recently published their functional outcomes. They said that initially for the first 3 months or so, there is some restricted movements. Then they did a dynamic MRI studies. 6 months down the line with the controls, it was exactly the same. They were matching. So as they showed with the CT scan that the entire rectus were coming in the midline. The whole thing was, it was like a neo-linea alba. They give the neo-linea alba being created. And they found that a functional MRI in all the positions, like pronation, getting up, sitting down, the lateral bands, all of them, as compared to the controls, there was no significant difference. So functional outcomes were great in the series.
Thank you, sir.
Now, we'll call upon Dr. Naveen Sharma on ventral laparoscopic transabdominal periperitoneal TAPP presentation.
Naveen Sharma. Yeah, this one. Let's label it as Dr. Naveen Sharma. Session 2. Session. Apologies for the delay. Yes, I got it. Pointer it. Chairpersons, friends, last year I was in Pokhara when I had delivered a talk on robotic surgery for doing a TAPP for ventral hernia repair. And then I realized that in Kathmandu, Nepal, there are very few robos. So I thought it will be more worthwhile and more interesting to talk about laparoscopy for the particular repair. Dr. Deborshi has already made my job a lot easier by telling you about all the newer techniques for ventral hernia repair. And I'd like to just talk only about TAPP because Dr. Deborshi has already told you why ETEP violates all the planes of incising the posterior rectus sheath at one place, sometimes two places on one side, and maybe on, if you include both the sides, if you're doing a TAR, you already cut that in 4 places and you might be getting some new hernias as a result of it. So if you stick to the preperitoneal plane, you're not cutting anything. You're not creating a problem which is perhaps the solution being worse than the initial problem. For a 2 centimeter hernia repair, if you go for a big surgery, perhaps you're not doing the best thing. We know this EHS classification, and TAPP works well for these small and medium primary hernias, and perhaps the W1, that is less than 4 centimeter of the incisional hernias. Beyond that, this technique doesn't do very well because the flap becomes a little too large for us to handle, at least from one side. And of all the layers in which we can place the mesh, I find the preperitoneal is the one which is least intrusive and destroys the least amount of tissues. So this is where we concentrate all our efforts on. This was not always so. In 2022, my colleagues had published this particular article describing our experience with the ventral hernia repairs. And at that point in time, even in our institution, the bulk of the surgeries were IPOMs and IPOM pluses. But we found a patient with an IPOM with a complication which was terrible, done outside, of course. And then that one patient changed the course of the department's thinking, and we tried to focus on preperitoneal repairs for these ventral hernias. So there was not much evidence till 2023, and then this meta-analysis came, which spoke about the fact that it was indeed much less painful as compared to an IPOM. And as compared to the ETEP approach, it took less operative time and lesser hospital stay. And definitely, you're not cutting across so many tissues and worried about destroying the linea alba and other problems. So this was actually a great thing. The blue lines represent our experience with laparoscopy and the red ones with the robotics. So initial learning curve, we agree. We spent most of our time doing robotics, understanding the planes. But at some point in time, the laparoscopic procedures started coming up more in numbers. This is my own series. And for the department, for this particular area, we have almost done about 60 laparoscopic ventrals. And I'm not the only one. The entire team seems to be happy with this procedure. Comparing TAP versus ETEP, very few papers comparing directly head-on. And one of them said that there's no difference in pain. But in that series, the TAP took a little more time. But the workload on the surgeon was less. And the other one said that there was no difference in pain or complications. However, ETEP took longer time. But we are not comparing apples to apples here. Usually, the patients who are going to be tackled with an ETEP would be larger hernias requiring larger meshes because that plane is far more robust. And the smaller ones tend to be done more using a TAPP. So points to take home if you want to do it. You have to keep the patient right on the edge of the table. You can't have him midway. That won't work out because your instruments will going to strike. And the hand has to be low. So desi jugaad is that you sling it with a simple bed sheet and it hangs low. Those fancy table attachments, they make it a little more low and that adds to the bulk where the instrument starts striking. So if you have the luxury of having two assistants, have them. So instead of the scrub nurse at the lower end, if you can get hold of another assistant when you're working superiorly, if the person below holds your camera, because the camera would need to change and it becomes very difficult for the person holding the camera to show from here upwards. So if you can have two assistants, works very nice. I like to be seated when I'm operating these cases. So these are key steps. Most are same for all laparoscopic surgery, so I won't dwell much upon this. The key thing and where people face challenges are the development of the peritoneal flap, because that's where you start creating holes. And once the holes start getting very, very messy, you give up the procedure and shift to an IPOM. So that's a great place to start. Instead of an IPOM, you go for a TAPP. If it doesn't work out well, your IPOM always remains a rescue procedure, if especially the peritoneum is looking good. So I'll show you two videos only, in which the peritoneal flap is going very beautifully, and one where we were struggling and how we rescued ourselves. That will be my intention over this. I won't be showing you how to close the defect or deploy the mesh because that's standard and it requires just simple suturing skills, which I'm sure most of the younger people have already. So here we go. So first thing is reducing any contents, and then about 5 centimeters away, I like to start the flap. If you can find this yellow fat, it's your friend, and that's a place where the thing is going to be much easier. Now, if you see some cobweb-like things attached to the anti-abdominal wall, the white things, you try to take them down. Look at the left hand also. It is holding the flap very, very widely. It's a big instrument. We are not holding the flap using a Merrill end. It's a big instrument, so the pressure is evenly distributed. Now you're trying to take the fascia transalis down from the posterior rectus sheath. Some amount of cautery would be required, but by and large, sweeping movement can sort it out. Some people also prefer to use a gauze for this particular thing. However, that's a little less controlled, and I prefer to do it simply with the hook. As Dr. Deboshi had already shown that volcano, which he did not like, and at some point in time, you'll try to dissect the sac away after having dissected some space, both superiorly and inferiorly. Now this is to be done delicately because we don't want to create too many peritoneal rents here, and that's easier in a primary hernia. When you're dealing with an incisional hernia, by and large, you will have to create a peritoneal hole which is big, and at the end, you'll just have to suture it back together. However, peritoneal rents are easy to manage once the peritoneal is lax. If it is tight, it tends to tear more. So this is just the hernia sac which is being dissected. Sometimes you'll have a hole out here if you are not able to dissect it out very well, and that hole can be easily sutured back. So once the sac is down, you'll have to go to the other side. And at this point in time, we have to be careful that we don't inadvertently create a peritoneal rent while dissecting on that side. So this dissection continues. In this particular patient, we also had right inguinal hernia, which we also dealt with in the same sitting with the same flap, with the same 3 ports. I will just show you that in a minute. So this dissection continues for about 5 centimeters more beyond the edge of the defect, and then we close it back together. See here, the peritoneum is thin at that point. So I'm showing you the right inguinal hernia, and we just used bariatric instruments in order to deal with this hernia right in the same sitting with the same port positions and everything. So we just have deployed 2 different meshes. So for a unilateral hernia, you can go opposite to the side of the hernia and do the same procedure if you have a unilateral with a midline ventral hernia. So that works perfectly fine. I think we're almost at the end of this. So this is the other one in which things did not go so well. So I'm on the other side of the hernia, I'm dissecting, and you'll notice that quickly the peritoneum is thin and I've got a peritoneal hole out here. Now I'm trying to go around the peritoneal hole, trying to take the fascia transversalis down, and I've got another peritoneal hole. Trying at some other place, again without success. So at such a point, it's not a crime to go above one layer, that you've got a TARM plane. If you cut the posterior rectus sheath at that point in time, you can always approach that place. So this was a hostile peritoneum, difficult. We had already done one side, on the other side. So at some point of time, I thought that these peritoneal holes will not be approximated easily if I don't release the tension on it. So I just cut the posterior rectus sheath away. And this is a very comfortable plane to work in. I myself admit that this is a much more easy plane to work in retrorectus, but you are cutting the posterior rectus sheath. And we don't know the consequences of that in the long term, especially if you're cutting at 2 different places while you're doing an E-tip. So that's more concern. So here it's a kind of opposite of a Carolina's crossover, that on one side you are pre-peritoneal, and on the other side you've just created a small 2-3 centimeter pocket, which is above the posterior rectus sheath. And so once you release this tension, it will make the closure of this defect a lot easier. So we'll show you that in a couple of minutes. So since that one side is robust and one side is peritoneum, which is very weak, a PDS 3.0 or a 4.0 works very well in this particular situation, instead of the V-lock kind of sutures, which tend to scrape, tend to tear the peritoneum. So a smooth suture, PDS, works pretty well. So peritoneal holes are the bugbear of a TAPP. So if we can prevent it, and if we can manage them, then the battle is won. And I'm sure a lot of people in the audience would agree that in this particular plane, you have not cut through anything which is bad, which you should not have cut. And for a 2 centimeter kind of a 4 centimeter kind of a hernia, I feel a E-tip or a TARM primarily is not the best procedure. So if you are able to reduce the tension, this works pretty well. It's just a completion of this procedure. Since we've got 3 minutes, I'll just complete this so that there's time for questions. Key thing is to take the tension away, not to try to be too adventurous, not to try to bridge the entire big hole try to take it in small bites. They say how to eat an elephant. You eat it one bite at a time. So this is the way you manage these peritoneal holes as well. You go slow, try to do what is manageable, and then at some point in time, it just comes together. When you're doing this, it's also a good idea to reduce the intraperitoneal pressure to about 6, and these things come very nicely together. There's no tension on the tissues. So this one study that the team had done, and if we took away all the confounding factors, we found that it was pretty similar in both the cases. In spite of this raw results showing that there's a lot of difference, as most studies tend to show, the difference was that in laparoscopy, people were using tackers, and in robotics, people were using suturing. So once we took away the confounders, the results were pretty much the same. And this is ongoing, in which the entire team is doing TAPP, and we are determining what are the risk factors, surgeon experience, patient factors, and we're trying to find out what are the factors for conversion. At this point in time, our team has a conversion rate of about 25%. Thank you so much.
We have some time to have 1 or 2 questions from the audience, please.
Wonderful presentation, Dr. Naveen. First of all, I would like to congratulate you. I am Professor Pahwa from Lucknow, KGMU, India. So one question and one comment I would like to highlight here. The one thing is important from our initial orators also. Now, if you go 30 years back, for hernia, it used to be my teachers only. Herniorrhaphy used to be the most common procedure. Then it came hernioplasty and Lichtenstein. Then we are having so many procedures. So now I think it is required for our youngsters, I will pass on this message, we need to learn these all procedures. Like they should be mastered in herniorrhaphy, they should be mastered in Lichtenstein, they should be mastered in TAPP and TP. Only then they can survive and sustain it. Because it is like patient choice and like case-to-case basis selection. So like for particular patient, what will be the ideal situation? The same in ventral hernia repair also. I would like to ask one question, like you mentioned about like you're doing TAPP. So initially you mentioned like in the cases which are small hernias with good peritoneal. So do you have any like scenario like you will screen with diagnostic laparoscopy and then you will say, okay, I am proceeding for this in TAPP and in rest of cases I will proceed with IPOM. Because we don't have very long-term studies, comparative studies. Although we are saying IPOM is also time-tested and tested procedure, and I think it is not outright we can reject it. It is still laparoscopically commonly performed procedure. So like in second case, as you said, you went in subrectal. So initially you can decide and you can go for IPOM. Like what we are doing sometimes, peritoneum is very hostile. It looks very thinned out. So it looks totally impossible to go for TAPP. So in select cases only we can go for TAPP. So what is your take in this?
So that's what our conversion at this point is about 25% with complete set of our residents as well as faculty doing this. So sometimes the peritoneum will be bad, sometimes the surgeon is going to be inexperienced, whatever. So what I say is when you're already doing just IPOMs, this is a great low failure way to start off your procedure. If you find that the peritoneum is very hostile, if you are not able to handle the peritoneum, you already have prepared the patient for an IPOM. Early on, your default rescue procedure might be an IPOM. When you're more experienced and you're more familiar with the planes, perhaps a retrorectus would be a better plane to go in because you're trying to avoid intraperitoneal mesh. I'm not so sure if intraperitoneal mesh is a good thing, whether it's on its last legs, whether it will survive 10 years or not. My take is these complications are coming. They're either coming to us or they're going to somebody else. But long-term meshes, 15 years or more, they are coming with complications. We are all experiencing them as case reports. We are just trying to be in denial that it causes nothing. Dr. Devarshi said about adhesions. There are problems related to sepsis. Meshes get infected for whatever reasons, instrument sterility or whatever reasons. Those meshes, once they get infected, they're pretty bad. And intraperitoneal, when things go wrong, bowel gets adherent, meshes migrate into bowel. There's a lot of problems that are happening. It's better to have some tissue between mesh and bowel, and I feel that peritoneum is pretty good. That is what nature intended, perhaps. Going for an E-tip for a 2 centimeter is something that I'm not happy offering to my patients. That's about our own comfort and our own judgment about this.
Thank you, Naveen.
Thank you so much, sir.
I think Siddhant Khare is here in the world. Dr. Siddhant Khare. Okay. I think he has not submitted his presentation. Anyway, he seems to be absent. And Dr. T. Shivakumar, he couldn't come because of some problem. So our next speaker will be Abhishek Malik.
This is yours. Presentation. Can this be also? Also, single. Presentation behind this. I think one also. Okay, another. ठीक है सर. Starting you. Start. Good afternoon, everyone. I'm Dr. Abhishek Malik. I will be presenting feasibility of TAP hernia repair at tertiary care centers, its challenges and opportunity. First of all, I would like to thank my co-author, Dr. Arvind Joshi, for providing this opportunity to present the paper, and SSN for providing this opportunity to present our paper at this forum. So introduction, minimal invasive hernia repairs are preferred in high-income countries where more than 70% of hernia repair are done laparoscopically. But in low-income countries, in context of Nepal, more than 60% of hernia repair is being done open due to technical challenges, affordability, and acceptance among the patient. We have evaluated feasibility, perioperative outcomes, and patient-reported satisfaction following TAP repair at our center to measure the feasibility of hernia. Study objectives of our study was assess feasibility of TAP hernia repair, and we measured complication rates, patient satisfaction, and perioperative outcomes, and we measured operative time, intraoperative complications, postoperative complications, and length of stay. And long-term outcomes were measured by recurrence and chronic groin pain. So our study was simple, retrospective descriptive study done at a single center, single surgical unit of BNB Hospital, Gwarko, Lalitpur. Our study population was all TAP hernia repair done by a single surgeon. All cases that were operated by lateral nerve surgery from May 2019 to April 2025 were enrolled in the study. We did telephonic follow-up after at least 6 months to all the patients, and with patients with suspicion of recurrence were followed up in person clinically. All the cases that had incomplete data, since this was a telephonic follow-up, whoever patients didn't pick up the phone or could not respond were excluded, and any patients that had follow-up less than 6 months were excluded. We screened total 84 patients in our study and excluded 18 patients. 12 of them had incomplete data, and 6 of them had follow-up less than 6 months. So total case analyzed was 66, and hernia we studied were 74. So coming to data collection and analysis, study performer was initially pilot tested in first 10 patients for validation of a study performer. Since we studied patient satisfaction that was not previously studied, we had to do pilot testing for validation. Data collection was done in Google Forms, and entry was done in Microsoft Excel. We used SPSS version 31 for data analysis. And tools, descriptive statistics expressed as mean plus minus standard deviation, or median range, interquartile range for continuous data, and frequency for categorical data and qualitative data. So for consistency and consistent outcome after the study, we have defined few things pre-study, that is recurrence, any bulge swelling observed at surgical site confirmed by examination. Chronic groin pain was defined as pain for more than 6 months at a surgical site requiring analgesics, and feasibility was defined as lesser complication and higher acceptance. So ethical consideration, consent was taken from each patient. Most of them were verbal. IRC approval was taken from IRC of BNB hospital. So these images shows that one of our cases that had direct hernia. The upper right image shows the mesh placement, and lower shows how the peritoneal closure in tap repair. So coming to the study results. So total number of patients we studied were 66. As usual with hernia, most of the patients were male and only 2 patients were female. And total number of hernia studied were 74. Among them, 73 was inguinal and 1 was incisional hernia at the, in inguinal region. Among the inguinal hernia studied, 57 were unilateral and 8 were bilaterals. Surgical approach, almost 94% of patients were laparoscopically operated and 6% were robotically operated. So we were the first in Nepal to do robotic tap repair. Demographic details, age in years. So mean age of our study was 50 years, ranging from 15 to 78 years in patient. Most of the patients were in 50 to 60 years, and most of the patients' occupation was 30, and salaried about 50% of patients were salaried. So since our hospital is a corporate setup, so most of the patients were from business and salary background. Coming to clinical details, total BMI, mean BMI of our patients were 24.8. Most of the patients had normal BMI and a few patients were overweight. Coming to ASA category, most of the patients were ASA 1, and that is 71.2 of the patients. ASA 2 were 28.8%. And so in 31.8% of patients had history of smoking, whereas 69.69% of patients had history of alcohol use. Coming to hernia characteristics, most of the patients were indirect, that is 69.21%, and direct were 24.32%. Contents were, most of the patients had omentum as content, and bowel was in 5.4%, both bowel and omentum was in 13.5%, and none of the patients, non-content was in 35%. Most of them had, the content was already reduced when, during the creation of pneumoperitoneum. So almost 94% of patients had reducible hernia, and only 5.4% had irreducible hernia pre-operatively. So size of hernia defect, most of the patients had medium-sized hernia, that is 3 to 5 centimeters, and 32% of patients had a small hernia, and only 11% of patients had large hernias. Coming to operative details, mean operative time was 89 minutes, median operative time was 75 minutes. That ranged from 44 minutes to 270 minutes. 270 minutes was for our first robotic case. But most of the cases were operated within 50 to 100 minutes. Intraoperative, we didn't encounter any major intraoperative complications. Minor bleeding was noticed in 6 patients, that is 8.1%. We didn't encounter any, we didn't converted to open. We had no nerve injuries, bowel, or reported bladder injuries. Coming to immediate post-operative complications. Post-operative complication was Clavin 1 classification were 13, total 19.6% of patient, whereas Clavin 3 n equals to 3, 4.5% of patient. And the complications that were reported were seroma formation in 15 patients, urine retention in 3 patients, intractable pain in 1 patient, infected seroma in 1 patient, and port site, there were no reported complication of port site wound infection or hematomas. So management of post-operative complications, seroma Clavin 1, 13 was there. Most of the patients were managed conservatively with scrotal support and Urine retention, Clavin 3A, managed with alpha blockers, catheterization, they required catheterization and were discharged with catheter. Infected seroma, Clavin 3A, this case was interesting. He had urine retention that required catheterization, with also he had infected seroma that required multiple aspirations and antibiotics, but he didn't require reoperation or explantation of MIS. So coming to post-operative outcomes, our mean length of stay was 2 days. That ranged from 1 to 3 days. Most of the patients were discharged on 2 days, and most of the patients returned to activity within 2 weeks. Median time of returning to activity was 7 days. That ranged from 5 to 14, and only 8 of the patients required more than 2 weeks to return to activity. So this was our additional study that additional point that we studied in this in our study. So there was patient satisfaction that was not previously studied among the hernia patients. So counseling, the most of mean was 3.9, but most of the patients were satisfied with the counseling, preoperative counseling. They 3.8 mean in about hospital stay. They were satisfied with the hospital stay. They were most of the patients were also satisfied with the pain control in postoperative period, and most of the patients were satisfied with the recovery and also returned to activity. 98% of patient was satisfied, and only 1% was not satisfied. That is, the satisfaction was measured by whether they will recommend this surgery to others or not. Only 1% who had recurrence. So coming to long-term outcomes, there was recurrence in one of the patients, that is 1.3% of all. There was swelling in inguinal region that came around only 2 to 3 months after surgery. He was advised for retap, but patient didn't opt for reoperation and lost to follow-up. Chronic groin pain was seen in 2 patients, that is 2.6% of total patients, and that was responsive to medication, and no additional intervention was required for this patient. There were no cases of reoperation or port site hernia. So coming to discussion, so median operative time of our study was 75 minutes. That is in coherence with Zanik M. et al. That was done, published in EHS 2025. This is a learning curve analysis that showed median operative time of 70 minutes. Also similarly, Basukala S. et al. Published in Health Science Republic. That was comparable. That median operative time they published was 81 minutes. And single surgeon, this is a single surgeon study, hence that the operative time was steady to around 80 minutes after 20 cases. Intraoperative complications of minor bleeding was less than 50 ml in 6 patients. That was similarly, Saini et al. Also published that there was no major intraoperative complications, but they required 2 open assistants in 3 cases for sac reduction. In our cases, we didn't find any this sort of complications. Khanal B et al. Published in Annals of Medical Surgery, injury to epigastric vessels and bowel injuries. So a study, but their study population was complicated hernia, so it cannot be compared to our study. Discussion, early postoperative complication rates, that is total overall postoperative complication was 24.24%. Seroma was in 22% of patients. Egawa et al. Showed published similar results of overall 34% of complications and seroma in 19% of patients. Basukala et al. Similarly published 23% of complication in overall complication and seroma formation in 11%. This is comparable to all other studies. So patient satisfaction, no comparable data was available. As previously mentioned, all but 1 patient was satisfied with this surgery. Unsatisfied patient had recurrence. So coming to recurrence, 1.35%. Meta-analysis done by Gopal et al. Was 1% to 43%, similar, comparable to our study. And Basukala et al. Also published 3% recurrence. So incidence of chronic groin pain was 2.6% in our study. That was coherent with Singh et al. Meta-analysis done by Singh et al. And chronic groin, they have reported 4.69% of chronic groin pain. Other studies also have shown similar results. To conclude our paper, so we can say that TAP is feasible, safe and effective in tertiary care settings in Nepal. Higher complication rates, that is 24%, may present as major challenge for implementing TAP repair, but prospective study would be more suggested of whether it is feasible or not. Low recurrence rate, that is 1.3%, that is comparable to global data, and high satisfaction rate, that is 98% among patients, provide opportunity to promote TAP hernia repair. So limitations is, so since we have included cases from 6 years, there is recall bias. This is a single surgeon study, so single surgeon bias will always be there, and no control group for comparison in our study. So these are my disclosures, references. Thank you.
Thank you for a very nice presentation. So it was a retrospectively collected data.
Yes, sir.
Yes. So one question to you: how you close the peritoneum? You use VLOC or just?
We use VLOC, sir.
VLOC.
VLOC. Barb suture by not exactly VLOC, but we use Barb sutures.
You mentioned near about 12% of your study population have big hernia. So which classification system you applied here?
So we have not implied EHS classification in this, that is more than 3 centimeter. We have just measured that more than 5 centimeter, we have defined it as big hernias.
So what you have done?
Not a standard, we have not a standard, we have not followed a standard classification.
No. So what you have done to that 5 centimeter defect?
So we have not closed the defect, we have put preperitoneal mesh only.
Just put a mesh?
Yes, sir.
So just a quick comment on the 2 paper which you mentioned, that is from my unit. So one study population, the Khanal is a Bhavani. So that population was acute groin hernia. We
Yes, sir.
done lab repair in the emergency setting. So that is only, I mean, in our unit, what we do is TEP, total extraperitoneal repair. TAPP in our unit is only for, we preserve for, one is emergency, second is recurrent hernia, third we do for large scrotal hernia, either S1 plus minus S2. So that is our algorithm for this sort of scenario. So the data which you showed about the bowel injury and inferior epigastric injury, that we done, I mean, there was 1 bowel injury and 3 inferior epigastric injury, which was tackled. That was in the emergency scenario. Another paper which you mentioned, the timing of the surgery by Basukala, again, is the same. The 81 minutes is slightly higher for, I mean, if you see the unilateral hernia, but again, it's for complicated patient. So the message is we need to know the both surgery, TAPP, TAP, and even open also. As patient required, we should able to offer them all 3 procedures.
Sir, currently we are offering only open and TAP repair. In TAP, we are offering both robotic or laparoscopy. We are not doing TAP at our center because of our early experience. Initially, we used to do both, but we have stopped doing because of technical reasons only. Otherwise, I have studied that coming to year, we did, compared to your study, we have done only the easier cases, I will say. We have not done most of the complicated cases, and we are doing complicated cases, we are currently doing only open surgeries.
Thank you. Any question from floor?
One more speaker.
So in our center in Bir Hospital, we have studied about 2,000 cases of tape and tap. In our, while preoperative diagnosis was inguinal hernia, either direct or indirect, 15% of our patients also had obturator and femoral hernia. So in your study, what percentage of your patients had either other groin hernia, obturator or femoral hernia?
So we didn't have any of the obturator. In our study, there was only direct or indirect, and we didn't encounter any such. About that 15% is quite high to come, but we had only, most of the patients were only direct and indirect only. All of the cases that we studied were that most. Only one was incisional hernia, that was different from other study. We usually don't do TAP for incisional.
Thank you, Dr. Abhishek.
Thanks, sir.
So we move on to the last presentation of this session by Dr. Ajay Kumar Pal. He'll be speaking on a prospective study to compare the operative and quality of life outcomes of hernioplasty versus herniorrhaphy for complicated primary ventral hernias in emergency settings.
This year, sir? First of all, thanks to the organizing team for inviting me to present my topic on comparison of perioperative and quality of life outcomes on hernioplasty versus herniorrhaphy for complicated primary ventral hernia in emergency settings. I come from King George Medical University, which is a 4,500 bedded hospital, and we receive a lot of emergency patients coming with ventral hernias. So there is no conflict of interest from my side. So coming onto the topic, the ventral hernia, 15 to 18% of the patients are of the ventral hernia done globally among the hernias, and the 20 million hernia operations are performed yearly worldwide. So complicated hernias present in surgical emergency have a 7 to 15% of incidence. In the traditional approach, the herniorrhaphy is the standard of care in contaminated settings. So in the primary hernia or in emergency setting, we prefer herniorrhaphy usually, but of late in the last decade, the use of hernioplasty has come even in the complicated settings. So, but there are limited prospective studies still, especially in the developing countries. Our aim was, primary objective was to compare the perioperative outcomes and also using the Clavin-Dinto scores. And on secondary objectives, we evaluated quality of life outcomes using non-disease specific, which is general score, which is 36. Another one is hernia specific scores, hernia Hercules and the Caroline Comfort scales, which is specific to the use of mesh in hernias. Pain assessment we used by VAS scoring, which is visual analog scale. So after institutional ethical approval, the study was approved for a 2-year duration, and it was a prospective interventional comparative study. It was non-randomized because of the emergency nature of the setting. And we collected a sample of 58 patients in these 2 years of complicated primary ventral hernias. And the two groups were, group A was patients done with herniorrhaphy, and group B was hernioplasty. So in the patients were adult patients with complicated ventral hernias and treated by these two procedures. The patients who were on corticosteroids, who were immunocompromised and were not giving consent for the procedure, were excluded from the study. So procedure was in the group A herniorrhaphy, the Prolene number 1 or 10 suture was used in a tension-free manner to repair the fascia. After the dissection of the facial planes, the hernial sac was not incised at the start. It was only incised after the dissection from the skin and the subcutaneous tissue, and we evaluated that whether there is any viable or non-viable contents are there or not. And then the wound layers were closed with the skin with the help of nylon 20. In the hernioplasty, the polypropylene mesh only was used, and it was either sublay or only fashion, depending on the contamination level. If the contamination level is, we find that there is a contamination level, there is chance that toxic fluid is there in the tissues, we place the mesh separating from the in a sublay manner, and the mesh was fixed with the help of non-absorbable sutures, and at least 3 to 5 centimeter of overlap, mesh overlap over the defect size was done. So in that, the total 58 patients, in the first group there were 27 patients, in the group B was 31 patients. So mean age of the patient was 49 years. In the herniorrhaphy group was 53 years. So mean BMI in the hernioplasty group was 27, and in the herniorrhaphy was 26, which is also comparable. So we can say that the results that we found were comparable. So in the among the duration, there was no significant difference in the surgery duration was found, and the p-value was not significant. And the comparable mean pain scores also were there with a p-value of 0.63. Coming on to the surgical site infections or the complications that we found. In hernioplasty, on the day 7, 3, 7, 14, and 21, 8% patient had surgical site infection, which was basically limited to the subcutaneous tissues, and it was managed by the help of IV antibiotics. and it was only in the up to Clavin-Dindo 2. In the herniorrhaphy group was also comparable, the infection rate, but the seroma formation rate, which was comparatively more in the hernioplasty group as compared to the herniorrhaphy group, which was having a significant value. We also evaluated the surgical satisfaction scores, which was basically done for the comfort of the surgeons, but not more for the procedures done through the laparoscopic route, which was also part of our hernioplasty group. Some procedures were done by laparoscopic route in the emergency setting also. In the quality of life outcomes, there was also no significant difference was found, but in the recurrence, there was no recurrence in each of the groups. Coming on to the site of hernias, we found that the commonly complicated primary ventral hernias were in the region of umbilical or infraumbilical or supraumbilical region, and rest of them were epigastric, lumbar, or hypogastric regions. The patients in the two groups were in the complicated hernia settings were more of irreducible and obstructed nature, and very few cases, 2 cases of strangulated hernias which we operated. According to the EHS classification, the majority of the patients were MW1 and MW2, and there were 2 cases of lateral hernias were also. And the type of surgeries we did was the open and laparoscopic, more in the herniorrhaphy patients, and for single patients of laparoscopic, the patient was not willing to go for mesh repair, so we performed only on the dissection and then performed the herniorrhaphy assisted by the laparoscopy. And in the 12 patients, we operated by laparoscopy in the hernioplasty group. The complications in the Clavin-Dindo G1 and G2 groups, the complications were a little bit more on the herniorrhaphy side, especially considering the majority of the obstructed patients were there also on the herniorrhaphy group. This could be a source of bias in our part, which is a limitation of our study. And coming on to the quality of life scores, which is SF36, the limitations were comparable in each group 1 and group 2, and there was at the end of the day, it was the p-value was not significant. The surgical site infections were also comparable, and the Hercules chart also reveals that both the study group had similar and Hercules, which is all of these instruments are validated instruments for comparing quality of life outcomes. The earlier studies that have been done in 2000 by Lejening and Berger, they favored mesh repairs for lower recurrence rate, but the setting was elective in nature, and our study focusing on the emergency cases and utilization of quality of life scores is one of the few studies from this part of the world to evaluate quality of life in primary ventral hernia repairs in complicated settings. And definitely it can be said that though the operating time can be in the range of 15 to 20 minutes higher in the hernioplasty group, but p-value not being significant, but rest of the complications and other things are comparable, and they are similar, aligning with the previous findings. Post-operative pain was also a little bit higher on the hernioplasty side, but it was also comparable, not significantly deranged. The recurrences were not, though the recurrences were not there on the 6 months period, but longer time period is required to evaluate recurrences. So it may be up to 5 years or 10 years. Follow-up will reveal the true nature, whether this in an emergency complicated hernia setting, whether the herniorrhaphy is itself sufficient enough for preventing recurrences. And the better quality of life outcomes achieved after hernioplasty is also an added advantage for an herniorrhaphy procedure, and the long-term outcomes will also be evaluated further. So, well, limitation is single center design, smaller sample size, and limited follow-up of 6 months only, but the use of mesh repair can be safely performed in an emergency complicated hernia setting. Recent guidelines, though, especially started with the use of prophylactic mesh repair in an emergency setting, and maybe at the time of stoma closures. This also prompted us to perform this study, so why not we cannot do in a complicated hernia setting also. So overall, this functional outcomes and quality of life outcomes can be safely preserved, and the curve through which it is going, that probably longer term outcomes will also be favoring use of hernioplasty. So our key findings are with the significantly shorter with the hernioplasty, the hospitality was shorter. We had got a lower complication grade overall with the use of hernioplasty. The quality of life outcomes were comparable, and especially the Carolina Comfort Scale was better in the use of mesh by hernioplasty. The outcomes are initially higher in the hernioplasty, but at the end of 6 months or 3 months, the outcomes are comparable. And though our study has a limited sample size, but we haven't found any recurrence yet. But longer term outcome studies are required for commenting upon the recurrence. So in conclusion, hernioplasty is safe even in an emergency complicated hernia setting. Longer term functional outcomes and quality of life outcomes have a role to play. And though the judicious use of mesh and contemplated emergency settings are there, there may be a lot of peritoneal contamination, there may be pus inside the peritoneal cavity. This actually is basically the mesh should not be used. Classical guidelines say that, but it is also being researched upon day and day whether we can use mesh even in those settings. Thank you. These are my references. Thank you. Thank you very much.
Thank you, Ajay. It's a wonderful paper, no doubt, and having a very good result, and no complication, no recurrence. That's a beautiful thing. Before I will open for the floor, two things I will just tell it. We are talking all the time the urban hernias. We never urban hernias. We are not dealt with rural hernias at all. All these facilities are not available in the rural area. That's why we must touch somewhere about the rural service of hernias, because we do a lot of hernias in the rural areas.
Yes, rural hernias is also do also require training of the surgeons, use of laparoscopy if available.
If not available, then we have to do open.
Then the abdomen has to be trained in laparoscopy, open hernia.
That's why I said we must touch when you talk of the hernias, you must, I think, keep in mind that there are a lot of people who are having hernia in the rural areas. First thing. Second thing, I was wondering if the types of hernia, which operation is suitable for that without any complications or less complication or something like that. Will that AI will help it if you feed up all the data to the AI, and he will tell us which hernia and which surgeries will be better for that?
So based on the Professor Jani was saying, Dr. Jani was saying that AI can help us in individualized treatment of patients. If we have got all the data available from all the studies we put into the AI, probably these models are already there. The Western people are also using it. And we also have to develop our country specific or our region specific AI models. So because our patients are a little bit different from the Western populations. So they have got a high muscular index, maybe their fat content is or BMI is different. So in that case, AI will be help us to delineate which patient will require hernioplasty, which patient can refi may suffice, or also will help us in delineating the various layers, the kind of defect, three-dimensional configurations, and put in the mesh. I've also developed a model in which I am also developing in which the CT images, 3D images we take out, and for individual patients, what is the exact size of the mesh, whether we want to use a heavy mesh or a low weight mesh, or what kind of pliability or tissue pliability is there to compensate for the extent of cuff, extent of exertion, extent of weight lifting, all.
That's true. I think what you said, Rakesh, AI will help us that to tell us.
Definitely, sir. Just the very nice presentation. Very nice presentation. Just a quick comment about this. I mean, adding the laparoscopic in this scenario in the MIS, if patient is feasible, we done published just systemic review and meta-analysis not in the ventral, but it's a groin hernia. Very significant finding of that study was a significant reduction in the bowel resection, because that is one part of causing most morbidity and mortality in this scenario. And definitely, if the bowel resection is less, then chances of adding mesh in that patient is very high. That is one. Another, a quick comment about your study is a very nice study, but follow-up is very short. 6 months, we cannot say whether the patient recur or not recur. Because hernia of this size, if this suture repair, definitely they will come someday to some of you. Thank you. Thank you very much.
Thank you so much.
Thank you very much. So thanking all the speakers, wonderful speakers. So the session ends here and there will be next session coming up. Thank you very much. Thank you very much, all the members.
Thank you, sir, and thank you to all the presenters. Before we move on to the next session, I would like to remind you that the certificates and the mementos are kept outside. There's a station situated there. I request all the presenters to kindly receive your tokens as well as certificate, and the chairpersons will get the certificates only. Thank you. Now, we will proceed with the third session, that is the pancreas session. I request our chairpersons, Dr. Chitralal Bhattachan, to kindly come forward and assume the stage. Dr. London Lucian, Dr. Avanish Kumar, Dr. Prasann Bir Singh Kansakar, and Dr. Kalpesh Chani. Now, I'd like to remind all the presenters that you are allotted 15 minutes for the entire duration, and you will get a warning bell 2 minutes prior. Thank you.
Okay, thank you everybody. Welcome to the session 3 this afternoon, which is on pancreas. It's a pancreas session. So we have our first speaker, Dr. Ramesh Singh Bandari, who's going to speak to us about the quest for the best pancreatic enteric anastomosis after a Whipple's operation. So Ramesh, thank you, and please take the floor.
Ramesh.
Thank you, Chairpersons. Good afternoon, everyone. And I'll be speaking on the pancreatico-enteric anastomosis following pancreaticoduodenectomy. I'm here to justify that we're still in the quest for the best technique of pancreatico-enteric anastomosis. So after pancreaticoduodenectomy, we have two options to connect the pancreas to create the continuity, either connect it with the jejunum or with the stomach. But despite so much improvement in the perioperative care and our surgical skills, the postoperative pancreatic fistula still remains one of the most important concerns because it increases morbidity and mortality. This very big systemic meta-analysis was published in 2021, which looked into 160 randomized controlled trials of more than 17,000 patients. And it showed the benchmark values of 2% mortality with 53% overall morbidity. I think it's still very high, and the POPF rate was around 14%. There's a lot of debates, PJ or PG, and within PJ, whether it's invagination, different types of invagination, donking, or ductal mucosa techniques. There has been ongoing conflicts and debates, and you keep seeing frequently these, discussion and literature looking into comparison between these various procedures. But having said this, I think we're still to find the best possible technique of pancreatico-enteric anastomosis. If you see invagination or techniques, a proper donking technique have been described. Besides that, there are almost more than a dozen of these various donking and invagination technique has been defined. And also regarding the ductal mucosa types, if you can search, and you will find more than 12, 13 different techniques. And among them, I think these are what I have listed out are one of the most common techniques of pancreatico-enteric anastomosis. It says ductal mucosa type. So this ductal mucosa is also combined with sometimes invagination as well. And one of the common ones these days people perform around the world are either Heidelberg, modified Heidelberg, Blumgart, or modified Blumgart techniques. But having so many options with that, I think we are still confused. What is the best then? Which one would be the best technique to create the continuity between the remnant pancreas and the intestine? Let's see what about the evidence, what the evidence says about PJ versus PG. Now, if you look into the literature and the evidence, plenty of randomized controlled trials and a lot of these meta-analysis and systematic reviews. Although many systematic reviews, they include the same studies once and again. Now, if you go through these systematic reviews, I think there will be slight inclination toward the pancreaticogastrostomy preference over pancreaticojejunostomy. But having said this, meta-analysis by Claire vs. M in 2014, they looked into 7 randomized controlled trials, and they came up with that you cannot so strongly say that PG is better than PJ. It's because I think there is a lot of heterogeneity among these the patients' population in these groups, so it's very difficult to compare the outcome in these various randomized controlled trials. RECOPANC trial, I think many of you, those who are doing pancreatic resections, would have heard about this. One of a very good randomized trial, very intention to treat analysis was done, more than 440 patients. It looked into specifically, it's a multicentric randomized trial, a very popular trial, and looked into PG or PJ. And what it found was there was no difference in terms of the POPF rate. In fact, there was high PPS in patients who had undergone pancreaticogastrostomy. Those who advocate pancreaticogastrostomy, I think the explanation is that the stomach is close to the pancreas, stomach has good blood supply, so anastomosis heals properly. There's less activation of pancreatic enzymes, so less chance of developing POPF. Also, the absence of bile also helps a little bit to reducing the fistula rate. And whenever there's bleed, you can detect early via nasogastric tube. But having said this, even this study, which did the study based on these factors, it failed to demonstrate the difference between these fistula rate, as you can see. And again, this study also revealed high GI bleed in patients who had pancreaticogastrostomy. But what was found that if you compare pancreaticojejunostomy high-risk group with PEG, in that subset group, actually, the PG was more beneficial in terms of reducing fistula rate. So it seems that in a selected high-risk patients, pancreaticogastrostomy could be a better choice. Now next, among different types of pancreaticojejunostomy. In 2009, one Chinese surgeon came up with his own experience of more than 100 patients, total 119 patients, and he compared Dunkin with 2 different types of ductal mucosa, but he failed to demonstrate any technique is better. What he stressed upon is the fact that the successful management of pancreatic anastomosis actually depends upon the meticulous surgical technique and the experience rather than the type of the technique. Now, I went through so many these systematic reviews and randomized trials. You can see, you can find on literature, and it's very conflicting results. But most of these systematic reviews, they have shown us that there is no difference whether you do Dunkin or any kind of ductal mucosa techniques. Some of the initial randomized trial actually showed the invagination techniques was better than the ductal mucosa. However, in later period, if you see, there is not much difference between any of these techniques. In 2016, ISGPS came up with their position statement regarding which type of the anastomosis should be preferred. They have labeled pancreaticojejunostomy ductal mucosa type, they have recommended, but it's also based on only moderate agreement. As you can see, this was just based on the moderate. That means they cannot even strongly recommend that PG is better, the ductal mucosa is better than the invagination or the Dunkin techniques. But recently, this Blumgart techniques has been taking over. There's a lot of talk about this. The one study from this Italian study, 224 patients, they compared Blumgart anastomosis with ductal mucosa with other type of anastomosis. They could not demonstrate the difference between fistula rate, but what they demonstrated was the rate of severe complication was significantly reduced. Following this one meta-analysis back in 2020, published in Nature Research 2020, this also showed, this meta-analysis also could tell us that the Blumgart anastomosis actually is helpful in terms of decreasing the fistula, clinically significant fistula rates. One interesting study was published, it's a single surgeon preference from China. You all must have heard about Peng, Mr. Peng, 150 consecutive patients with 0 fistula rate. It was very interesting. I don't think anybody else has ever produced this result. So I don't think anybody is still following his footsteps. It's very rare to have no fistula at all. Nobody else ever reproduced these results. And there is some concern. I always add bronze to all my pancreatic enteric anastomosis. And definitely there has been some evidence that it reduces the delayed gastric emptying. But in terms of reducing POPF, there is not much significant the evidence to say that, but I found some, to support myself, I found some of these randomized trials, comparative study actually, not very big numbers, that even pancreatic POPF rate can be reduced by adding these Brown's anastomosis. So what I'm doing, my journey of pancreatic duodenectomy is, I had been doing continuous Donkin pancreatic duodenostomy. Then I shifted to doing modified Blumgart Dr. Mucosa. Then I'm very confused on whether to do Donkin or Dr. Mucosa. I'll share this journey with you all. I always had Browns, and I used to be very dogmatic about octreotide use. Now I'm being very selective. So in the last 13 years, 167 PDs I have been able to perform. So first 104, I was very clear, all patients had Donkin. Then I moved to DTM. I will share why I moved to DTM. Now I'm confused between DTM and then this Donkin technique. In the last 3 years, I think I've been included among the high volume pancreatic surgeons in terms of pancreatic duodenectomies. So the first continuous Donkin technique I learned during my training in Australia and Melbourne in 2010 at Alfred Hospital. So this technique was actually devised by Stephen Wigmore. I think every pancreatic surgeon must have heard about him. This is a continuous Donkin techniques where the pancreatic remnant is dissected, 4-5 centimeters of the stump is mobilized clearly, and then we take these stitches in superior and inferior aspects, and the jejunal end is prepared, and the two ends are brought close together, and we do take a posterior continuous suture, at least in the pancreatic side, 3 to 4 centimeters away from the pancreatic jejunal end. And then once we do that, the stump is pulled in, and with the help of these stay sutures, the pancreas, 3 to 4 centimeter pancreas is completely down. So at the end of the procedure, this whole Donkin procedure looks like this. So whole of the pancreas is done. So we published our 100 patients with Donkin pancreatic duodenostomy, and we published our results. And what we found was, I think ampullary is one of the common indications for us, and that's why majority of our patients had soft pancreatic texture. In terms of POPF, the clinically significant POPF was 23%, PPS was 21%, mortality was 11%. So it just looked a little bit high. And I compared my results with the others published. In terms of POPF, CR, POPF, clinically relevant POPF, I think it's quite similar, 23%, and it's been varying between 13 to 28%. So not too bad. But what I realized was the PPS rate was quite high, 21% in comparison to the standard values that I looked in the literature. And at the same time, my colleague, Professor Polishna Joshi-Lake, she used to do the same way I used to do this Donkin technique, but she later on moved to Blumgart. I don't know what made her move to Blumgart technique. And she compared her initial 25 patients of Blumgart with this Donkin technique. And she was able to demonstrate a very good, clear results here. In this modified Blumgart techniques, the POPF was 8%, completely less than 50% reduction, 0% PPS rate, 0% mortality. So I was confused. Now, what I'm doing, I think I'm doing wrong. So in that case, I also have to move on to the same technique. So then I started doing the modified Blumgart technique. So how we do it is, and I've copied the picture from her article, but these videos are all mine. So it's basically 2 transpancreatic U stitches, which goes through the pancreas, through the jejunum, comes back and comes back again into the pancreas. So above the duct, I think superior part and inferior part of the duct, at least 2 U stitches we take. I don't know if it's clear or not there. So that's a U stitch. Once we take 2 stitches, so we pull the pancreas and jejunum together, and then make a small opening to create the ductal mucosa anastomosis. It's interrupted. We usually take at least 4 stitches posteriorly and 4 stitches anteriorly. And stenting, not regularly. In some patients, I do stenting if it's too small, but not on all the patients. And so I complete posterior stitch, then the anterior ductal mucosa stitch. And then finally, the U stitch is completed. And the whole of the pancreas is connected with the jejunum. And there is slightly invagination because of this U stitch. The pancreas is invaginated a little bit into the jejunum. So this is how we do, and we've been doing in our department, both our units in Department of Surgical Gastroenterology, UTS. But interestingly, and then I compared these first 32 Dr. Mucosa, and my results are same. I've been not able to, either improve or change in terms of POPF rate and the development of PPS actually, and in comparison to the results from my colleague, although the mortality was reduced by 50%. So now here comes that I was very confused. Now what is wrong going on? Why I'm not being able to reduce this clinical significant POPF and PPS rate? Then I looked into the literature benchmark values. I think at least it's good that these values are not too bad in comparison to these benchmark values. If you see these benchmark values that has been published, the morbidity is still as high as 73%, and your clinical significant fistula, if it's around 20%, it's fine. And severe complications, around 30%, the mortality should be around 9 to 10%. So if your results are hovering around this, I think it should be okay for all of us. So that's what I found in this journey of my pancreatic duodenectomies. So with this, I would like to end that I think all of our efforts should make sure that our outcome values should match with benchmark values. And we should improve our surgical skills and perioperative care. And despite this improvement, if our results are not improving, so I think we should continue our quest to find the best technique of pancreatic enteric anastomosis. And I can still confidently tell you that there is still no best technique or single technique of pancreatic enteric anastomosis. The quest still continues, but we should make sure that we, put on our full efforts with the best surgical techniques and the best perioperative care for the best benefit of our patients. That's it. I'm very happy to take the questions from everyone. And this photo is So this is one of the last weeks, my solo concert in one of the world's top 50 clubs. So more than 1,000 participants. I think I became the first surgeon to perform such a big solo concert in a public forum. Thank you all.
Thanks, Ramesh, for a very nice lecture. I thought you'd be singing for us today, but
Thank you, sir. Thank you.
So I think you brought up an interesting question about which is the best technique for doing anastomosis after pancreatic duodenectomy. And I don't think there's a clear answer yet. Maybe just a quick poll for the audience. Those of you who do a pancreatic duodenectomy, how many do a PG? Those who do PGs? You stopped. So I used to do a PG too. I've changed also. PJ?
All PJs.
All PJs. Okay. But I think that the question that you have raised about you discovering different things along the way is an important one to understand in all surgical procedures. There's no ideal technique unless you perfect your own technique, and you must find your own way of doing it well.
Exactly.
And that's the main answer behind how you would try and solve problems. And there are final points to it. So I think that was the key message you're trying to share with us.
Correct.
I do appreciate that comment. Any questions from the audience that you want to ask Ramesh before he steps down from the stage and sings to us later on? Anybody, any pressing questions? I know you're on a tight timeline, so I'm going to keep it very short. If not, thank you very much, Ramesh.
Thank you so much. Thank you.
Yeah. I would like to invite Dr. Deepak Sharma for making his presentation on prediction of post-operative pancreatic fistula using alternative fistula risk score. Dr. Deepak Sharma. I think he is not here.
Good afternoon, everyone. I'm Dr. Deepak Sharma, and thank you for letting me present in front of all my mentors out there. So I'll be talking on prediction of post-operative pancreatic fistula in pancreatic duodenectomy using alternative fistula risk score. As Sir just said, the POPF is the worrying features after pancreatic duodenectomy, and it is the main determinant of morbidity and mortality after pancreatic duodenectomy. And it is the forerunner of all other complications in pancreatic duodenectomy, like that hemorrhage, sepsis, and others like delayed gastric emptying and fistulas. So as the quest for good anastomosis continues, the quest for finding the best predictor for POPF also continues. So there has been various models that has been described, including the preoperative models, intraoperative models like pancreatic texture and duct diameter, post-operative models like drain amylase levels, and a combined model of both preoperative and post-operative models. Among those, fistula risk score is the most validated one, which included pathology, duct size, pancreatic texture, and estimated blood loss. However, estimated blood loss is not reliable, and the pathology, most of the time, the histopathology comes later on, so it cannot predict the perioperative discomfort. So Monk group et al. In 2017 proposed alternative fistula risk score, which omitted the two variables and added BMI, which is thought to be a predictor of leak. So with these with these features, we try to find out the efficacy of this alternative fistula risk score in our pancreatic duodenectomy cases. So the main objective of our study was to find the efficacy of alternative fistula risk score for predicting POPF after pancreatic duodenectomy, including the specific objective of calculating individual alternative fistula risk score, correlation of this risk score with POPF, and incidence of complication after pancreatic duodenectomy, and the study factors that are affecting clinical relevant POPF after pancreatic duodenectomy. So IRC approval was taken, and it's a prospective observational study. And all the patients who underwent pancreatic duodenectomy in our department in TUTH was taken. And with a prevalent incidence of 12%, a sample size of 55 was taken for our study. All patients who underwent PD were taken, except those which are less than 16 years, who failed to participate and who had mortality within 2 days, as the diagnosis of POPF requires a drain MLS at day 3. So this is the alternative fistula risk model, which divides the patient into 3 groups: low risk group, intermediate risk group, and high risk group. And it can be calculated with the formula, or free software is available in Evidentia that can calculate you within seconds. And the pancreatic texture was determined by the operating surgeon into 2 groups, that is firm or hard in one group and soft in other group. And the PD diameter was measured in CT preoperative at the level of the neck. The POPF was defined according to the ISGPS 2016 definition, where drain fluid amylase level was taken in day 3 with more than 3 times the upper limit of institutional normal values, and were graded according to SGL as well. The other pancreatic specific complications were defined according to the ISGPS or ISGLS definitions. So a patient who were planned for elective pancreatectomy were taken. All baseline characteristics, including the fistula risk score and postoperative and intraoperative variable were included, and postoperative complication as well as the drain fluid levels were analyzed. So the analysis was done in SPSS software version 25, and the data were presented as frequencies, percentage, or were compared using chi-square test, student test, or man within U test. The p-value of 0.05 was considered as statistically significant. So coming to the results, a total of 65 patients were eligible for pancreatic duodenectomy. However, 9 patients had an alternative procedure like for metastasis, triple bypass, or laparotomy and biopsy, and 1 patient was unresectable and had to do a choledochogestomy in this case. And 56 patients were taken into pancreatic duodenectomy, and 1 patient had an early mortality within 2 days, so he was excluded. So a total of 55 patients were analyzed. As coming to us, the data, its mean age was 55 years. Most of our patients were male and had a good performance status of ASA1 and ECOG 0. Most of the patients did not have a biliary drainage, and the most common form of biliary drainage who had was PTBD, and it was done in 23% of our patients. To come to the intraoperative variables, most of the patients had a soft pancreas, as sir has already told that most of our cases were ampullary carcinomas, and the duration of surgeries was around 400 minutes. Blood loss was around 500, and 5 of the patients had an extended resection, like hepatopancreatic duodenectomy, transverse colon resection, ileal resection, and type 1 portal vein resections. And the PG anastomosis were variable. Both dunking and ductal mucosa were done, and the most common was ductal mucosa anastomosis. Postoperative variables like octreotide were used in around 40% of the cases, and bile culture was positive in 24% of the cases only. And mortality was around 9%, which is equal to the benchmark value. Coming to the complications, hyperamylasemia was seen in 41% of patients, and around 13% of the patient had a clinical relevant POPF. And PPH was seen in 7 of the patients, and DG and Chi leak were seen in a few of the cases, just 2 or 3 of the patients. And most of the patients had a minor complication, and major complication was seen in 13 patients in our series. And the most common complication was surgical site infection, followed by POPF and PPH. So coming to the final histopathology of our cases, most were ampullary carcinoma, followed by pancreatic ductal adenoid carcinoma, and there are various other diagnoses as well. So the main component of the study was the alternative fistula risk score, which was around 8%, and most of our cases were landed up in intermediate group, and around 30% of the cases were in low risk group, and 7% of the case had a high risk for pancreatic fistula. So when we compare the data, it was seen that when we take all the three, that is the older definition of the pancreatic fistula, that is 2007 definition, including the bile leak, alternate fistula score could predict the leak with a p-value of 0.0002. But when we take only the grade B and C, it was not statistically significant. And it was also not significant in all high risk as well as intermediate or low risk group. So with this, we also calculated the factors which caused the clinical event POPF. And in univariate analysis, it was the NRI, preoperative biliary drainage, the hyperemesemia, positive bile culture, and the pancreatic pathology, non-pancreatic pathology were significantly associated with POPF, but none were significant in multivariate analysis. So POPF is a main determinant of complications of following pancreatic duodenectomy, and as alternative fistula scores was validated in various studies outside, but in our series, it could not predict the POPF in our set of populations. So this, to compare, our series had a almost equal incidence of POPF and CRPOPF, and when we see compare the various risk group in various studies, our population had a slightly more low risk group. So that may be a reason why the alternative fistula risk score could not predict the POPF correctly. And the other one was all other studies had a p-value of less than 5. That is, alternative fistula score could predict the clinical event POPF, but our study was a contradictory one. So there are various limitations in our study. That is the single center, and if it had a large multi-center study with more cases, the result may have been different, and there may be some inter-observer variability in determination of texture of pancreas because it was a subjective one, and the number of patients in high-risk group was very small, so it could not. So the result may have been varied. So to conclude finally, alternate fistula risk score is an effective predictor tool for overall POPF, including bile leak, biochemical leak. But when it comes to clinical relevant POPF, it could not accurately predict the POPF. Thank you.
Thank you, Dr. Deepak. Is there any question from the floor? One question, please. If someone is interested in asking a question, one question.
I'm just curious, thank you. Coming from a different country than yours, I'm seeing a lot of ampullary carcinomas. Is it more common in Nepal? Is that why you're seeing it more than pancreatic duct carcinomas? Second question I was going to ask is why PTBD rather than ERCP as the main drainage before surgery? Again, it's unusual for pancreatic papillary type.
There's no specific, I think, guidelines, but it's an institution's practice and the surgeon's preference. So we have both ERCPs and PTBDs. So personally, my own experience is while doing PTBD, you don't touch that area. So less cholangitis, less pancreatitis while you are operating. That's the only reason. So we can debate on that.
Thanks, Ramesh. I suppose it's a nice paper. Thank you very much for sharing that. But the general comment for most pancreatic surgeons is that we always assume POPF and take the highest precaution possible rather than predict and then be less cautious. Always err on the side of safety as the preferred method. But it's a nice study to do. Thank you very much for sharing it.
Thanks.
So I'd like to call upon Dr. Praveen Bikram Thapa to speak on strategies to vascular involvement during pancreatic duodenectomy.
कालो स्क्रिन होइन वाइट स्क्रिन छ
यसमा त आइरहेछ
देखाएन ल्यापटपमा भए ठिक हुन्थ्यो देखाएन यसको ठिक छ त
So I think meanwhile we'll just till this problem is being resolved. So we'll call upon Professor Paleswan Joshi Lakhe to talk on venous resection in pancreatic duodenectomy, principles and outcome.
Thank you very much. So I'll be speaking on the principles and outcomes of venous resection following pancreaticoduodenectomy. The pancreaticoduodenectomy combined with venous resection is considered as a complex procedure, but it is not as complex as pancreaticoduodenectomy with arterial resection. And in 2021, the Heidelberg group came up with the classification of pancreaticoduodenectomy based on vascular resection and additional organ resection. And they showed that as the complexity increased from venous resection to additional organ resection to arterial resection, the procedure-specific complications and the mortality also increased. And recently, the International Study Group for pancreatic surgery has come up with the complexity and experience grading to guide patient selection for minimally invasive pancreaticoduodenectomy. And they have also included tumor vessel contact as the factor for complex pancreaticoduodenectomy, which should be done in a high-volume center by high-volume surgeons. So the main indication of venous resection would be to achieve R0 resection. And depending upon which classification we are following, the venous involvement can be resectable or borderline resectable. If you see that if you follow the MD Anderson Cancer Center and AHPBA classification, the venous involvement that is reconstructible is considered as borderline resectable. But if you follow the NCCN guidelines, the venous involvement that is less than 180 degrees without any irregularity of the venous contour is considered as resectable pancreatic head cancer. So it is important to understand the anatomy and the concept of mesopancreas dissection whenever a venous resection is contemplated. And it is important to dissect to the left of the superior mesenteric vein and resect the plexus SMA from 11 o'clock position to 5 o'clock position, making it the systematic mesopancreas dissection of level 3. And in this context, the origin of inferior pancreaticoduodenal artery is important. And as you can see here that in majority of the patient, it has a common origin with first jejunal artery, and it arises from the dorsal aspect of the superior mesenteric vein from 5 o'clock position to 7 o'clock position. And it is also important to know where the first jejunal vein lies. Majority of the patient, it lies behind the superior mesenteric vein and superior mesenteric artery, but in some patients, it lies in front of the superior mesenteric artery. Amongst the venous anatomy, the confluence pattern of left gastric vein and inferior mesenteric vein are important for venous resection, especially when the confluence of portal vein, superior mesenteric vein, and the splenic vein are being resected. So the paramount, the fact that is very important is the preoperative planning, and which is done in a multidisciplinary setup, and it is done with a high-resolution multi-detector CT scan with pancreas-specific protocol, and the detailed arterial evaluation as well as detailed venous evaluation needs to be done. And this is one of our patients who had distal cholangiocarcinoma, where you can see the main portal vein is involved more than 180 degrees, and there is contour irregularity. Besides this, it is also important to look whether there is any venous thrombosis or venous collaterals are present or not. So depending upon where the portal vein or superior mesenteric vein is involved, it is classified into 5 zones. When only the main portal vein is involved, it is the zone 2 involvement, and when only the superior mesenteric vein and its branches are involved, it is zone 4 involvement. And when the portal vein, superior mesenteric vein, and the splenic vein confluence is involved, that is zone 3 involvement. And if it is on the right side, which is more likely with pancreatic head cancers, it would be zone 3A involvement. And this is also, the CT show is from one of our patients, where showing zone 2 involvement. So depending upon the zone of involvement, the various preparation and the primary vascular reconstruction and the backup reconstruction are defined in this particular paper that was published in HPB in 2016. So International Study Group for Pancreatic Surgery has classified venous resection into partial vein resection and segmental vein resection. And if it is primarily repaired, it would be type 1 repair. If it is repaired with a patch, which can be a synthetic patch or vein patch or sometimes peritoneum or even the falciform ligament can be used as a patch. It would be a type 2 repair. And when segmented venous resection has been done with primary end-to-end anastomosis, it will make type 3. And when interposition graft has been placed, it would be make type 4. And this diagram shows zone 3A involvement, where depending upon the circumference of venous involvement, one can go for primary repair or segmental resection with primary end-to-end anastomosis or interposition vein graft. So the most important principle in resection is to do systematic mesopancreas dissection, and I prefer to go with the posterior artery first approach, then the anterior approach, and the medial uncinate approach. So it means that you need to have combination of artery first approach to whenever venous resection is required. And it is important to get the proximal and distal vein control, and also all the draining collaterals need to be taken into control. And the important thing is that the venous resection and reconstruction should be done in the end. So it is said that up to 30% of the venous involvement, circumference of the venous involvement can be repaired primarily. And in order to avoid the bowel edema, the venous resection and reconstruction needs to be done in the end. And whenever the occlusion time is more than 20 minutes, it is recommended to occlude the superior mesenteric artery as well. And up to 3 centimeters of the resected vein can be repaired by primary end-to-end anastomosis. And there are various techniques to approximate the vein for primary end-to-end anastomosis. And whenever it is not possible, then autologous vein graft, especially from the internal jugular vein or left renal vein, is used, or synthetic PTFE graft can be used. And anticoagulation is required only if synthetic PTFE graft is used. So this is one of our patients who had pancreatic head cancer. And as you can see here, that there is zone 3A involvement, and the circumference of the vein involvement was less than 30%. And we just partially occluded the vein and did the tangential resection with primary repair. And this is our another patient where we individually clamped the portal vein, superior mesenteric vein, and the splenic vein, and resected the tumor and did the primary repair. So this is our another patient. She was a case of pancreatic head cancer in the background of intraductal papillary mucinous neoplasm, and she had zone 4 superior mesenteric vein involvement. And this patient underwent segmental resection of the vein with primary end-to-end anastomosis. So it is important that at the end of the anastomosis, before you make the knot, you leave a growth factor. And it is important to release the inferior clamp first, and do the bloodletting, and then release the superior clamp, and make sure that there is no wasting at the anastomosis. So in this patient, we resected around 1.5 centimeters of the vein, and we were able to make primary end-to-end anastomosis. So venous resection becomes challenging when there are collaterals at the porta, which may be or may not be associated with portal hypertension. And these are pictures from one of our patients who had duodenal carcinoma with portal cavernoma. But fortunately for us and also for the patient, this patient did not have portal hypertension. So this patient, we followed the principle of venous resection without reconstruction by preserving one of the collaterals, and then did the pancreaticoduodenectomy. What we did differently was that we divided the bile duct in the end with the vascular stapler as there were multiple collaterals, and did anterior side-to-side hepaticojejunostomy. So in last 5 years, in my unit, out of 102 pancreaticoduodenectomies, 10 patients underwent venous resection. And as you can see here, that most of our patients had either zone 3A or zone 4 involvement. And most of our patients underwent type 1 portal vein repair, and 3 patients underwent type 3 portal vein repair. And majority of our patients who had portal vein resection had pancreatic pathology. And in comparison to patients who did not have portal vein resection, the group of patients who had portal vein resection had increased blood loss, significantly high in amount of blood loss intraoperatively, as well as the operating time was also prolonged. Although the procedure-specific complications were high in patients who had portal vein resection, but it was not statistically significant in comparison to patients who did not have portal vein resection. However, the reoperation rate and the mortality was significantly high in patients who underwent portal vein resection. This might be because of the small number of patients as well. And if you look into this meta-analysis, which included 30 studies with more than 12,000 patients, out of which 2,000 patients underwent portal vein resection, showed that the intraoperative blood loss, the operating time, as well as the in-hospital mortality and 30-day mortality were significantly high in patients who underwent combined portal vein resection. This meta-analysis showed that the procedure-specific complication was not different. However, the R0 resection was significantly less in those patients who had portal vein resection. So this is a recent publication, and this is an interesting study which took into consideration the global data from all over the world, 317 centers with more than 4,000 pancreatic duodenectomies, out of which 444 patients underwent venous resection. They showed that the major complication rate was comparable between the medium and low HDI countries and high and very high HDI countries, suggesting that the technical skills are there in low resource countries as well. But what they showed was that there was non-significant trend towards higher mortality in medium and low HDI countries, which showed that there was difference in complication management and rescue capabilities that ultimately determines the patient outcome. So their post-operative complication of that study with the global data were within the benchmark values. But when we compared our data with the benchmark values, in terms of the immediate oncological outcomes like lymph node yield and R1 resection, you can see that our data are within the benchmark value. But the procedure-specific complications like clinically relevant postoperative pancreatic fistula, the post-pancreatectomy hemorrhage, and the in-hospital mortality they are beyond the benchmark value, although our overall mortality is around 5%. So this 92 patients are without venous resection, where mortality is 4.37%. So in conclusion, what I would like to say is that the venous involvement can be reconstructable. Venous involvement that is reconstructable can be considered as resectable or borderline resectable, depending upon which definition we are following. And it is important, the most important thing is the preoperative planning in a multidisciplinary setup. And with the global data, with the existing meta-analysis, and with our data also, the results of combined venous resections are acceptable and are comparable. Thank you very much.
Questions? Yes, sir.
New data is going to come pretty soon. The utilization of neoadjuvant therapy resulting into the resection, vascular resection. They're going to improve. And I think we are looking at the post-operative thrombosis of the anastomosis is about 20% if you look at it, which we are not going to ignore with the neoadjuvant therapy group. That will be prevented. So the data is coming, I think, next year, most likely, with the neoadjuvant, our combined worldwide data. And I think, did you have any patient in your series that got neoadjuvant?
So there were two patients who had neoadjuvant therapy, and both the patient had locally advanced pancreatic head cancer before the neoadjuvant therapy. But both these patients did not require venous resection because after the neoadjuvant therapy, it was not required. We just had two patients in this small series.
Very nice. See that in pancreatic cancer, why is it like that? See, checking using What about it? Having such a big either the pancreas or the pancreas has all the tumor cancer. But surprisingly, there is no liver metastasis at all. Have you
So in pancreatic head cancer, so because these patients will develop jaundice early and they will come to you, unlike the patients with pancreatic cancer of the body and the tail, they will not have any. They will just have pain abdomen or maybe anorexia. So they will wait for a longer period of time to come to a clinician, and by that time the patient will develop a liver metastasis. Whereas in pancreatic head cancer, they will develop jaundice, which will make them to go to the clinician earlier. I think that's the reason.
Thank you for a nice presentation. This one, I was just curious, of the veins that you resected, were there evidence of histological involvement of the vein after they were resected on pathology?
Yes, I think in 2 patients, out of 10 patients, in 2 patients, the histology was positive in the vein as resected vein as well. Yes.
The remaining 8 were negative for involvement.
It was negative.
Thank you.
Wonderful work you're doing, Palesha. And this is just I'm inquisitive about this one patient you mentioned that did not require venous resection. Did you do advential excision and analyze this pathology?
So I did not get you, sir.
Now, you see, you mentioned one patient who did not require venous resection after chemotherapy. But did you do the advential excision of that vein?
So in both the patients, after pancreaticoduodenectomy, there were 2 patients who had neoadjuvant therapy in this series, and both the patients, after pancreaticoduodenectomy, the specimen showed no residual tumor. There was no tumor in the specimen.
The adventia of the
So
vein.
we always do the mesopancreas dissection. All the standard resection technique was done, and there was no residual tumor in the specimen after resection.
Okay, Professor Lucky, thank you very much for your
Thank you.
presentation. Thank you. So we're going to move on to the next speaker. Dr. Prabin, your slides are okay now? So if can we invite Dr. Prabin Bikram Tapa to share with us on strategies to vascular involvement during pancreatectomy.
Type C छैन अब।
So respected chairpersons, today I'll be talking about strategies to vascular involvement during pancreatectomy. So I'll be talking more about my experience rather than taking the data and literature review from elsewhere that we can do right now from Google. So if you see the NCC guideline, it is divided into resectable, borderline, and locally advanced. And our strategy is to go for neoadjuvant therapy for borderline resectable and locally advanced pancreatic cancer. And this is the definition we follow, though there are other definitions as well. So I'll be talking about what I do if there's arterial involvement, and what I do when there is a venous involvement. To make a strategy, I have to look for hepatic artery, SMA, celiac, and splenic artery. And in venous, I have to look for portal vein, SMA, SMV, splenic vein, jejunal and iliac vein, and coronary vein. So hepatic artery is very important while doing the pancreatic surgery. The reason is it has got many variations. So it is, we classify this according to the Mitchell classification, and we had published long back on it. And we have seen that the normal variant, the common variant is 37%, and uncommon variants are also very common. 75%, and uncommon is 37%. So why is this important? Does it have anything to do with oncology, biology? There's only one paper which says that a replaced right hepatic artery adjacent to pancreatic carcinoma should be divided to obtain R0. However, the outcome is poor. We have a very small series. What we have found is if the aberrant hepatic artery is 2 centimeters away from the tumor, from SMA, and it is involved, we can go for upfront surgery with R0 resection. But if it is within 2 centimeters from SMA, then it behaves more like a borderline resectable, so we go for neoadjuvant therapy. So this is the strategy we follow. If we see aberrant right hepatic artery abutment or encasement within 2 centimeters, we go for neoadjuvant. Beyond, we go for upfront surgery. So if there is only abutment with intact lumen, we go for divestment. If there is involvement of the lumen, or if there is bleeding while dissecting, or if there is, we are not convinced that there's tumor, then we go for resection. This is one of the picture where this aberrant hepatic artery, and we have done divestment of the vessel. We usually do cold dissection with Caesar, and we clear the tissue around the aberrant right hepatic artery. So this is gastroduodenal, which is clipped, and we did. This is again one more case where we have done a cold dissection. We use only Caesar. We don't use cautery. So we are taking the peri-adventitial tissue. Many times we go sub-adventitial as well. So this is a case where we could not do divestment, so we had to do the resection. The absolute indication for resection is if there is post-operative bleeding, where it is not safe to do divestment, or if there is involvement of the lumen, then we go for resection. So replaced or aberrant right hepatic artery is not that uncommon. So we have got various series, So this is one, this is another one. This is when we did divestment of the SMA, when we did lap, PT for SPN, there is aberrant hepatic artery. In cirrhotic liver, again this is the case where we have done resection. This is the divestment where the proximal part is narrow and the distal is wide. So this is the divestment which we could do. Yes, sorry. So second blood vessel, what artery we talk about is SMA, because there are SMA approaches. It makes a boundary of the triangle where we dissect. We go for dissection. Sometimes, of course, we go for resection as well. So artery first approach, this is a review article by Silas Trikhande and John Windsor, and they contributed a chapter in our book on pancreas and biliary surgery as well. And this is the only article from our center that we approach SMA first in different way for different pathology. So this is the surgery we have done, posterior approach, posterior for head and neck, especially involving portal vein and SMV. So this is in a group pancreatitis where we could not make a tunnel. There's uncinate vein draining the uncinate process. So we tie it, then we expose the SMA, and this is the medial approach. So this is how we do it. This is an inferior approach. This is it is transmesenteric inferior approach. It is supracolic inferior approach. This is left approach. If there is a lot of adhesions, we mobilize the ligament trees, we take control of the SMA, and we proceed. But many times, it's the combo thing we do, rather than doing a single approach. So this is SMA is important. It's for triangle surgery because it makes the boundary. We do triangle surgery where we take the apex of the triangle where previously we never used to take it out. And we showed the result that 20% of the cases are benefited. The previously what R1 we used to do is R0 right now when we do triangle surgery. That's how the paper from Heidelberg, they have shown that the increase in the outcome, overall survival. The Heidelberg, they have Twitter, they have, in social media, they have shown our surgery. They have posted, this is our surgery, doing the triangle surgery. So arterial divestment, I was quite lucky to learn this procedure from Professor Bushler. When I went there, they were just starting, so it was quite difficult for me to learn. Again, I went for the second time. I was lucky to assist him. He told me to scrub and go for this one. And we started doing, and it's for teaching purpose. Also, we made a schematical diagram. So either we go for periarterial divestment or subadventitial divestment. And this picture has been taken in many lectures elsewhere also by eminent surgeons. And this is the paper we have published. If this is a locally advanced, obviously we go for neoadjuvant chemotherapy, we go for arterial first approach, then we go do the resection, either resection or divestment of the SMA. So this is one of the pictures where we have done the divestment of the SMA. So everywhere I'm using the Caesar. This is a subadventitial. This is a subadventitial divestment. But one issue, what we have found here is rate of pseudoaneurysm is a bit higher than what we get in normal Whipple's procedure. So this is the case in which, again, if the lumen is involved, if we are not convinced that tumor is completely taken out, or if there's bleeding, we go for resection and anastomosis of the SMA. So in this case, we have done the SMA recon. And if you see the cut end of the pancreas, it's almost hard pancreas, so we could do the secure anastomosis. If it is not, then sometimes we go for total pancreatectomy. So to assess this vascular structure, what we are doing is we are using ICG. So this is the ICG, arterial phase, hepatic artery, SMA. Then later we see the portal vein and SMV. So that helps us to assess the anatomy and the vascularity of the remnant pancreas as well. Celiac artery usually in pancreaduodectomy, it's not that important. Many times we have to do, if it is the head and neck tumor, then only do. I don't have any experience regarding the celiac artery resection, so I'll be skipping this. But one thing is that when we do dissection around the celiac, and the lymph node yield is slightly higher compared to leaving it behind. And we have seen, are there any changes per operative while doing the celiac resection? Yes. The patient may go into bradycardia as we are pulling the stellate ganglion. And another thing what we have noticed is because of stellate ganglion is taken out, everything is taken out, the motility of the stomach is rapid. So delayed gastric emptying is not there. The gastric emptying is rather better if we do the extensive surgery around the celiac. So next is a venous, portal vein, SMV, splenic vein, jejunal ileal vein, coronary vein. So this is the portal vein and SMV is important because it is infiltrated by the tumor or there may be thrombosis leading to cavernoma formation. So these are all pictures, SMA type 1, portal vein recon type 1. This is type 2, where we take the peritoneal patch. We usually do it when it is around the splenic vein. And the way of doing is a bit different from what I learned elsewhere. Rather than doing the side-to-side anastomosis, we take a bite from the edge of the vein, but the surface of the peritoneum. So the peritoneum end doesn't go inside and may not cause, the chance of thrombosis is less. But I'm not sure regarding it, but technically it should be better. So this is the case. So it's like putting a patch on the defect rather than side-to-side anastomosis. So this is type 3 repair we have done. And type 4, we haven't taken the autologous. I don't have any experience regarding this. But there are a few difficult cases with portal cavernoma formation. So we put a stent from SMV to left portal vein. We decompressed the hepatoduodenal ligament, and we did the resection rather than dissection. We took out everything from the hepatoduodenal ligament, and the liver was supplied by the left hepatic artery. And after taking out the specimen, we did total pancreatectomy. Then we shortened the graft. So this is the second picture shows the graft which has been shortened after the specimen was taken out. This is head and neck extension. And here the challenge is preserving the dorsal arteries. Sometimes by mistake, if you take it, then there can be pancreatitis or necrosis. So this we have identified in ICG. So the role of ICG here is important. And this role of ICG to assess the cut end of the pancreas, this was taken from us by eminent surgeon Malaysia Hogg and presented in EHPBA. But we don't know the result. We have published a paper regarding its role. We have seen that with naked eye, though it looks normal, it is devascularized, hypoperfused. So we had to re-resect the neck of the pancreas to make the proper vascularity proper. But we don't know whether it has really improved our outcome in POPF or PAPP. And we have published a paper, but it's a very small number. But again, we are coming with a larger number, so whether this is theoretically correct or whether it is clinically important or not. So this is the outcome regarding the vascular elsewhere. So the common thing is mortality is high if vascular resection is done. This is an intraoperative variation of the gastrocolic trunk of Henle. We have classified it. Did it help in our pancreatic surgery? It didn't help. It's just our academic exercise only, just to publish a paper. Coronary vein, many times it traverses through the triangle. We try to preserve it. Many times it's not possible. If we take the coronary vein, then we have to preserve splenic vein and IMV. Otherwise, there'll be congestion of the stomach and there'll be worse consequences. This is a case in cirrhosis where we have taken care of the coronary vein. The reason is the blood flows, there's a resistance at the sinusoidal level. For that reason, the blood flows from coronary and there'll be increase in the GI bleed. So we always die when we do for pancreas.
Probably you can try wrap up soon if you can.
So I think it's almost over. Jejunal, if it is not dominant, we do the anastomosis, otherwise we tie it. So this is infracolic approach, secretize this. Here we have secretized ileocolic vein because it was not dominant, so everything was fine. So we don't know the long-term outcome, but early outcome, we were quite skeptical because we did the root of mesentery dissection, so chyle leak could be a problem, but here we saw it was manageable. So this is my last slide. What the international literature says is the mortality is high if you do the vascular resection. But in our series, it's not like that, in 90 days mortality. The reason is most of our patients, they have died because of the pancreatic leak. Soft pancreas, easy to do, but worse outcome, like distal cholangio. But pancreatic head cancer with vascular resection, they do pretty well. So this is that's why we have done a grading system for Whipples, So which one is easy, which one is difficult, which one the resident fellow should do, which one the consultant do. So we have divided into 1, 2, 3, 4. You can search in literature. So this is the result from our same. Role of anticoagulant, it's debatable. I've got a very simple policy. If I do anastomosis of the small artery, I give antiplatelet. I learned from cardiac friends. If it is a large vessel, I don't do anything. For vein, if it is clamped for a long time, then we go for anticoagulant. Unlike artery, we give heparin and warfarin, but in artery, small artery, we give aspirin. So their pathology is totally different. So these are the books we have published so far in our department. Thank you.
Thank you, Praveen. We probably have time for one quick question, if anything has any pressing questions from the audience. Okay. Maybe one last message from you for the young surgeons in the audience. I mean, when we talk about arterial and venous dissections, it's quite a major thing to be doing. Yeah. So maybe one last message for the young surgeons in the audience before we close. Anything you want to say to the young surgeons?
There are very simple messages. One, you have to know the anatomy. Second is you have to be properly trained. You should not be fooling around. Yeah. You have to go through the literature. Like there are contentious issues like use of anticoagulants. And it's possible. It was a small center previously, so it was very difficult for us to do. But now we are doing around 50 cases per year. Derek was here. We attended. We just worked for 5 cases for this week. So it's once you get the number, everything will be solved.
Thank you.
Thank you.
Thank you very much.
So we'll move on to the next presentation. So very interesting topic on AI in HPB surgery, going to be delivered by Dr. Derek O'Reilly.
Thank you all for the wonderful invitation from the Society of Surgeons of Nepal. It's a great honor to be here at this meeting and in the wonderful city of Kathmandu. I'm going to be talking a little bit about AI in general, first of all, its application in medicine, and then some examples of its specific application in HPB surgery. So what is AI? Well, these are computational models, and they are designed really to mimic the way our brain, the human brain, thinks and makes decisions. The WHO definition is really more applicable to medicine, and the key part of this definition is that it has a capacity to perform automated tasks without human programming. Not so much a definition, but the third statement here is really about the value of AI. It should make our lives better, and it should make our lives easier if it is to have any value. In terms of medical applications, machine learning, deep learning, artificial neural networks are about analyzing data and giving outputs. Natural language processing is something I use in my practice currently in China, in Beijing at the moment. It's about AI's ability to understand human speech, either orally or in the written form. And I use this, for example, in our consultations. They're all analyzed by AI and transferred to the electronic patient record. And it's not just a verbatim record, it makes sense of the consultation. And then, of course, you can check it. This is a conceit we give ourselves. It's always more accurate and more detailed than anything I would have typed or dictated. Computer vision, though, I think is perhaps of the greatest interest to us as surgeons, because we're in a very visual specialty in terms of X-rays, CT scans, pathology slides, and of course, operative video. So here is a great way for AI to analyze what we do and help us. Coming to AI in HPB surgery, there's a journal called Artificial Intelligence Surgery, and this is a special issue on HPB surgery. That's my disclosure. I have no financial interest in the journal or on any other AI products. But I would recommend to anybody interested in AI surgery and HPB that, or in general, that this website is a great resource. Apart from the open access papers, there's a lot of webinars and podcasts that help us all understand this new and challenging area of artificial intelligence. This is a paper from that special issue from Ewan Harrison and his group in Edinburgh. It looks complicated, but it's fundamentally simple because it's a scoping review that maps out the areas in which AI can help us in the future, mirroring really the journey of a patient from the preoperative diagnostic phase, the intraoperative phase, and then there's the postoperative predictive phase. And some of these are overlapping areas. So this is the scope, as it were, of how AI can be used in our practice. And I'm going to give examples from each of these phases. It's not a comprehensive review, but just one example from each phase. And in the preoperative phase, what we really need in pancreatic cancer is early diagnosis. And can AI help us with this early and accurate diagnosis of pancreatic cancer? And this is a very nice study from China. It's called the PANDA study, which is a great name for a study from China. And it's about detecting pancreatic cancer at an early stage using what I would consider suboptimal CT scans. So scans done in the emergency room for trauma or other emergency conditions. And after development and validation, this AI tool was able to, with high sensitivity, and it's more important in pancreatic cancer to have high specificity, because if it's falsely diagnosed, the consequences are unnecessary whipples, which would be a threat to life. So it has to have very high specificity. And this tool had 99.9% specificity. It detected malignancies at an early and resectable stage. And as I said, it did so on these, on not just abdominal non-contrast scans, but also on screening chest CT scans. Now, you're all surgeons, you know the pancreas is not in the chest, but all or a part of the pancreas can appear in a chest CT due to the curvature of the diaphragm. So this can be applied to other cancers. Gastric cancer, and PANDA-2 is taking this work further. I want to talk about intraoperative use of AI. The reason I got interested in the AI is, can it solve our problems? And a big problem in our specialty is bile duct injury during a very common operation, cholecystectomy. 1 million done a year in the US for benign disease. And yet, a bile duct injury rate pretty constant over the last 30 years of about 1 in 500 operations. And it's a devastating complication, as you know. Devastating for the patient, devastating for the surgeon as well. And we haven't really got to grips with it. Despite specialization, the lawyers have specialized. Have we specialized sufficiently in this operation? And despite education, great work being done by surgical societies around the world to push with this surgical view of safety. But despite all this, we're still seeing common bile duct injuries. So can AI help solve this problem? There's lots of tools in development to help with the display of anatomy during surgery. AI tools such as this, an overlay onto the screen. Green means it's safe to operate there. It's called a go zone. The red part is a no-go zone. That's where the bile duct is. Don't be dissecting down there. So these are the sort of tools, and there's a lot in development. My colleagues here in Nepal are working on it as well. And in other operations like thyroid surgery to display the recurrent laryngeal nerve. There's lots of these tools which will soon be commercially available that will help with safer surgery. And I think if we can do safer surgery with less intraoperative complications and errors, then the onus is on us, I think, to adapt and use them. So you could see from that video that AI knows how to do a cholecystectomy. So why do we need a human in there? That's the question. And it's being, this is a rapidly evolving field, and this year the Johns Hopkins group published autonomous cholecystectomy in various models, including animal models, the porcine models. So there's no human involved here. This is a robot being driven by AI learning, clipping and cutting the cystic duct and the cystic artery. The next few clips will show something I like, which is the ability of this AI tool to learn from its mistakes. So first of all, it's grasping, it's inadequate, but it knows that, so it regrasps. So this is self-recovery and learning during the operation. Here it's clipping both the artery and duct together. It realizes from its learning and instructions that that's wrong, and so it corrects itself to clipping and cutting correctly. And as I say, this is a rapidly evolving field. There's no reported human operations, but I think that would be naive to think that that's not being done. What's being done is always several years ahead of what's in the public domain. So in the post-operative phase, really continuing the theme about complications. There are certain things that are inevitable in life. I think, I can't remember who it was, death and taxes. For us surgeons, it's death, taxes, and surgical complications. AI can help us with the prediction of complications and early recognition of complications. This study is a few years old now, but it looked at pancreas, liver, and colorectal cases, several thousands, and analyzed the patient electronic record. And it could be words, patient feeling a bit tired today. It could be the blood results. And it found that it was very accurate in predicting complications of surgery. So when you get a complication, and I've had many, there are two aspects to management. One is putting it right. If you can do that yourself, that's fine. If somebody can do it better, you need to find somebody better. And that's particularly applicable to the common bile duct situation. And the other is communication. A complication is not necessarily the end of a relationship between a doctor and a patient. It depends on how it's managed, and it depends on the quality of the communication. And good quality communication can even enhance the trust between a doctor and a patient. This is a very nice study, and it's about the quality of communication, comparing humans and comparing AI chatbots. And so these are patient questions that were put to doctors and to the AI chatbot. And firstly, they were evaluated by doctors for accuracy, blindly, of course, and the doctor said that chatbots' answers were more accurate and of better quality. Even more interestingly, then the patients evaluated the answers and they graded them for empathy, a word we've been discussing earlier today. And perhaps to no one's surprise now, the chatbot's answers were considered more empathetic and more kind than the human replies. So as I said, we should never be complacent. I think AI has the potential to out-diagnose us, to out-operate us. And perhaps we always felt at least it'd be human communication and compassion to fall back on, but perhaps not. I think ultimately, in evaluating AI, I'd echo what Dr. Tim Mitchell said earlier. They have to be evaluated scientifically for efficacy, and only before it's better than a human-performed operation and proven to be so, to have better outcomes, that these things should be adopted. And they have to be cost-effective. And when it comes to communication, ultimately it will be the choice of people, of our patients, whether they choose to come to see us for communication or whether they will consult with an AI doctor. And they will base that decision on value, on quality, and on cost. So I will summarize. AI is a potential tool to form a bridge between an individual patient and the patient-level data. And we can use it at all phases of a patient's management to help us with their care. Thank you all very much. Dhanyabad. Thank you.
Are there any questions from the floor?
Derek, thank you very much. A very nice talk. And I'm sure that the data for empathy was not done on a population of Irish physicians. That would have scored much better. My question is in relation to the very nice diagnostic implications you showed, and the ability to pick up early pancreatic cancers. Do you think AI will change our approach to screening in the future?
Yes. You know, I think that the principles of screening are still intact and have to be remembered. It's about accuracy. It's also about patient acceptability. What is the screening tool? But these studies are about screening, and it's about using existing information that we're already collecting, that are already happening, like in the electronic patient record, like having a scan for another purpose. That data is in the system. And what was remarkable about that study, a lot of the scans were people having screening for lung cancer, lung nodules. So there's huge opportunities opening up to use AI to screen for cancers. And we all hope in a screening program to find early cancers that are amenable to us changing the natural history. And pancreatic cancer is perhaps the most challenging because it has such devastating outcomes. Right? I think there's great potential there. Yes, thank you.
So, if there are no questions, thank you so much.
Okay. Thank you.
Dr. Terry.
Okay. And I would like to call Dr. Mukunda Raj Joshi for making his presentation on new frontiers in HPB surgery.
Thank you, chairpersons. At the outset, I would like to thank the organizing committee for giving me this opportunity. And especially, it's very difficult to present the similar type of topic after the renowned person has already talked on that. So I do not have personal data, but just an overview what is going on. So what are the new frontiers in the SPB surgery? Actually, the SPB system cancers impose a considerable burden because of poor prognosis, high mortality rates, and often presenting at advanced ages. So hepatopancreatobiliary field that covers the broad field like liver, pancreas, and biliary tree. And because this is the field which needs the surgical dexterity and deep understanding of the variable anatomy of the region coupled with the foresight, as well as the prompt recognition of the complication and its treatment. SPB operations are among the most challenging abdominal surgery due to intricate anatomy, critical vasculature, narrow margin for error, and even in experienced centers like negative outcomes like negative margins, complication rates, and long-term survival are closely tied to the quality of the preoperative imaging, surgeons' planning, and the real-time intraoperative judgment. So if you see in 1960s, the hepatobiliary mortality was around 20 to 25%, and the morbidity almost 60%. With the advent of the centralization effect, advanced imaging and surgical technique, as well as the perioperative care, in specialized centers, the mortality has reduced less than 5%, but the morbidity remains the same. And there is still the search is going on how to reduce this morbidity as well. So evolving landscape in the SPB surgery is the traditional open surgery to precision guided minimally invasive techniques, enhanced recovery program also, driven by the complex oncology, technological integration, and the pursuit of the improved patient outcome. So there has been the technological advancements, there has been expanding the resectability and personalized treatment with the integration of the novel molecular and genomic insights. So what are the technological advancements? Yes, there has been the robotic revolution. Robotic platform are overcoming the limitations, and that enhanced the 3D visualization is there. There is improved precision for delicate dissections and enabling the complex MIS procedures. So this is, we in our country have 2 robots in private center, and the one was the first one that was brought 1 year back, and recently the Chittor Medical College outside Valley is practicing robot. And then last week there was a live telecast, first live telecast of the robotic surgery. So the many things have already been discussed, but just to summarize that the artificial intelligence is a program that can sense, reason, act, and adapt. And also the machine learning is the subset of that, and the deep learning are the further subset. So this year, the Google is investing almost $90 billion on the development of the AI in the health sector. And according to the CEO of Google, he's saying that the present day algorithm is not up to the mark, and there are chances of error. So we can adapt it unless it is in the advanced phase. Machine learning is a subset of AI and uses statistical techniques, and the machine learning learns to solve the task problem from the examples and is then able to complete the task on its own. And deep learning is the subset of machine learning, the algorithm inspired by human brain, and the more data and more computational power it gets, and the more smarter it gets, and then there is no theoretical limits to what it can do. So if you see the publications in the last years, since 2014, the AI-related publication has been increased in recent years and rapidly, and mainly from the China, Korea, Japan, and USA. So there is a rise of AI and the digital twins for the care of the patient in pre-operative, intraoperative, and post-operative time. So these are some of the remarkable papers, peer-reviewed studies from the AI and showing the promising result. So what it can do is the pre-operative planning, the 3D modeling and printing can be made, and then with the complex vasculature, and this studies has shown that it has got very good results, and this is the 3D results that has been made can be brought to the OR. And this is the picture where the tumor is green, and then segment 5 resection has been planned, and the relation of the vasculature has been delineated by the AI. And the interoperatively, the 3D picture can be incorporated into the real-time pictures, so that the augmented reality can be used in minimally invasive and open surgeries that predicts the accurately can forecast which of the patient of the liver resection can go into the post-hepatectomy, liver failure, and other complications. And similarly, surgical planning can be done, and the intraoperative guidance, it guides the surgeons to where to go. Just that we have seen in previous lecture. In the post-operative management and workup also, the AI has been used. It can predict where the problem might come, which patient may go into severe sepsis. It can predict well than the previous scoring systems. So whatever the expanding resectability, there have been the new surgical strategies and techniques. Enhanced resectability has been achieved in recent years, and the minimizing the complication and expanding the indications. So the pancreatic head cancer has been, according to the resectability, it has been classified according the resectable, borderline, advanced, and metastatic, so that the neoadjuvant therapy can be planned as well. And the borderline resectable has further been classified into the biological, it is incorporated with the biological and conditional host-related conditions also. So there has been the clinical trials regarding the neoadjuvant therapy, which patients gets it, and the in the 2018, the PRODIG 24 trial has shown that the FOLFIRINOX has got the best reported survival. And this, even in the resectable pancreatic ductal adenocarcinoma, there has been the trials, and has shown that which patient has got the longer survival, and if they get the neoadjuvant, but it is yet to be established. Minimally invasive surgery is another frontier that is already has shown its efficacy and the result. And nonetheless, it has shown that it has got less blood loss, less blood transfusion, although the operating duration is longer, but the overall hospital stay is reduced, and the R0 resection rates had been improved. So even in biliary tract cancer, where the resection margin positive is a key issue, and a very narrow margin is there, even if the margin positive comes, then we can use the newer adjuvant therapies like S1 has got better result. So in hepatocellular carcinoma, precision imaging for the microvascular invasion prediction has been introduced, and then the microvascular invasion, where the microvascular microsatellites are present, that can be evaluated by the radionomics and the mixing of the AI. So the treatment strategy has also been, there has been changed, like the earlier, the BCLC was very much criticized because it was said that it was a very strict criteria, and in many parts of the world there has been the resection was done beyond the BCLC criteria, and recently in 2022 BCLC has been revised, and these red sections are new amendments. So the curative strategy for the hepatocellular carcinoma has increased with the neoadjuvant setting, predictive biomarker, sequential parallel application of the systemic and the local therapies, and then research to the treating liver fibrosis, so that it doesn't reoccur again, because the fibrotic liver is the soil for the hepatocellular carcinoma. So another frontier is that the ALPS, regarding ALPS in 2016, it had been criticized, saying that the innovation for innovation's sake, but there has been the endless pursuit of the hepatic resectability, and now there has been some promising results of associating liver partition and protein ligation in staged hepatectomy, and there are different types of ALPS have been named, and the minimally invasive ALPS procedure has shown the very good results. So the personalized treatment by the integration of the novel molecular and genomic insights is there. So this is the radionomic model, where the hepatocellular carcinoma has been classified into SC1, SC2, SC3, and the images where the more dense marker are there that are the bad prognostic tumors. So the molecular diagnosis can be used for the personalized therapeutics. Hepatocellular carcinoma and molecular classes has been that they classify according to the proliferation rate and the proliferative type and non-proliferative type, so that the proliferative type, they are more susceptible to the chemotherapeutic agents and that can be used as the neoadjuvant therapy. So another frontier is the ERAS. It has been used in 2001 and it is being used in preoperative, from the preoperative period, postoperative, and even the postoperative time. And the result is that the 90% compliance with the ERAS produces the complication rate to 20%. So although it's not possible to follow all the ERAS protocols, but it has got good results. So there are some emerging techniques like histotripsy is the novel non-invasive frontier, where this technique uses the precisely targeted high-intensity focused ultrasound to mechanically destroy the tumors by bubble cloud. So this can be used for the non-operative cases and the similarly irreversible electroporation and HIFU. But there are challenges to the new frontiers. Number one is the regarding the robotics and AI. There is a steep learning curve in the robotic surgery. The advanced navigation and the new techniques require significant and specialized training. And the cost and accessibility is also an issue in the country like ours, where the resource constrained in areas very difficult to acquire these new technologies. And it needs for validation. That is, the out of 38 studies that has been from the AI had high risk of bias analysis had been seen in the PROVAST analysis, and primarily due to the inadequate validation. There has been found that there is lack of independent validation, non-transparent and patient selection bias, and the publication bias has been there. So the many new technologies still require a large-scale randomized control trials to definitely prove the superiority. And the future horizon is the future of the SPV surgery is not just technical, but biological and informational. The combining the molecular guided resections, data-driven AI, and advancement in the regenerative medicine. Thank you.
Thank you. Any questions? If there are no questions,
thank you.
Thank you. Now I invite Dr. Igor Khatko for his presentation on minimally invasive techniques in pancreatic surgery. Dr. Khatko. Yes.
The chairman, dear colleagues, thank you very much for invitation, and it's a great honor for me to be here in such a great conference. And my talk today will be devoted to minimally invasive pancreatic surgery, and mostly for minimally invasive pancreatic duodenectomies, its possibilities, difficulties, and some results. So briefly about the history, the first laparoscopic procedure was performed by American surgeon Michael Gagne in 1993. He was not encouraged very much by the result, the same as Sir Alfred Coucheri, who performed the first distal pancreatectomy, and they didn't see any benefits in laparoscopic approach to this kind of surgery. But still, a lot of surgeons continue doing this, and the first venous resection was performed by Italian surgeon Professor Hascher in 2003. The first study was published by French surgeon Duluc, professor. It was 25 laparoscopic pancreatic duodenectomies, and you see from this time, more and more publications are devoted to this type of surgery. For today, there are a lot of systematic reviews. that confirm that the laparoscopic approach and minimally invasive approach in general have advantages in early postoperative recovery for the patients and has no disadvantages in morbidity, mortality rates, long-term results, and the only disadvantage is a little bit longer operative time. So all this data are summarized in several consensuses in Miami in 2020 and in Brescia 2022, where the role of laparoscopic and robotic and open procedures were stated like equal, and each of these approaches have a role. I also, it is necessary to mention that in 2024, in the consensus also devoted in, which took part in PISA, and was devoted to borderline resectable and local advanced pancreatic cancer, the role of a minimally invasive technique also was emphasized, that it is possible to use them even in such cases. So I would like to present a little bit now experience. So we performed first laparoscopic Whipple in 2007. First vascular resection was performed by laparoscopic approach in 2013 when we had the experience of about 50 operations. First study was published in 2016. In 2022, we overcame the number of 500 procedures. For today, we have about 1,100 procedures totally in pancreatic surgery, and among them is about 700 Whipples. It's for today. These figures are for April of this year. So here are our results. General number of fistulas, you see it's about 27%, and BC, grade BC is 23%. Mortality rate, it's a little bit less than 5%, and I'd like to emphasize that, to our opinion, it is very difficult to reduce the number of fistulas because it depends very much on the soft and fragile pancreas tissue and so on. But we should reduce the mortality rate because of fistulas. So there are two ways. It's proper draining, and we think that it is very important to introduce special antibiotics prophylaxis and special infection control in our clinic. So we created the service for infection control, and you see that the number of mortality rate went down after we did this. And for today, for last 200 operations, the mortality rate is about 3% in our hospital. So some words about laparoscopic and robotic techniques. Several years ago, we performed a retrospective study together with our colleagues from Italy and Germany, devoted to understanding of a learning curve in laparoscopic and robotic procedures. And you see that there are no differences in learning curve for these methods. And it is also the data from systematic review of 32 trials from our Chinese colleagues. And they also didn't see any differences in learning curve for robotic and laparoscopic approach. And I would like also to mention that for today, there is no one study that emphasizes that shows some benefits of robotic approach comparing with laparoscopy. In spite of this, we see that more and more publications, more and more trials are devoted to robotic surgery, and more and more surgeons use it. So in our hospital, we have 3 robots. So we use robotic approach, but not so intensively like laparoscopic. I will say some words about this a little bit later. So this is the standard technique. I'll try to be very short. It's absolutely like the same like in open procedure. It's deep Koche maneuver, then tunneling over along the portal vein, then transecting of the stomach with a stapler, then lymphadenectomy in the hepatoduodenal ligament. Now you will see how we transect the common bile duct by cold scissors. We do it by cold scissors, but at the end of the operation for today, because it's better to preserve the abdominal cavity from bile leakages. Then it's transecting again with cold scissors the main pancreatic ducts. And for today, we use dunking anastomosis with separate 2-0 tichrome. Yes, and the last stage, it is very important also, you see it's mobilization of the complex along the superior mesenteric artery, and laparoscopic approach provide all the opportunities to do it properly. So here is the pancreatic junostomy. We use dunking anastomosis with separate sutures with tichrome, and at the end, I'm sorry, something. And in the end, with an absorbable suture, 5-0 usually or 4-0, it's hepatic june anastomosis. And stapler anastomosis for gastric junostomy or manual anastomosis, if we perform pylorus preserving operation. So here are some additional opportunities that we can use during laparoscopic approach. On the left part of the screen in the upper corner, you see it's using this ICG for controlling of bile leakages at the end of the operation. We think that in some cases it may be helpful. Using of 3mm instruments, if we have very thin duct, it's also very useful and provide the possibilities to suture the duct of very small diameters. And on the right part of the screen, it's simply like an illustration for robotic approach and again pancreatic adjunostomy. But of course, it's much more interesting to say how laparoscopic approach can help to overcome the difficulties that we see in this kind of surgery. Here you can see that it is very soft and fragile pancreas, and it is very difficult to perform this anastomosis. To our opinion, it doesn't matter, laparoscopic or open approach and so on. So here it's, you should make the decision. Perhaps you should put as much drainage as possible for this case, or we think that in such cases you can perform total pancreatectomy and it will not be a mistake for such patients. In some cases, you can perform, especially if the pancreatic stump is very thick, like here, you can perform pancreatic gastrostomy. We do it very rarely. In my practice, I do it only once. But you see also the laparoscopic approach provide all the possibilities to perform this. And simply to illustrate the possibilities of laparoscopic approach, I want to show a short video. It's the tumor of the cancer of the body of the pancreas with the tumor thrombosis of splenic vein and portal vein. You see it here. So it was also quite severe portal hypertension. So here is transected pancreas, and the tumor is on the right part of the screen. And the initial plan was simply to transect the vein, remove the trump, and suture this incision. But you see that there were a little bit more adhesions inside the vein than we could imagine before the operation. And one of the posterior branches of the portal vein couldn't be controlled before this transection. So we need to change the plan right during the operation. We resected the vein, you see, controlled this bleeding, also clipped this vessel. I want to say that the total blood loss during this operation was about 800 millimeters, and postoperative period was uneventful. And we decided to put, after we resected the vein, the distance between the margins of the vein were about 5-6 centimeters. So we put the artificial graft, as you can see here, and you see that laparoscopic approach provide all the possibilities to finish this operation, and the operating field, to our opinion, looks like it looks in open procedures. So in our experience, we analyzed our results in open robotic and laparoscopic procedures and selected about 200 of patients. We selected the patients in which we managed to collect all the data, characterizing the preoperative, intraoperative, and postoperative results. So overall survival was practically equal, a little bit better in laparoscopic group, but these differences were not significant. So we analyzed the results using the method of textbook outcome. It's the method which came for us from colorectal surgeons, and perhaps you know this group of authors from all over the world choose this criteria for ideal outcome for after pancreatic duodenectomy. They are presented at the slide. So, and if you reach this textbook outcome after surgery, you see there are some publications. Here is one of them that say that shows that these patients who reach this textbook outcome have better overall survival. So in our experience, the average achievement of textbook outcome was about 64%. In laparoscopic group, again, a little bit higher, but without statistical significance. And the influence in overall survival also was, so the patient who reached textbook outcome, the median of OS was 28 months, and no textbook outcome 21 months, but these, again, differences were not statistically significant. But if we analyze it combining the textbook outcome together with the malignancy potential of the tumor and take the patients with G1, G2 tumor without lymph node metastasis or vascular invasion, we will see statistically significant better overall survival in these patients. So this textbook outcome, we think it's a little bit a little bit new measuring of the results, but we think that it is very useful to use it because it makes some standards for the surgeon and some motivation to achieve better results. Another thing that we started also using in our experience in our hospital, it's patient-reported outcomes about the surgery because it's interesting to compare how the patient think about different types of surgery. So we constructed the questionnaires, so 56 questions, and gave to the patients who went through the laparoscopic or open procedures in 1, 3, and 6 months, and for estimating surgical outcomes and compare it with functional recovery. So, and it's very interesting that during the first and the third months, and especially the first months, patients after laparoscopic procedures were much more satisfied with the surgery in global health status, in different signs like fatigue, nausea, vomiting, weakness, weight loss, and so on. And it is also very interesting, and I would like to put your attention on that in such component like future worries about future surgery. Also, the patients who are waiting for minimally invasive technique for their operation were much more better in their, much more less in their worries. So, but these differences, they went to 0 up to 6 months, and in 6 months, everything was equal after open laparoscopic procedures. So we can conclude that minimally invasive approach provides better early postoperative period and better opportunities for early beginning of chemotherapy, and perhaps that may influence on overall survival and on long-term results. And at the end of my talk, I want to emphasize that is, to our opinion, it doesn't matter. So we use laparoscopic approach, I think about more than 80% in our surgery, in our unit, in more than 80% of cases. But it doesn't matter which type of procedure you use, robotic, laparoscopic, or open approach. You should create this team of teams, because it is very important to have not only surgeons, but have anesthesiologists, nutritionists, gastroenterologists, endoscopists, and very important to have interventional radiologists who provide all the possibilities to solve all the problems after this complicated type of surgery. So it's part of our pancreatic team. It's our some online courses, and we have live demonstrations from our operating room. You can connect it with them, and here's part of our team, whole team. Thank you.
Derek, yeah, you have a question from Derek?
Congratulations. It's wonderful surgery and wonderful outcomes. The only problem is that not every surgeon can achieve this, and it's a question of generalizability, and many bad outcomes and results have been done with laparoscopic whipples. I want to ask you about robotic surgery, because I think that may solve a little bit of the problem. It's technically easier to do than laparoscopic. It gives you back the wrist action, maybe more control, and perhaps more surgeons will be able to do safe robotic pancreaticoduodenectomy than laparoscopic. I don't know what your thoughts are about that.
So in our experience, we don't see this. We see this from the experience of many surgeons from all over the world, European, United States, and South Korea, China. A lot of surgeons who use robotic approach with great success, but there are no studies that confirm this. No studies that confirm that learning curve is shorter. To my opinion, it's my personal opinion, I tried. So I use robot for colorectal surgery a little bit, But I don't feel the wish to start. It's perhaps because I have personal experience in laparoscopic procedures, but perhaps I'll start. I'm thinking about this. But for today, we have about 60 procedures by robots, by two surgeons in our hospital. To this moment, it goes quite difficult in our experience. But I think that future is very big for robots, but I'm not sure that in pancreatic duodenectomies.
Thank you very much. You're right. We do need to see some comparative data.
Yeah, thank you.
So thank you. Actually, the comments are valid because worldwide we haven't seen any change between laparoscopic versus robotic. The results are the same at the moment, but the cost is different for robotic compared to laparoscopic. So the cost factor becomes an important consideration.
Yes, the cost is much more higher, but it's interesting simply to the thing that we should think about which we should think. The last Congress of AHPB in Ireland, it was in Dublin, there was one talk that shows that robot is cheaper for pancreatic surgery. So
that's interesting.
Yes, we should think about this.
Any more questions from the floor before we move on? If not, thank you very much. Congratulations.
Thank you.
So we're going to move on to the next speaker, Dr. Vijay Mittal from the US. He's talking to us an update on pancreatic and islet cell transplant. Dr. Mittal, please.
First of all, I want to thank Romero and the Executive Committee of the Society of Surgeons of Nepal for inviting me, and greetings from the auto capital of the world, Detroit. I'm going to touch a topic which is very close to my heart, and I have put in almost 30 years into this whole process. Pancreatic transplant as a cure for diabetes. There are a lot of causes, everybody knows about it. We have blamed a lot of things, but for the juvenile diabetic, when we initially thought about pancreatic transplant in '78, there was a ray of hope for the juvenile diabetic to prevent secondary complications, which are retinopathy, blindness, kidney failure, and cardiopathy. The purpose was to replace the beta cells in whatever form we do, whether it's a vascularized pedicle or whether it's a beta cells, which is the islet cells. So we did consider whole organ transplant. Then later on, we thought about the segmental living-related pancreas and the beta cell transplant. Now, lately, I think the things are changing. Bariatric surgery has come up for treating obesity. And there was an article in 1980s, partial gastrectomy as a cure for diabetes. I think that's. So we usually take disease, pancreatic organs. There are 3 types of transplants we can do, either simultaneously, pancreas and kidney transplant in renal failure patient, or we do pancreas after kidney, which is a PAK, and pancreas alone in very brittle juvenile diabetic young people. So these are the 3 and the indications. This is my longest surviving patient of the pancreatic transplant. Now it's 42 years. So I think I always show his picture. I still follow him. And option, as I mentioned, transplant versus islet cells. This is our guru in the pancreatic transplant, David Sutherland at University of Minnesota. He just passed away last year. Remember him? So this was the first group in the world. We were only 12 people in 7 centers, 4 in United States, 1 in Sweden, Karolinska Institute, and Lyon, France, with Dubernard. So we usually used to meet every month in US itself. So what are the changing demographics now? Total number of diabetics is increasing tremendously. We estimate in 2045, 1/3 of the world population will be diabetic or pre-diabetic. Number of pancreatic transplants are at a very stationary number. I'll show you that picture. Number of transplant centers are decreasing because it's costly to run a pancreatic transplant center. So I'll show you that thing. And then now we are considering type 2 diabetic for pancreatic transplant and islet cells. That's another addition to our donor availability is an important factor because the wastage rate of pancreatic organs, the surgeons are to be blamed for that. We rejected 20% of the organs worldwide. So we wanted to utilize now them for the islet cell, and we have opened a bank in St. Louis now for all the organ rejected so that we can extract the islet cells. As I mentioned, pancreatic transplant versus bariatric surgery. COVID has given a hit on the transplant field as such, because in COVID era for 2 years, the transplant centers worldwide were almost 30 to 35% down in numbers. So these are the diabetics I mentioned. In US, we will have close to about 102 million in 2045. Total diabetics increasing almost 10 to 15% every year. This is 2004, 9, 14, 19, and then 24. We are now close to about 25% of the southwest portion of the United States. The population is diabetic or pre-diabetic. If you look at diabetic around, in 2021, we were 51 million in North America. Southeast Asia was 90 million, 61 million in Europe, 32 in South America, so close to about 400 million people were diabetic in 2021. And if you look at it, estimated in 2014 at the increase rate of 10.9% total in 2045. This is the number of transplant, pancreatic transplant are done. If you look at it, US numbers are very stationary, plateaued. And if you look at the non-US countries, their numbers are increasing and at the rate of 12% every year. These are the progress in the pancreatic transplant cases. If you look at it, in Europe, we are 21% down. In the United States, we are only 0.4% up. And if you look at the Southeast Asia, we are 37% up. So there are new interest in pancreatic transplant development. These are the countries, as I mentioned, transplant per million population. Finland is at the top, surprisingly. And if you look at it, India is in the end. We have only 2 centers, I think, in India who are performing pancreatic transplant at this moment. These are the number of pancreatic transplant centers in the United States. If you look at, we used to have 1,200 transplants a year, and now our number of the transplant center is down to 1,000 from 1,400. So there is a significant decrease. We have 11 regions in the United States for the transplant areas under UNOS, United Nations Organ Supply, which is the federal government center. And then we have pancreatic transplant centers decrease in number. This is a pancreatic transplants around the world. If you look at it, I mentioned some of these shown in the bar gram. Now, if you look at the type 1 and type 2, 80% of the patients who are coming for transplants are type 1 juvenile diabetic. but now there's an increase in the green column for the type 2 diabetics. Wait list is very long. This is the donor availability. In the United States, we have 1,500 donors available every year for pancreas. We are utilizing only 900. So there's a wastage of close to what now 30%, but now we are going to utilize for the islet cells. This is some of the pictures now you will see. This is a bench surgery which we do for the whole organ. We harvest the organ from the cadaver along with the liver. So we give vessel to the liver, and we have to do some bench surgeries. Oh, this was that gastrectomy and diabetes, I think pictures. Yeah, there it is. This was in 1980, it was published. And that is the pediatric surgeons claim that we can remission rate of 92%, which is not, for how long we don't know. This was during the COVID period I mentioned, and the transplants were down all over the world. Even the pancreas, if you look at it in the middle section. Now let's look at some technique and the outcomes. So we have to deal with the vascularized versus islet cells, cadaveric versus living, I mentioned, SPK, PTA, or PAK. Now the main problem will be drainage of the exocrine, whether we drain into the bladder, drain into the small bowel, or drain into the stomach. I'll show you all the pictures. Venous drainage has come up to a controversy, whether we drain systematically or we drain in the portal circulation as physiologically the organ is. Immunosuppression reaction is very much improved, and then we'll talk about the patient and graft survival quickly. So this is the harvesting. This is, you look at the organ from the back when we were harvesting, pancreas alone and liver was not harvested. Then we get the curl patch of the aorta, good size of portal vein, and we were very happy. Now what happened, we have to do bench surgery for pancreas because we give significant portion of the portal vein to the liver team, and so is the artery. So we take a bifurcation of the iliac artery from the cadaver and a portion of the external iliac vein for transplanting as a bench surgery at the back. The anastomosis, vascular anastomosis is done to the external iliac artery, and the vein goes into the external iliac vein. Now this is portal vein drainage. Now we have started putting intra-abdominal pancreatic organ, where we do to the end to side with the portal vein. But the arterial anastomosis stays down in the external iliac artery. There are some advantages and disadvantages of it, but on a long term, it does not make any difference in the survival or the rejection rate. Now, as I mentioned, the technique, systemic versus portal, we do 80% systemic, 20% portal, and in the exocrine drainage, 80% enteric now, and 20% in the bladder still. This is draining into the bladder. We take a portion of the duodenum loop and drain into the dome of the urinary bladder. And if you look at the other, is we are going to do this with the staples or hand sewn. This is in the small bowel. You bring a loop of small bowel extraperitoneal, making a cut in the peritoneum, and then take our duodenal loop and anastomose to the ileum and then secure around the peritoneal defect. This is, I think, the last couple of years we have started looking at put the organ as physiologically as possible. So we put the pancreas near the portal vein. The portal vein goes to the portal vein of the recipient, and then the duodenal loop, which will be anastomosed to the back of the stomach. So it's a portogastric technique of pancreatic transplants. It's done at 2 places now. One is in Louisiana and the other one is in Illinois. So this is how it looks like. Now the bladder drainage, there is always some disadvantage with the urinary tract infection. Enteric drainage is much better, but in bladder we can monitor the rejection rate. These are the advantages and disadvantages. These are the outcome. If you look at the pancreas and simultaneous pancreas kidney transplant is the largest number. And this is the immunosuppression regime with the tacrolimus and MMF plus steroids has the best results. We have about 92% 5-year survival now of the pancreas and kidney simultaneously. PAK is about 78%, but pancreas alone is about 40%. This is what is 95-7, 90%, 87, and 86. These are the pancreas transplant failure rate is about 10 to 15% over 5 years. Graft failure definitely happens in 5%. Kidney failures when the simultaneous kidney pancreas we do is also about 10% failure rate over the 2-year period. There's a lot of problem with the pancreatic transplants. We have 5.5% failure, technical failure rate, graft thrombosis, infection happens, and they are very minor and treatable. Just give me 1 more minute and I'll give you the history of pancreatic islets. This is all around the world, how much we do. Number is limited. We do only 1475 in 715 patients, so it's 2 infusion. And same thing is in Europe. This is Paul Lacey who started this thing. Problem with the islet cells is inadequate islet cells. In 1 pancreas, we get only 300,000 islet cells as compared the extraction rate is less. This is how we prepare it. This is Paul Camillo Ricordi who started the machine, automatic machine to get the cells. And this is how it looks like. Then it goes into the liver. This is in our radiology suite, we do it. And better standardized isolation technique. Liver site is a preferred site, better immunosuppression, and there's some tolerance developed when we do the islet cells. So islet cells has a future, but it's still to be done. Recommendation in a diabetic patient is, if patient is diabetic with renal failure, we advise SPK. Liable diabetic with severe hypoglycemic attack, PTA alone, and then we consider pancreas if a stable renal failure with diabetic. And stable diabetic with no renal failure, not a candidate for pancreatic transplant. We advise now bariatric surgery. Thank you very much.
Thank you, Dr. Mittal. Any questions from the audience? If not, I have one, Dr. Mittal, if you don't mind. You mentioned that the diabetic profile worldwide is about 3/4 in the poorer populations out of US and Europe. But the majority of transplants are actually in the US and Europe.
That's right.
So it's a big discrepancy between...
That's why I was showing in the developing countries, the increase in pancreatic transplant is 35% more.
Correct.
As compared to Europe and United States, we are very stable.
So even though it's increasing in percentage, it's actually a very small increase by number alone.
It depends will be the organ availability in these countries.
Yep.
People are going just for doing, but can they sustain that number?
Correct.
Will be a problem.
So the issue that I was going to ask you is, in terms of starting a transplant program, whether it's islet cell or whole organ transplant, the cost of setting up a service is tremendously high, not just in terms of expertise, but infrastructure setup and donor setup as well. What are your thoughts about going into other directions like gene manipulation for hepatocyte, for example?
Yeah, gene manipulation is on the grounds now. We have isolated at the NIH now. I work at that study myself. We have found a gene in a family So we are going to work on that gene, whether we can change the mutation of that gene in that particular patient. So that's, I think, maybe another 5-10 years. So diabetics will have a much better avenue once the gene manipulation can be done.
So I have one question regarding why is survival so low for the pancreas-only transplant compared
Pancreas
to...
transplant alone survival is because when we do the kidney and pancreas, the immunosuppression, which is for the kidney, has a beneficial effect on the pancreas. So it's like a synergistic effect on the pancreas about the kidney immunosuppression.
Thank you so much. So I think if there are no more questions, we'll move on to our next presentation. Thank you so much, sir. Management of pancreatic necrosis by Dr. Praveen Suryavanshi.
मिरर गरेको ठ्याक्क त्यहाँ यहाँ चाहिँ यहाँ चाहिँ
कहाँ
रेजोल्युसन रेजोल्युसन
कहाँ यता आएर हो
एकछिन यसले म चेन्ज गर्नु पऱ्यो एक्सटेन्डेड डिस्प्ले युज गरौँ
युज एक्सटेन्ड गर्नु
यहाँ त आयो तपाईँको
यसो गर न त्यो तानेपछि डुप्लिकेट गर्यो भने मिरर
गरौँ सिधो सिधो
So give me the next slide. So
पसन्द
छैन अहिले आएकै छन् डिस्प्ले आएकै छ यसो
It's not working on this.
No, it's not working.
It's not working.
एकचि कन्भर्टर जोडेर
Can you use from there?
Yeah,
you can use from, but
there is no
you don't have there. Can you have the next? Can you have the next one? Last one?
So there are some technical issues. In fact, we don't have another presentation, so we'll just have to wait for some time. we're ready to start.
I apologize for this delay. In fact, initially I confirmed and it was working there. But no. Sorry. So respected chairperson and respected all senior teachers and colleagues and dear friends. I'll be talking on the management of pancreatic necrosis, more on the technical aspect, what we have developed over the few years. So I don't have any conflict of interest, and I bring greetings from the Association of Surgeons of India, also from my alma mater, that is MGM Medical College and Hospital, Chhatrapati Sambhaji Nagar. This is also my city is famous for the World Heritage UNESCO site of Ajanta paintings and this Ellora caves. This Ellora caves is especially, it is a complete temple carved out of single rock. It is almost 150,000 square foot construction, which is carved out of single rock thousands years before. So as far as definitions of necrosis is concerned, it is a mature and encapsulated collection of pancreatic and peripancreatic necrosis that has developed well-defined inflammatory wall, especially after 4 weeks of episode of acute pancreatitis. So this assessment of necrosis can be done with CT scan. As a surgeon, we should prefer CT scan because we can plan our surgical planes and also the site where we can do anastomosis with the lumen and the vascular associated structures like the splenic vessels. If there is a splenic artery aneurysms, everything can be well assessed on the CT scan. MRI should be done only in cases when there is no obvious necrosis and you want to quantify necrosis to select the treatment option, whether to go for the endoscopic necrosectomy or laparoscopic necrosectomy. In that case only, MRI should be done, otherwise it should not be done. So this is, as I mentioned, we should not just look for the size of the necrosome and its location, but the important vascular structure which are at the bed of the necrotic cavity, or sometimes it may be traversing through the necrotic cavity, has to be assessed on the CT scan. Nothing should be surprised intraoperatively. So again, you can see in this patient, there was active bleeding in the necrosome. Contrast gush was there. So all this has to be assessed on the CT scan. In this patient, there was a splenic artery aneurysm, which was protruding into the necrosome. So all this has to be assessed carefully before operations. Again, in this patient, there was a tense pancreatic ascites with the necrosis. If you are doubtful about the amount of necrosome, the best investigation in today's practice is the endoscopic ultrasonography. Here exactly we can assess the amount of necrosome and whether associated complications are there for to selectively select the best surgery for the patient. So the goal of the surgery should be to drain infected fluid, excise completely devitalize and necrotic pancreatic and peripancreatic tissue by preserving the normal pancreas and avoid complications like bleeding and injury to the surrounding organs. So traditionally we used to do open necrosectomy, and we all know it was associated with a lot of perioperative stress, organ failure, pancreatic fistula formation with the pancreatocutaneous fistulas and the incisional hernias wound-related complication. And this is a benchmark paper which was published in 2010 by the Dutch group, who suggested this step-up approach. Initially, when patients in sepsis, put the percutaneous drain, control the sepsis, buy some time till you reach the cross the 4 weeks of acute pancreatitis, and then you plan some definitive treatment in the form of either minimal invasive surgery. So unfortunately, most of these studies, they compare endoscopic management with the either open surgery or the retroperitoneoscopic surgery. But the other minimally invasive approach, that is laparoscopic approach, is not well assessed. And if you see many papers where there are multiple sessions of endoscopic treatment management, ranging from 3 to 15 sessions were done to get the effective control of this pancreatic necrosis. So what we thought that since there are minimally invasive technique which has been advocated, it can be endoscopic, it can be retroperitoneoscopic, or it can be transperitoneal laparoscopic also. So being a surgeon, what I feel, It is a, like if you do transperating necrosectomy, it is a saline through a known sea. And also we can achieve extensive necrosectomy in a single setting, which cannot be done endoscopically. And also we can tackle multiple pockets, the pockets in the pelvis, pockets in the paracolic gutter, which cannot be managed endoscopically. That can be done laparoscopically. And not only that, other complications like bleeding, perforations, bowel fistula, all those can be managed effectively laparoscopy in a single settings. And also, if there is a etiological factor like gallstone pancreatitis, cholecystectomy can be also done in the same setting. The only hue and cry about this approach was the risk of contamination of the peritoneal cavity, which is otherwise a sterile cavity. And second was the fistula formation after surgical necrosectomy. So to address all these issues, what we have done, the transperitoneal, transgastric, intraluminal necrosectomy. So I will explain how we are achieving this. So we are eliminating the risk of the peritoneal contamination also, and also the post-operative fistula formation, but simultaneously giving all the benefit of minimal invasive necrosectomy and, to the patient. So what we do, once we do open the anterior gastrostomy, we just puncture the posterior wall, and inside the gastric lumen, we suck all inflammatory fluid inside the gastric lumen without contaminating peritoneal cavity. So once the cyst cavity is adequately decompressed, then we do open wide cystogastrostomy. It can be done either a stapler or with the harmonic, and then whatever loose necrosome is there inside the necrotic cavity, that we excise just gently with the rotatory movement. So most of the times there is a wall of granulation tissue, and this necrotic tissue is well separated from the surrounding granulation tissue. So once this, whatever loose necrosome is there, that is completely extensively excised, then we can go inside the cavity, inside the lesser sac, and do further extensive necrosectomy under vision. So this is how whatever loose necrosome is there, we are just taking out gently, just with the rotary movement. We should not use any energy source or the scissor to do this necrosectomy. So once this loose necrosome is taken out, whatever adherent necrosome is there at the bed of the pancreas, that also we can loosen up with the blunt suction cannula. Also, if you are very close to the vessels, we can do hydrodissections. So now here you can appreciate I'm at the in a splenic hilum, and this is the the lower polar splenic vessels, and there is a necrosome around the splenic vessels, and I am doing hydrodissection to take out the necrosome under vision. So such extensive necrosectomy cannot be done endoscopically, but we can do under vision safely laparoscopically. This is another patient. You can see there are multiple adhesions in the peritoneal cavity, and there were multiple pockets in the pelvis and in the Morrison's pouch. So again, we did this anterior gastrostomy, and then after adequate incision, then we just puncture the, why I'm showing this, that this is doable in each and every patient. So again, posterior wall, we just puncture with the harmonics blade without making a wide opening. And once it is punctured, we suck all the inflammatory exudate inside the gastric lumen without contaminating peritoneal cavity. Again, you can appreciate we are again sucking out inside, and once it is adequately decompressed, and then we make large posterior cystogastrostomy. And when this cystogastrostomy is done, then we again go inside and do further. So you can assess again all these inflammatory exudate can be sucked out under the vision and with complete extensive necrosectomy. Even if there are the pockets going into the mesocolon, we can go from the epigastric region, we can shift your camera port to the epigastrium, and we can go behind the mesocolon, and if the pocket is continuing into the left paracolic gutter and to the anterior to the kidney, even we can go that extensively with this approach. And now we can appreciate all these extensive necrosectomy can be achieved in single sitting. Same patient, as I mentioned, this patient had the pocket in the Morrison's pouch. So again, we opened all those adhesions, and that pocket was again drained adequately. So all these multiple pockets can be done, managed very effectively in the single setting. Another patient where there was extensive massive bleeding after this percutaneous catheter insertion, and you can appreciate there was a lot of blood. Patient was in the shock, and then he was referred to us for the management of the endoscopic, management complication of the endoscopic management. Now you can see we control the blood and all these extensive necrosectomy. This patient was treated constantly for almost 8 weeks. And then you can see this is a splenic vein here, this is splenic artery, and this is how we do hydrodissection around the vessel to achieve complete extensive necrosectomy. Same patient, again, there was a pocket in the pelvis that will also drain effectively. Again, if there is a standalone pocket in the paracolic gutter which is not connected to the retroperitoneum, what we do transperitoneally, we just access that pocket, but we put the another trocar retroperitoneally from the flank, and through retroperitoneally we do all extensive necrosectomy without contaminating peritoneal cavity. So both the pockets, retrogastric and the paracolic, away from the stomach, can be managed effectively in the single setting without any changing the patient's position. So again, all these loose necrosome is separated, and again, we can appreciate I am doing hydrodissection at the splenic hilum. So only concern during this necrosectomy is the bleeding. Most of the times this bleeding happens from the granulating wall of the wall of necrosis, and these are the most of the time oozers from the venous vascularized venous small tributaries. So most of them, they are well controlled with the compressions. Here you can appreciate I was trying to do necrosectomy from the uncinate process. This is the pedicle of the superior mesenteric artery and vein. So after doing necrosectomy, there was oozing. I just packed with the gauze pieces. Meanwhile, just give in a 15 to 20 minute time, do some other job and come back. You will find in most of the cases, these bleeders will stop. If you not use any energy source like the Caesar or harmonic, we need not to bother about this bleeder. These are the venous bleeding for the venous sites, and they very well respond to the patient's compression. So after this compression is taken out, now we can appreciate there is no bleeding. So the key mantra here is not to use any energy source for the necrosectomy. So this last pack is taken out, and you can appreciate there is complete control of the bleeding. So then, what is the role of retroperitoneoscopy? Again, if there is a standalone collection in the paracolic gutter without any collection in the lesser sac, then you can go ahead with the retroperitoneoscopy. Again, in the prone position or the left lateral position, we go inside, mark the lesion depending on the, we mark everything on the CT scan, and then lose all the necrotic tissue, and then you can achieve extensive necrosis in one setting. You can appreciate this is the amount of necrosome, and at the end there is a very well granulating residual wall of necrotic cavity. Just what is the role of endoscopy then? Endoscopy is the treatment of choice if there is a pseudocyst without any necrosis which is communicating with the pancreatic duct. You can appreciate this is a pancreatic duct and there is a communication with the wall of pseudocyst. So in that case, do just pancreatic stenting, this patient will respond wonderfully. Or in patient, if there is a pancreaticopleural fistula formation, if this is the pancreatic duct and you can appreciate the tract going into the pleural cavity. So do wide pancreatic sphincterotomy, do pancreatic stenting, this fistula is dried up in no times. Another is the pancreatic ascites. You can again appreciate this is the pancreatic duct here, and this contrast is just half minute. Pancreatic is, this contrast is leaking into the peritoneal cavity. So these are the patient very well, this is the indication for endoscopic management in pancreatic necrosis. Or if the necrosome is less than 30% of the total volume of the pancreatic cyst without any complication of the cyst in the form of infection, bleeding, or the fistula formation, then the endoscopic management is the choice of treatment. Or other patients where there is isolated pockets in the subdiaphragmatic region. So you can, what we can appreciate, we did endoscope, this US guided. This is the spleen here. This is the spleen, this is the diaphragm, and there's a pocket here, and there is a very small window between the spleen and the diaphragm to enter into the this collection. So this was the, we entered and did the drainage of this pocket through the stomach. Or we, in some patient, we do, if there is a residual collection of pocket in the surgically done cystogastroscopy, so endoscopically through the wide cystogastroscopy, we go inside and do total necrosectomy for the residual pockets. So techniques depend upon the extent of necrosis, associated complications, patient general condition, available local expertise. So we can use endoscopy, laparoscopy, retroperitoneoscopy. But what I feel, if you really want to give best treatment option, we surgeon must master all those skills. We should be the master of all technology. So we must create future-ready surgeons like this Roman emperor. They were trained to use many weapons in the battlefield as per the requirement. Same way we must train, we should be good anatomists, pathophysiologists, radiologists, skillful surgeon. And after that, we should be endoscopists, laparoscopic and robotic surgeon, not at the cost of the basic sciences. So we must master the science and not just the single technology. So if you master the science and adopt adequate technology, we'll be able to give best possible treatment option to our patient. Thank you so much.
Thank you, Praveen.
Sorry for extra 1 minute.
No, you make a very difficult situation sound very easy. But thank you for a very comprehensive overview of pancreatic necrosectomy and management of pseudocysts. Any questions from the floor before we end this session? I think we have time for one quick question. Yes.
Experience you've shared. Now, we've adopted the same principle for the last 4 to 5 years, but there's something else we're doing is for retroperitoneoscopies, what we found is using a TAMIS port is actually more helpful than just using a laparoscope. So when you've got a TAMIS port, you can actually insufflate better. You've got an irrigation suction device as well, and you can irrigate at the same time. So like you said, some cases, it's mainly the retroperitoneum that has the collection and the necrosis. But absolutely excellent talk, exactly what we are trying to follow these days. And one other thing we are practicing in our unit is we ask the radiologist to put a transgastric into the cyst. So that drain is kind of, slowly we grade it up. And we start with a 12 French and we keep going up. And by the time it's 6 to 8 weeks, it's got a big size drain there. And that drain helps us to create your anterior gastrostomy as well as your posterior. And like you said, we just staple it and then do the necrosectomy. So I found, like you said, when you've done that, the mortality just comes down. And the last 3-4 years, we haven't had any further mortalities in this kind of step-up approach. Absolutely beautiful talk.
What I would like to stress here that as a surgeon, we must master all these techniques so that we can offer the optimum treatment choice to our patients. Otherwise, what's happening, if we master just single technology, we try to fit everything into that technology, what we have mastered. And in that bargain, we lose the optimum treatment options. So all this endoscopy, laparoscopy, we do ourselves in our department. Thank you.
Praveen's point to the young trainees in the audience is that we should widen our repertoire of possible use of treatment techniques that you are going to be trained in. So the more you're able to do different treatment methods, the better for us in terms of management. So I think Praveen, that message is well taken. Thank you very much for sharing with us.
Thank you.
On behalf of my co-chairs, I'm going to end this session for now and hand over back to the committee. Thank you very much for joining us for this session 3.
Thank you for the presentation, sir. We will now shortly begin with the distinguished A.K. Sharma oration. Ladies and gentlemen, let us now begin. It is my honor to introduce Professor London Lucian, a leading HPB surgical oncologist and one of Singapore's most accomplished academic surgeons. He is the Group Director of the International Collaboration Office at SingHealth and Director of SingHealth Duke University. He also serves as a senior consultant in HPB and transplant surgery at SGH and NCCS. Professor Uy has held several major leadership roles, including chair of surgery at SGH, founding director of SingHealth Transplant, and deputy medical director of NCCS, and has had over 250 publications, multiple book chapters, and serves on numerous national and international committees and examination boards. His contributions have been recognized through prestigious honors such as the Asian Surgical Association Lecture and National Outstanding Clinician Mentor Award. Please join me in welcoming Professor Dr. London Lucian for the A.K. Sharma oration on surgery and surgical training in Singapore, collaboration in skills training, technology transfer, and research.
The Society of Surgeons of Nepal duly recognizes your academic excellence and unparalleled surgical journey and hereby awards the distinguished Anjani Kumar Sharma oration to Dr. London Lucian Oy on the day of 21st November 2025. Sir.
Before we start, just a personal note. In his short CV that he has sent, Professor London has mentioned that he has been training HPB fellows throughout the region, and they're from India, from Philippines, from Brunei, and Nepal. And I was the lucky candidate from Nepal. In 2000, I had the great opportunity to work with Prof. London, and he really taught me HPV surgery then. And he's been my close friend and mentor since then, and we have been in communication, although we're meeting after 25 years. And London, as I can say, is not only an excellent teacher, is an excellent person. And my children, who have now become big, my wife, we all remember the great hospitality that Prof. London and Kathy, his better half, gave us during our stay in Singapore, and we never felt that we were away from home. Thank you, Prof. London, and thank you for accepting this oration. Thank you.
Sir, please.
So Sunil and Romeo, thank you very much for this great honor to be here in Nepal. And of course, thank you to the Society of Surgeons of Nepal for this kind invitation. It's indeed a great honor to be delivering this special oration for Professor A.K. Sharma, Sunil's dad, obviously. And we have become friends over many, many years now, as Sunil has mentioned, the last 25 years. And it's great to be in Kathmandu, although it's for the first time. It's been a great experience that me and my wife have both enjoyed in the last couple of days for your hospitality, Romeo especially. Thank you very much. Can I have my first slide, please? Okay. So as a tribute to this oration, can I just share with those who are not from Nepal a little small bit of what I know of the Professor A.K. Sharma. He was born 7th of June in 1928 in Baluwahi, Suraha district in Nepal. And he got his MBBS from Kolkata Medical College, India in 1955. And what was more important, he went on to get his fellowship of the Royal College of Surgeons of Edinburgh in 1962. Now, he has got too many achievements to mention. I have summarized a few. He was the founder for the Department of Surgery in Burr Hospital in 1962, the first hospital surgical unit in Nepal. And also the head of Department of Surgery Institute of Medicine in 1978, and the head of surgery at Tribhuvan University Teaching Hospital. He was also the founder for the Baktupa Cancer Center and co-founder for the Nepal Medical College. Having done all this, he's been recognized, obviously, as the father of modern surgery in Nepal, and also the father of modern surgical education and training in Nepal as well. So given this background, I've been asked to share with you what his passion has been, which is surgical training education. So my talk for today will be focusing on surgery and surgical skills training in Singapore and how this has evolved over the last 200 years, and with a special focus on looking at collaboration in skills training, in tech transfer of different sorts, and also in research. This is Singapore. We don't have a nice skyline that you have in Nepal. We took a flight this morning to see Mount Everest and the ranges, and it was beautiful. In Singapore, all we see are tall buildings, no tall mountainous ranges. And we welcome you anytime to come and visit us. Please pay us a visit. My background, as mentioned, I'm a HPB surgeon by training. I'm still operating and still seeing patients, but I hold multiple roles in Singapore General and the National Cancer Center as well. I've been privileged to be involved in many societies in the region, especially in the ASEAN Pacific region. Now, in context of what this lecture is about, I have over the years held several roles in different committees at the national level at the Ministry of Health and also in the universities. And it's in this context, I'm sharing with you the evolution of surgical training over the last couple of years. The scope for this afternoon, I'm going to share with you in 4 different time frames. The pre-1970s, which spans about almost 200 years, which was before specialization came about in the Singapore context. And then from 1970 to the 2010 period was a primarily UK-based training system that we adopted in Singapore. And then from 2010 to 2025, which is just this year, a very US-based system. And the transition was important because we saw how we took different training programs from the UK system and from the US system. We tried to use both systems to some extent, and then from this year onwards, we're going our own way. So let's start with the pre-1970s, before specialization. This is our College of Medicine building in Singapore, which is where the first medical school was and where I studied medicine in my younger days. So in 1821 was when the first medical outpost in Singapore was established. This is just 2 years after the founding by Sir Stamford Raffles, who came from UK at the time, from the British East India Company. And that was the beginnings of Singapore General Hospital as we know it today. The medical school came on much later in 1905. In those days, there were no medical students in Singapore before that. They all had to go to England for medical education. By 1905, a group of Singaporean merchants, if you like, who were wealthy, decided to support the establishment of a local university. And this was the start of the Straits Settlement and Federate Malay States Government Medical School, which in 1912 was renamed the King Edward VII College of Medicine. But it was not that long later that we had our first lecturer in surgery. And this was Mr. E.D. Whittle, who was a Scottish medical officer based in Penang. Penang is a small island just north of Singapore. In those days, we were still a British colony, and Mr. E.D. Whittle came down as our first lecturer in surgery. And only in 1922 did we have our first professor of surgery, again from the UK, Mr. Kenneth Black, who also introduced ophthalmology to our system. Now, we had to wait several longer years before we had our first professor of surgery locally. The first Singaporean professor was our Honorable Professor Yeoh Kim Seng, who was a general surgeon by training, but also went to cardiac surgery in those days and did the first open heart surgery in Singapore in about 1957. He later became Speaker of Parliament and went into politics as well. But in those years, pre-1970s, it was an interesting time for us in Singapore because there was no formal structure of training. If you want to do surgery, what you did, you found someone who was a surgeon, trained under them as a disciple of sorts, as an apprentice. And when it was time for you to go and get your degree, you usually went to UK for your certification, either from one of the colleges in UK. In those days, because of the rules and restrictions, we could only do the FRCS Edinburgh or the FRCS Glasgow. So Tim, if you remember, in England in those days, we couldn't do the English exam. So Singaporeans in those days were primarily going to Edinburgh and Glasgow for our degree. And John will appreciate that. So this is how our training program was like pre-1970s. Housemanship 1 year after graduating from medical school, then a period of time as a medical officer. This time frame can vary between 3 to 5 years, in which time you did your Part 1 fellowship exam, and the Part 1 could be either Edinburgh or the FRACS Part 1, which was easier for us, it's MCQ based. And when you did that, you did FRCS Part 2 in Edinburgh or Glasgow, and then you became a registrar after that. So it's unstructured totally, no time frame duration, no selection process. You find your mentor and you carry on. This is pre-1970s. Now we come to the period where most of our surgical training was being set up and established in the country, and this is from 1970 to 2010. This was probably the most structured period of our training program in the country. In 1970, just about 5 years after independence, Singapore was founded only in 1965 as an independent country, as a republic. And 5 years later, we realized that we had to establish our own training programs to set up specialization in the healthcare system. So the Ministry of Health set up this thing called the Specialist Accreditation Board. This board was designed to look at how we will oversee training, and this was delivered through the Joint Committee of Specialist Training called the JCST. And the JCST was then divided into multiple specialist training committees called STCs. And STCs were divided into general surgery, into internal medicine, and so on. And I was thankful to be able to chair the STC after I completed my training. Now, in those days, there was a fair amount of tech transfer required. As a young country with no background in academics in terms of training of surgeons and physicians, we had to look at tech transfer, and we looked at different colleges around the world. And the closest one that could support us was the Edinburgh College of Surgeons. And it came across fairly early on to help us set our curriculum. So we used a syllabus from the Edinburgh College. They helped us set up assessment systems. And we then went on to establish our Masters of Medicine Surgery in Singapore as a conjoined exam with the FRCS Edinburgh. And that has existed for the entire period from 1970s until 2010. So our first training program, Surgical Training 1.0, looks like this. 1 year of housemanship, usually about 1 year plus of a medical officer training program, so you get your groundings as a medical officer. You then went on to apply for traineeship, and you entered what is called MO training program. So the medical officer trainee will be basically a basic surgical trainee. And this lasted for 3 years, during which time you took your Part 1 and your Part 2, after which you went on to become a medical officer specialist for an undetermined duration. And the time frame I put down between 0 years to whatever time frame before you enter advanced specialty training as a registrar. The time frame becomes quite long if you look at it. And of course, the exit at the time wasn't exam-based. The exit was based on interview. The candidate who completed the registrar training after 3 years attends an interview by senior surgeons. If he passes that, he becomes a specialist thereafter. So fairly structured, but yet unstructured. Some degree of curriculum, but not quite there. Now, at this time frame also, the government realized that as a young country with young trainees trying to be surgeons, there were many gaps in our training program. There were many gaps in our service delivery. So for example, although we could do some general surgery, we couldn't do such specialized skills. And therefore, the government introduced a thing called the Health Manpower Development Plan, something that was to us very useful for sending surgeons overseas to pick up skills that were not available locally. This was actually for durations up to 6 months to 2 years, but there was also a bond when you came back. And the bond was important because if you send someone for 2 years and you come back and you leave for private practice, you lose the skill sets. So upon return, most of us were bonded for 5 years. So this is me in my younger days. Sunil, I was a fellow like you. I was a fellow in Australia with Russell Strong. So Professor Strong was the first surgeon who did the successful living donor liver transplant in Australia, in Brisbane. And this is where I met my wife also at the time. So it was a fruitful training period for me as a young trainee, as a young fellow. Now, there was also a need to embrace science because, you know, as we are learning skills in surgery, we also need to understand disease processes and how to overcome diseases as a means of finding solutions. And that became an important part of our training program. So as a requirement, all our trainees at the advanced surgical training phase had to publish at least one paper in a journal, in a peer-reviewed journal. There was also a big competition for traineeship. I mentioned about the gap between the basic and the advanced training. If you wanted to become an advanced trainee, you had to look at being more competitive. And many programs required us to do a PhD or the MD. And that was the beginnings of academic surgery. In those days, in 1990s, there was an evolution of different things as well. There was a manpower shortage, and therefore there was a need to shorten the training period as a requirement and reducing gaps between training. There was also changing evolution of patient expectations. Our patients expected more now. We became more affluent over time. They wanted more from the specialists looking after them. So registrars looking after patients as primary caregivers wasn't enough. They wanted consultants to be looking after them. So our training program 1.0, as you know it from that time, evolved into 2.0. We removed the gap between basic and advanced surgical training to shorten it so there's no gap between the applications. You apply at the very beginning and you carry on right through for 6 years. So that shortened the training period. We tried to reduce the requirements for assessments, but we recognized that patients wanted some guarantee of quality assurance. So we moved our FRCS Part 2 and MMET conjoint exam to become an exit exam when you completed 6 years of training. So that became the quality assurance, and we removed the interview process from there. But things happen beyond Singapore's shores and also within Singapore as well, primarily in UK. In those time frames, there were certain evolutions. Subspecialization came about. Orthopedics, ENT, urology started to move away from general surgery as a training requirement, and the loss of common exams. I remember as a fellowship exam when I took it, I did orthopedics, I did some ENT and some neurosurgery as well, but that's all gone in those days. It was evolving. And the period for training, therefore, became a bit awkward for the basic general surgery training. So the BST of 3 years became too long for specialties that had their own 4-year advanced surgical programs. In UK also, there was a changing evolution towards intercollegiate examinations among the 4 colleges. And that impacted our association with Edinburgh College because in the collegiate exams, there was a change towards a membership MRCS examination. And we felt that the MRCS couldn't quite link to our Part 1 MMET surgery. So we had to delink that as well. And these were changes that went beyond our control. But it also made us realize as a country that if we were too dependent on overseas countries, we couldn't grow our own system. Because whatever happens overseas, we are affected primarily as a direct recipient of it. So 2.0 had to evolve. So when it evolved, it became 3.0. The MRCS exam we kept because we took the exams from the UK still, and it was held in various parts of Southeast Asia, which was good for us, and also in India as well. And the MRCS now became the exam after 2 years of basic surgery training. From 3 years, it became 2. And the advanced training program became 4 years instead of 3. The MMET has to evolve because it's now de-linked from the MRCS, and the MMET became a thesis base to be more academic. So we're trying to drive towards academics, and the thesis was based on case reviews and topical reviews and assessed by senior academic surgeons. And of course, the exit exam became a requirement. The exit exam was now the FRCS conjoint. The intercollegiate, we couldn't sit anymore. So the Edinburgh College did a conjoint exam with us and Hong Kong College. And it was a new formation of a new partnership and as well as a new tech transfer. So this exit examination was interesting. And I was one of the 3 members who started this. From the Singapore side, I was the chief examiner. The Hong Kong side came in and Edinburgh College came in. And it started in 2002, where we shared expertise from the Edinburgh College, who took ideas and concepts from the intercollegiate exam and brought it to us. And we set up examiner trainings, quality assurance programs, and we had joint exam boards to learn from how we would grow our own programs in Singapore and in Hong Kong as well. And the partnership between Hong Kong and ourselves was important because both of us had a strong British background, both had similar surgical programs, both had similar healthcare systems that could be interchanged. And the collaboration between Hong Kong and Singapore has grown until today. And the Edinburgh College involvement has evolved over time from a tripartite to now a quality assurance and advisory to the 2 parties in Hong Kong and Singapore. So we are evolving and changing also. And tech transfer has become joint development of programs and joint development of questions and so on. HMDP also evolved. HMDP evolved because we realized that if we send people overseas and bring skills back, over some time, we will have all the skills required internationally. And we therefore said we won't send people overseas so soon after their fellowship, give them 2 years to learn the local setting, get the grounding in the basics of subspecialization before going to learn more advanced skills. We also looked at complexity of surgical evolution. Things became more complex. You looked at hybrid OTs, hybrid procedures, and so on. So we went on to team-based HMDPs, where we send teams across to learn how to do surgery, how to support the surgical procedure as well. We also started government-to-government agreements to accept trainees from other countries into our formal programs. And we took from 2 countries, from Brunei and from Saudi Arabia, trainees who did our 6-year program before they exited from the fellowship program. We started this thing called the reverse HNBP, where instead of sending surgeons from Singapore overseas to learn, we took surgeons from elsewhere to come and join us. And that's when Sunil came in, because we brought fellows in to train with us now. And of course, we looked at capacity building. This is some of our fellows that I had with me over time, and being grateful to have taught some of them and become friends over the years. Rolly was my first one from the Philippines. He's now Chief of Surgery in Davao, Southern Mindanao Islands. Of course, Catherine and Sunil were the 2 that were most famous or most notorious when they were with me. They formed a trio that were quite good. And of course, Catherine has gone on to become a leading surgeon in the Philippines as well as in the worldwide region for HPB. And Sunil, as you know, is the top surgeon now in Nepal and HPB surgery. So grateful for your progression. We've had others across the globe as well, from India, from Brunei, from Myanmar, and so on. So these are things that we built in terms of reverse HMDP coming to train with us. And over time, they become trainers of their own setting as well. So tech transfer can go either way. Interestingly, we have gone on to capacity building. Singapore has been fortunate. I mean, we have only 60 years of history, but we have progressed very fast. And we have been lucky in doing that. So how do we therefore build capacity beyond us? We happen to be in a region that is within 6 hours of flight time, heavily LMIC based. A lot of countries around our region can't afford training, can't afford devices, can't afford infrastructure as well. So in terms of capacity building, I'm showing an example of what my current role is as Global International Collaboration Office Group Director for SingHealth. We have been growing cardiac surgery in Papua New Guinea, for example. And how we do capacity building, we bring surgeons in, we bring the specialists in to train with us in cardiac surgery first. So the team gets built over time. When they go back to Papua New Guinea, we help them build the infrastructure of the cardiac ICU, the cardiac theater, the pump machines we try and support and bring across. And over time, we proctor the surgeons there on operations. And we keep going back year by year until they're independent. And this year, they're totally independent now. So that's how we build capacity and how we transfer skills in terms of tech transfer, in terms of collaboration. Now, interestingly, when I told you about the way that we built the collaborations with the UK colleges, we thought, what about medical school education? Because when surgeons are being trained, they must start from a base. And the base for us was a British base, the MBBS 5-year medical school program. But in the year 2000, we said something needs to be done to change the curriculum. And we explored the US medical school system as a graduate entry medical school. So Singapore is the only country at that point in time that had 2 systems existing side by side. So as a teacher, I was teaching the MBBS undergraduate medical students who were between 19 years old to 24 years old. And I was teaching a graduate entry program for students who were 25 to 39 years old when they come to school with a prior bachelor's degree or prior PhD or prior master's program. And the teaching method is very, very different. The way they learn is very different. And the curriculum was very different. But it was important because if you heard Tim this morning, Tim talked about surgeons going beyond just surgery. And we looked at the model of how we want to train our students. So our students, we wanted an end product that was clinicians first. They were doctors first after 4 years of the program. But we wanted them to go beyond that to become clinicians plus. And the clinicians plus could be a clinician innovator, a clinician scientist, a clinician leader, and so on. And based on that end product, we went back to say, what kind of graduates from which kind of programs do we bring into the Singapore curriculum? We looked at engineers, we looked at science graduates, obviously, because of the pre-med requirements. We looked at lawyers even. We looked at arts and social science people. And we looked at business studies and finance people because they can do different things in the healthcare system. And if you change the medical school curriculum, you can then change and create surgeons who can make a difference after their surgical training. So this is actually evolution in progress beyond surgical training to the pre-training component of it. Now, research also evolved. I mean, as surgeons, you know, when I was chair of surgery in Singapore General, I had 16 departments under me from all specialties, including anesthesia and orthopedics and so on, and ENT. It was interesting because we said surgeons don't like bench research. Pipetting, you know, doing gel and so on is not really for surgeons. Surgeons like to build things and develop things. We are more mechanical. So most surgeons want to do biodesign, do innovation in medtech, hard tech, rather than in health tech. And we started exploring how can they learn skills beyond surgery to become surgeon innovators. And we looked at Stanford. Stanford University is very innovative because they have got a strong pathway for innovation, and they've gone to a biodesign program worldwide. And I know that there are only 2 programs worldwide that have partnered with Stanford: Singapore Stanford Biodesign and India Stanford Biodesign. And this program is a 1-year-long program where surgeons learn to work with engineers. So if you look at the screen here, every year there are 4 fellows. And the 4 fellows, only 1 or 2 will be surgeons. And if you look at the list for the 2011 to 2016 period when I was chair of surgery, all of them came from Singapore General as surgeons in the program. And they're working with engineers, working with, some of them were business people, finance background and so on, so they can learn to form a team to look at the problem in surgery, craft a potential solution and prototype, and then go on to potentially do a startup company. And this model has been evolving over time, which is interesting to us because surgeons now become innovators. Now, all that was well and good until 2010. Then the government said, okay, I mean, we have been doing this with the UK system for so many years. Is it working for us? And they looked at certain things, and from 2010 to 2025, a good 15 years, we did a full 180-degree switch from the UK system to the US system. And what changed? So there were some things that we looked at in the previous few years that in the British system, it didn't quite work for us because the timing to training was very, very long. Okay. Number 2, it was more time-based progression in those days and less competency-based, although I know now in UK it's competency-based, but in those days it wasn't. Training was unstructured. There was a curriculum, there was a syllabus, but the standards were quite variable. And a lot of times, the trainees were working as registrars on the job. They were not dedicated trainees in the real sense. They were called trainees, but they were doing clinical heavy loads, and they were working with surgeons on the ground. There was also no formative assessments. You just carry on for 6 years, you do your exam, and you exit. But for the 6 years, how well are you doing? There's no formal assessments in terms of formative assessments. And of course, we had no knowledge-based assessments at that time. There were no MCQ exams. It was all based on clinical assessments and viva voce. So this period, the government said, okay, let's look at the US system, and we engaged ECGME. In fact, we were the first country in the world that adopted the US system outside of the US boundaries. So it became subsequently ECGME International. So we were the first country to set the international format. It was a change from time-based to US-based competency models, and the specialist training committees that I chaired before evolved to become residency advisory committees. The training responsibility also changed. The national committees no more had oversight of the trainees. It was devolved into different sponsoring institutions. So that created a problem because there was no national selection. But what was important change for us was that in the US system, after you graduate from medical school, you entered straight into training. There was no housemanship, there was no MO rotations, straight in after graduation. And that shortened the time frame tremendously. So this was surgical residency 1.0 when we first started for the first 3 years. And you realize that there's no housemanship. Once you graduate, you enter training straight away. This is the US system. And we found that this actually created problems for us because the trainees were very, very young when they entered. Because at 24 years old entering residency, you really are very, very young. In the US, you entered after graduating from the first degree. So you are 28, 29-year-old. There was also this problem about shortened duration from 6 years to 5 years, and the problem of ABSITEs every year. ABSITE was a training exam, which is MCQ-based every year, but it's very tough for the trainee who's working very hard on the ground. You're operating every day, trying to study for MCQs, and it's quite daunting on them. We kept the English exams. We did the MRCS and the conjoined specialty exams still. So we're still doing the UK type exams, but with the US training system. So it was a bit of an awkward situation for the trainees. And it's a bit trying to switch to two different worlds and two different systems. What was good about ACGME was that they looked at competencies in many ways. I know that UK colleges have gone that way now also. These are some of the competencies that we looked at. What was important, they brought in time-restricted training programs. So in the old days, as a registrar, 120-hour work week is no issue for us. You stay on call for 3 days in a row, no issues for us. But working hour restrictions became a problem when it came in because you shorten from 6 years to 5 years, you shorten training time from 120 hours to 80 hours. It's a big change in terms of exposure to training, exposure to clinical material. Decentralized training, Singapore has got 3 different clusters. The 3 clusters are now separately involved in their own training programs. So instead of a national program, we now have 3 separate programs delivered through 3 different institutions and 3 selection processes. So it became a bit more confusing and a bit more competitive. And of course, we introduced the exams for knowledge-based assessments. So we brought in the American Board of Medical Specialties, and they created a body called ABMS Singapore. This was good for us because it was tech transfer. We paid for this, of course. We paid a lot for this. But the American Board of Medical Specialties taught us how to learn to write exam questions on MCQ base. They helped us craft questions. And over the years from 2010 onwards, we slowly evolved our own question bank so that now the exams that are being done with ABMS are 80% Singapore written questions, and they become our property over time. But there were issues, as I mentioned to you. It wasn't quite as smooth sailing. We realized that the absence of housemanship after graduating created a lack of broad-based training for our students to become a specialist straight away. The exposure as MO was important because we wanted you to be more rounded as a clinician. And the shortened training duration from 6 years to 5 years and from 120 hours to 80 hours also created exposure problems for clinical case material that they are used to. We still had clinical assessment overload because now you're seeing EBSITE every year. And of course, the exit exam was still British-based and still clinical-based. So how do we evolve? We went back to the housemanship requirements. Okay. So after 3 years of doing this, we said, yes, housemanship must come back. You apply after you do a couple of years of MOship. So we brought back the first 2-3 years, and then you enter into training. We took away EBSITE because it was too daunting for our trainees, and we kept the exams for the UK system for clinical exams, and we kept the ABMS MCQ for knowledge-based examination. This is our model for 2.0. But there were problems still because the MRCS and the exit wasn't quite purpose-fit for residency. They weren't trained for it. And residency period for senior residency was too short at 2 years because it used to be 3 years plus 3 years, then 2 years plus 4 years, and now 3 and 2. So we had to evolve again. And this evolution, as you see now, which is 3 years of junior and 2 years of senior, then became 2 junior years and 3 senior years, similar to what it was in the British system, where we shortened the 2 years for a cross-surgery in general program for all specialties. So where are we now, having done all that? It sounds confusing. I myself, we were evolving it over time, trying to learn things and trying to understand and adapt as the world was changing also. So from this year going forward, there were a few things that have changed. And we realized that whatever we brought in before didn't quite work for us because we like to know our trainees. In the British system, we had 6-month rotations. We knew our trainees very well. You trust them to operate as first surgeons. In the US system, the rotations are 1 to 3 month rotations. It's too short to know somebody. If you don't know the person, you won't let them operate as a first surgeon. And that gap was a big gap, big problem for us. So this is a Singapore drink. Those of you who have been in Singapore will know this drink. It's called kopi cham. Cham is a Hokkien word for mix, and kopi is a Malay for coffee. So what you see is black coffee, milk tea, combined you get coffee milk tea. It's a strange taste, trust me. If you haven't tasted it before, you can try later on mixing coffee and tea. But it's an interesting taste and it grows on you over time. So we took the best of both. We took black coffee and we took milk tea. We combined it to Singapore kopi cham. So what happened? We took the best from the British system and the best from the US model. So from the British system, we said, yes, the prior clinical exposure as a senior doctor after graduation was important before training started. Don't enter surgical training so early. Do a year of housemanship, do a year or 2 of medical officer rotation, and then come in and apply for traineeship. We realized that the British system of trainer-trainee bond, which was built over 6 months rotations, are actually quite good for us because the bond becomes strong you know a trainee well, they can look after your patients very well. 1 month rotations, 3 months is too short for getting them to be there. The clinical load was important. The training hours are important because with the kind of load, you can actually get the experience that you need. Surgeons are not just thinkers, we are doers. If you don't have volume to train, you can't do well. So that was important for us. And we felt that the clinical-based exams that the college exams were doing in the UK were actually very good ways of assessing higher order thinking. The Viva is realistic because when you interact and you discuss cases, you probe deeper than the simple MCQ-based exam. And the same for the clinical examination as well. It's more real to life. Now, from the US system, what we found was that, yes, if it's time-based only, we are limiting our trainees to complete by time without looking at competency. So we then said we will keep competency-based assessments based on what HGBA taught us, but we also wanted to keep the knowledge-based assessments, which is what's happening in UK as well. So now we have knowledge-based assessments together with clinical assessments, and the structured program from US we kept also. So this is the best of both worlds that we took into consideration. And now, going forward from this year onwards, this is surgical residency 4.0, the Singapore model. And here it will be a year of housemanship, 1 or 2 years of MO rotations, you enter 3 years of junior residency, 3 years of senior residency, and then you exit as an associate consultant. So this is our current structure, and we will do 2 exams to remove the exam strain on the trainee. We'll do an exam at the intermediate level called the Primary Master of Medicine conjoined with Hong Kong and Edinburgh, and a new modified conjoined exit exam, which is MCQ followed by clinical exam. So this is our assessment model. We look at different things for different competency skills using different tools for assessment along the way. And they're done both as formative as well as summative assessments. And they give us a very broad overview of our trainees to give us a more rounded assessment so that we're more complete in how we will see they are going into the future directions as a surgeon itself. Now, the exam assessment format is like this. The formative is on top, summative is below. The formative ones are, we do DOPS, which is direct observation of procedural skills. When the trainees come to us and operating with us, we observe them, we grade them using the US-based system of scoring. It's a checklist for scoring how they will do DOPS. We do EPAs for clinical competency on a regular basis. There's monthly review of EPAs for different competency score sets. But we still kept the summative assessments at the intermediate level and the exit level. So once when you complete your basic surgical training and once when you finish your advanced surgical training. And it's done to assess 4 different things: knowledge, reasoning, clinical skills, and professionalism. And it's done through different methods, through MCQs, Vivas, and clinical examination. So we're trying to combine everything into a different system format. And we hope it will work. We will tell you later, 5 years, maybe how it's going to come. If sooner we invite back 5 years later, let you know. Now, just a taste of what the exams are like. This is a new exam that we just structured starting this year, okay? And it's a combined exam between Hong Kong and Singapore College, supported and guided by the Edinburgh College. So it's our local exam between 2 Hong Kong and Singapore partners, but supported and guided by Edinburgh College. And the intermediate exam looks a bit like the MRCS, okay? But it also looks a bit like the JSF exit exam. So we have got 3 parts: a part 1 MCQ, so we have the knowledge-based assessment; a part 2 EMQ, again knowledge-based; and a part 3 OSCE exam, which is more Viva and clinical-based. And this format is created with a joint bank from the 3 parties. We write our own questions, so it's acclimatized to our own setting and our own practice, our own way of practice. Hong Kong and Singapore are very similar, and the practice model therefore looks quite similar. We have also changed the requirements for clinical exam. There's a mandatory requirement to do the intermediate exam MCQs before you go to the clinical examination. So this is the JSF MCQ. Again, likewise, we have paper 1, paper 2, 100 questions, and this will be adopted from the American board questions that we had before. It will transit into this bank. So the banks that have been written, validated over the last 16 years will now become the new bank for this. And of course, we kept the Vivas. This is very typical of the intercollegiate exam format. We have kept all of this. And we introduced academic Vivas, anatomy Viva, and so on. So very similar to the UK system. So in conclusion, ladies and gentlemen, friends and colleagues, surgical training is all the same. Wherever you go in the world, it's all the same. What do we want from our trainees? We want great surgeons. If we want great surgeons, the way of training them cannot be very different. So we learn from different people, we share and we collaborate. And if we can partner each other over the years through different associations, different societies, we can restructure our program to be more similar and more, in a sense, more progressive and more forward-going. Surgery training obviously is long, complex, and evolving. And also with patients' expectations changing over time, we should be more aware of this. But I want to just share with you something about thinking beyond surgical training. As surgeons, we look at surgical training only as the period of traineeship. But we should think about the pre-surgical training and the post-training and build a system. Without a system, you cannot get very far, which is why most of us multi-head in different roles. We train our students, we train our surgeons, and we train our post-surgeons to be sub-specialists. And that's how we grow as a country, as a nation, as a general population around the world. So, as Tim mentioned this morning, we want to be ready for now as surgeons, but we want to be ready for the future also. So thank you very much for your attention. Please come and visit us in Singapore. This is our beautiful skyline. Thank you for the honor again.
Thank you so much for such a delightful oration, sir. Now it's time for a short tea break for 10 minutes. Then we will be back here in the hall for the highlight of the ceremony, that is inauguration. presidents of affiliated societies, and members of the executive committee. It is our privilege to acknowledge the presence of His Excellency Dr. Shail Rupa Kheti, Ambassador of Nepal to Germany. We now request the esteemed members of the executive committee to solemnly proceed into the hall. Their entrance will be accompanied by the surgical anthem composed by Dr. Utsama.
जीवनको मूल्य बुझ्ने सच्याउने जिन्दगी सजाउने हरेक क्षण हामी डटेर जुझ्ने जीवनको रक्षा गर्न सँगै सँगै अघि बढ्ने
From the mountains to the plains below, where the rivers of compassion flow, with steady hands and hearts so true, surgeons stand for me and you.
नयाँ पिँढीलाई सधैँ मार्गदर्शन दिइरहने सृजनशीलता र हाम्रो चुनौती पछि सफलता मिलो सधैँ सफलतामा हँसो र खुसीका पल सँगै
Sleep at night and endless care. Our healing touch is always there. With skill, with honor, proud and free. We serve with love and dignity. In the theaters, light is there. Precision guided by our noble hand. With knowledge deep and purpose pure. Every disease we try to cure. A surgeon's touch will prevail for cure. Our legacy will long endure. Long live the Society of Surgeons of Nepal.
Ladies and gentlemen, once again, a very warm welcome to the inaugural ceremony of the SSNCon 2025. It is a privilege to have your presence with us this evening. We are deeply honored to have all of you here. Without further ado, I would like to invite our esteemed dignitaries to the dais. Kindly welcome the President of Society of Surgeons of Nepal, Senior Consultant Dr. Romeo Kansakar. the President-elect of Society of Surgeons of Nepal, Professor Robin Joshi. Our chief guest is arriving shortly. Next, we have the General Secretary of Society of Surgeons of Nepal, Dr. Anip Joshi. Our scientific chair, Professor Sunil Kumar Sharma Dhakal. May we all please rise for the national anthem.
Salutunga pulka हामी एउटै माला नेपाली सार्वभौम भई फैलिएका मेची महाकाली सायुथुङ्गा फुल्का हामी एउटै माला नेपाली सार्वभौम भई फैलिएका मेची महाकाली प्रकृतिका कोटि कोटि सम्पदाको आचला वीरहरूका राजधानी स्वतन्त्र र अचल ज्ञान भूमि शान्ति भूमि तराई पहाड हिमाल अखण्ड यो प्यारो हाम्रो मातृभूमि नेपाल बहु जाति भाषा धर्म संस्कृति छन् विशाल अग्रगामी राष्ट्र हाम्रो जय जय नेपाल।
We now invite our esteemed dignitaries on the dais to kindly come forward for the ceremonial lighting of the panas. We have our senior surgeon, Professor S.K. Dr. Bhattacharya. Thank you, sir. It is now my honor to invite our President, Dr. Romeo Kansakar, to deliver the welcome speech.
So good evening to you all. Honorable Chief Guest, she has not arrived yet. So she'll be arriving shortly. So distinguished national and international delegates and presidents of the various surgical societies, respected advisors and seniors, delegates from abroad and across Nepal, esteemed speakers and faculties, members of the Society of Surgeons of Nepal, ladies and gentlemen, warm greetings and heartfelt welcome to you all to the Kingdom of to Nepal. It is my great honor and privilege to address this august gathering and welcome you all on this 16th International Conference of the Society of Surgeons of Nepal. Your presence here enriches this event and inspires us to continue striving for surgical excellence in our country and in the world. So at the outset, I extend my deepest appreciation to all our distinguished speakers and faculties, both national and international, who have contributed their time, their expertise, their energy, and wisdom for this conference. I also express my sincere gratitude to the Honorable Health Minister for gracing this ceremony as a chief guest, and to all our presidents of different societies and representatives from various surgical societies across the world, the Association of Surgeons of India, the Royal College of Surgeons of India, the Royal College of Surgeons of England, the Royal College of Surgeons of Glasgow, the College of Sri Lankan College of Surgeons, Bhutanese College of Surgeons, Maldivian Surgical Society, and Pakistan Surgical Society, and all those have come from various countries across the world. So over the past 2 years, I have tried my best to take this Society of Surgeons of Nepal to a greater height. We have worked with dedication to extend our academic, professional, and public health contributions. I'm proud to highlight some of these initiatives. We have strengthened our SSN journal to provide high-quality academic publication, and which has been indexed. Introduction of continuation of training courses for the young surgeons and residents, helping to build the next generation of leaders in surgery. Regular continuous medical education activities, organization of conferences with various IAGS, with ISCP, with Bhutanese Surgical Society, and others to serve our community. In conducting public awareness camps and outreach activities to serve our community. The inclusion of dedicated nursing session in our conference, acknowledging their central role in surgical care of our patients, advocating and fighting for the rights of and welfare of the surgeons across Nepal, promoting universal adoption of surgical safety checklist, reinforcing our commitment towards patient safety and care. So one of the other achievements that we have done this year is the successful incorporation of the collaboration of allied surgical societies, including the Neuro Society, NESON, the Euro Society, NAUS, the GI Society, NASG, Plastic Society, the Oncothoracic and Vascular Surgical Society. We are all from the same fraternity, and together we are stronger. So today we are also moving towards significant collaborations with various other societies. So we are in the process of signing MOUs with AMASI, the Association of Minimal Access Surgeons of India, the Sri Lankan College of Surgeons, and ISCP, International Society of Coloproctology, ASI, Associations of Surgeons of India, and various other organizations, so that our junior surgeons will have training opportunities and skill development and surgical education for our members. So a conference like this, of this scale, is impossible without teamwork. So I would like to thank all the sponsors who have generously helped and supported to make this event successful. My organizing committee, thank you very much. And the volunteers, especially Mr. Kamal Sherpa, our secretary, for his unwavering commitment. So our organizing committee and our executive committee have tirelessly worked behind the scenes and kept everything going till now. So my sincere gratitude to our immediate past president and the scientific chair, Dr. Sunil Kumar Sharma, who has always stood by me and supported every endeavor of the SSN activities. To each one of you, thank you for believing in the mission of the Society of Surgeons of Nepal. I hope you all enjoyed Nepalese hospitality and the scientific, academic, and cultural activities we have prepared for you during this conference. If there are any shortcomings, I humbly request your understanding and forgiveness. Let us continue to work together for the excellence in surgery, for our patients, and for our future. Long live the Society of Surgeons of Nepal. Thank you and namaste.
Thank you so much, sir. We are delighted to announce the release of this year's conference souvenir. May we invite Dr. Manish Pokharel and Dr. Tanka Bohara for the souvenir release. We now request our General Secretary, Dr. Anip Joshi, to present the General Secretary's report.
Thank you very much, Sneha. Namaste and warm evening. Good evening to all the national delegates and our international guests and friends from all over the world. So we welcome you once again to the land of Himalayas, Lord Buddha and Pashupati Nath. So I'm given this opportunity to present the 2-year report of Society of Surgeons of Nepal. It has been a wonderful experience to work for our society, which is running now in its 33 years and still running in quite a good shape, and working for the betterment of surgeons of Nepal and working for the welfare and professional growth of surgeons all over Nepal. This executive committee has done numerous works. I would like to introduce a few of the works that has been done. First, there has been a lot of memorandum of understanding that has been dealt by this executive committee with many other societies from India, from Sri Lanka. Besides that, this has also created many opportunities for the young surgeons as well as the trainee surgeons who we believe in society as the future of surgery, who are the torchbearers of surgery and who are going to lead the surgery of the country. Besides that, the society has also dedicated a lot of its time to work for the community. It has gone into community level and done a lot of community awareness programs as well as many surgical camps. In order to help in the professional growth of the trainees and surgeons, Society of Surgeons of Nepal has conducted many continuous medical education programs in acute care surgery, surgical critical care, breast and thyroid surgery, and numerous other surgeries in Kathmandu as well as outside Nepal. Our president has visited many other chapters of Society of Surgeons of Nepal to conduct these CMEs and symposiums. We, as executive committee, have been able to conduct 2 conferences. Last year, we conducted, at the end of 2024, we conducted in Pokhara, our National Surgical Conference, which was in collaboration with South Asian Surgical Care Society. And this year, this is the 16th International Conference of Society of Surgeons of Nepal that we are holding. In addition, the society has also thought about its valued members, so that's why it has provision of many awards like Young Surgeons Award, Best Resident Awards, and Poster Awards to promote the professional growth and scientific activities of the surgeons in addition to their clinical care. Society of Surgeons of Nepal has also conducted many training programs, such as basic surgical courses in collaboration with Nepal Medical Association. President of Nepal Medical Association is here with us. We are very grateful to you. Besides that, we also had conducted basic surgical skills for young doctors like medical students and those young doctors who are interested in surgery, because we want to hone them, we want to give them opportunity and show them how surgical skills are gained. We also worked with other societies of Nepal, such as Cardiac Society and Society of Internal Medicine of Nepal and Society of Anesthesiologists of Nepal, in order to draft an intersocietal consensus recommendation for preoperative cardiac evaluation of patients. This is to promote the collaborative work between different societies, professional societies of the country. Our president, along with other members, visited National Medical Education Commission of Nepal, and then they drafted a curriculum and gave a very genuine advices to improve the quality of surgical education of Nepal. We were also invited by Ministry of Health in association with World Health Organization and Nick Simons Institute last October for drafting the National Surgical Plan. And we were very much close to drafting this plan, because we thought that surgery should not be focused just in the urban areas or the city areas, but it should be gone into the marginalized areas as well as the rural areas of the country. With that vision, we have been trying to amalgamate many different chapters of different provinces of the country in order to give a fresh mandate to the society and to give opportunities of leadership to its valued members of the Society of Surgeons of Nepal. Society also conducted its executive committee election for the 2026-27 body, and it was done by the Chief Election Commissioner, Professor Sunil Kumar Sharma, and his team. We have also done few of the work and drafted for the change in the constitution, because with time, everything needs to be changed, and change is inevitable. So the constitution that we have also needs to be amended. So this executive committee has also formed, as per the Constitution of Society of Surgeons of Nepal, 3-membered Constitution Amendment Committee, which is working to amend the constitution. And few things that would be valued and treasured by all the members, and which I'm also very personally close to, is this committee has been able to design the different gowns for the Society of Surgeons of Nepal and given the officiate these gowns for these kind of inaugural sessions, which we are wearing at the moment. Besides that, it has also officiated SSN anthem, which we heard during the march in procession, as well as the scepter, which stands tall here in front of this August gathering. So for our international guests, we would like to say that our country is diverse, geographically, culturally, linguistically. So we try to find this unity in this diversity. So that's why Society of Surgeons has also invested a lot to include all the province chapters in this society. In this process, before this executive committee was formed, 4 chapters were already there. So the Sudur Paschim chapter, which is the far western part of Nepal, and the Madhya chapter, which is the southern Tarai part of Nepal, has been now incorporated in the Central Committee of Society of Surgeons of Nepal. And just a couple of months ago, we heard voices from our friends, from our colleagues who are working in Karnali region. Karnali region of our country has got the lowest human development index or the economic status. So that's why we want to include that area as well, and with that focus of including the marginalized as well as the rural surgical care system, we also incorporated Karnali chapter in this executive committee. And our country has undergone a lot of revolutions, and we are a part of that revolution because it's our society that's changing. Recently, we saw a big revolution in our country where a lot of young people had demanded for change. And then with that sense, Society of Surgeons of Nepal has also invested to start a young surgeons chapter. And our young friends who are the medical students are working on that, who really have interest in surgery, have drafted a draft for the youth chapter, which we are going to incorporate during our constitution amendment. We also think that nursing colleagues are an integral part of our surgical care because as surgeons, we always believe in teamwork. That's why from last year, we have been able to start a nursing session, which is dedicated to our nurses who work for our patients, who are our partners, who are the real heroes of healthcare delivery system, and started this session in our scientific programs and conferences. We are always with our surgeons, and then we are always with the doctors. So whenever there are any voices against the doctors, Society of Surgeons of Nepal has always stood up against those vices, be it about the Consumer Court Act which really suppresses the doctors, Society of Surgeons of Nepal has boldly and loudly raised the voice for their surgeons. And whenever there are violences against the doctors, usually Society of Surgeons of Nepal go in hand with Nepal Medical Association and other professional societies, and then advocate and show the solidarity for our surgeons and doctors of Nepal during any sort of protests or movements. Our president has been honored with many fellowships, to name a few, from the College of Surgeons of Sri Lanka, then Association of Surgeons of India, Association of Minimal Access Surgeons of India, and all these different fellowships has been conferred to our president. So to endorse all these things that we have worked for past 2 years, which are very close to our heart as our executive members, we are organizing our annual general meeting during this conference so that all of these can be officiated and endorsed. So with this brief report of this Executive Committee of Society of Surgeons of Nepal led by Dr. Romeo Kangsakar, I would like to end my report by highlighting this symbol which you can see in front of you, this scepter, and what we wish as the Executive Committee of Society of Surgeons of Nepal is let this scepter stand as a symbol of unity, of fairness, of integrity, of professionalism, of solidarity, and of strength of all the surgeons of Nepal and all the surgeons of the world globally. Thank you very much.
I'd like to announce that we are graced by the presence of His Excellency Dr. Shail Rupakheti, the Ambassador of Nepal to Germany, and the President of NMA, Dr. Anil Karki. I request both our dignitaries to kindly take the front seat. A huge thanks to the Lakhe dancer and the music performers for such an astonishing performance. Now I'd like to call upon our scientific chair, Professor Sunil Kumar Sharma Dhakal, to present the annual scientific committee report.
Good evening. While we wait for our chief guest, she is on the way. We've got the message. I would like to present a few things. So, first of all, I'd like to thank all the foreign delegates and dignitaries who have accepted our invitation and have come to enrich us with their scientific knowledge, and so that all of us here in Nepal are going to benefit for the betterment of our patient care. We've had a 3-day conference. Today is the second day. Yesterday we had a pre-conference workshop, and I'm sure there are going to be very more interesting deliberations tomorrow. So just to highlight a few things, it was always my dream that we Nepali surgeons should conduct a pre-conference workshop on our own. I'm very thankful to my Indian colleagues who've been helping us for the last 25, 26 years since the inception of this society. But at the same time, I'm very proud to say that for the first time, we had a complete Nepali faculty pre-conference workshop that went well, very well yesterday. A big round of applause to our young, dynamic surgeons. There are a few I must mention that showcased excellent work. Dhiresh Mahajan, Satadi Bhattacharya, Dr. Tanka Bora, Dr. Rakesh Gupta, Dr. Pranil Rai, Dr. Nirvan Rai, and so many more to mention. They did an excellent job in showcasing the beautiful work. I'm also very proud to announce that recently, for the information of all Nepali surgeons, it's been a proud moment. If you are here in the hall, I'd like you to stand up. Dr. Pratik Gurung, are you here? Dr. Pratik Gurung. Well, Pratik demonstrated a robotic pyeloplasty, a Nepali surgeon demonstrating in a Nepali institute, operating on a Nepali patient. So for the first time, a robotic surgery was live telecast, and it was under the banner of Society of Surgeons of Nepal. So that's been a proud moment to us as well. We're going to have more deliberations tomorrow. Please look forward to it. This society, along with the South Asian Surgical Care Society, has a South Asian Surgical Care session tomorrow. As our president said, we've had with the Neurological Society, with the Urological Society, with the Plastic, the Cardiothoracic, we've had various sessions. We're very proud to say for the first time, because of our president-elect, Dr. Robin Joshi, we've had a full day of the Now session within this conference. So truly, Society of Surgeons stands as the mother institution and taking all the other societies forward. In total, we are going to have 68 guest lectures, 177 free papers, 15 video presentations, 27 posters, 2 debates, and I was part of that. And my other debater, Dr. Robin Koirala, I think did a fantastic job today. A round of applause to him as well. We had 4 panel discussions, 2 today and 2 tomorrow. And for the first time, our General Secretary requested, like the TED Talk, we have started what is known as the SSN Talk. So we've had a full day of an SSN Talk. We also had the special lectures delivered by our very own Professor K.D. Joshi, his hallmark journey in establishing plastic surgery in Nepal. So I hope it's going to be a fruitful 2-day as it has been to us. and we hope to see you again in the future. Now, I've got one more announcement. I'm going to change my cap. I was requested by the executive to be the Chief Election Commissioner for this year, and we had our society elections recently, and these are the following who will be taking over the executive from Romeo and his team at the end of December, the 1st of January. So I'm going to call out the names. Please be kind, rise from your seat and just introduce yourself to the gathering. President, Dr. Robin Joshi. Immediate past President, Dr. Romeo Kansakar. Senior Vice President, Dr. Rupesh Mukhia. Vice President, Dr. Pranil Rai. General Secretary, the very dynamic and the lady who gives us all that exuberance, Dr. Sumita Koju Shrestha. Treasurer, Dr. Aneep Joshi. Joint Treasurer, Dr. Roshan Gimere. Sorry, Dr. Roshan is the Joint Secretary. Joint Treasurer, Dr. Utsab Man Shrestha. And we have for the first time 5 Gen Zs among surgeons, 5 newcomers who are going to overhaul the society, hopefully for the better. Dr. Sujita Hirachan. Dr. Uttam Laudari. Dr. Bidur Prasad Acharya. Dr. Rakesh Shah. And my dear friend, Dr. Akananda Singh, but apparently he had some errand to go to Delhi and he has gone. So I wish a very good tenure for the next 2 years and congratulate every one of you. Thank you very much.
Thank you so much, sir. Our chief guest is almost here, so we will wait a minute for her.
haya ha ha siri ma ha ha mandu siri ma ti rina vijaya aha Nepal mandal माझे पद्मगिरी निवासिता आहानमा मीना मामी श्री महामहु घोषम उमा वर्णा दे एकास्य चातुर्भुज नमा मीना मामी श्री महामहु घोषम ahadahi ina puja ahapharga saradhari ahapama ahapuja ahapustaka Danodari ahanama meena mami siri mahandu ghosham aate ekumanda Latri Jukumara Ahasuba Arnapadu Kapati Ita Puja Ahanama Meena Mami Siri Mahandu Ghosham Ahasadu Guru Prasta Deri Siddhi Ahavanai Siri Surata Apaja Gita Jariya Ahanama Meena Mami Siri Mahandu Ghosham
La sole asa Lasole asa dimkhanan Lasole asa khalana Lasole asa dimkhanan
ए घर हाम्रो शिखरपुर वरपर चार भाइ हाम्रो हाटघर तेरो मेरो घरबार होला कि होइन जाऊ मै च्याङ बरबर लासो
हाम्रो तेमल वरबारा हुँदैन तेरो मेरो घरबारा घर हाम्रो तेमल वरबारा हुँदैन तेरो मेरो घरबारा आफूले देखे क्या भनेला होइन चङ्बा वरबारा आफूले देखे क्या भनेला होइन चङ्बा वरबारा
घर हाम्रो शिखरपुर वरपर चार भाइ हाम्रो हाटघर घर हाम्रो शिखरपुर वरपर चार भाइ हाम्रो हाटघर तेरो मेरो घरबार होला कि होइन जाऊ मै च्याङ बरबर तेरो मेरो घरबार होला कि होइन जाऊ मै च्याङ बरबर रोसीमा खोलामा तर्ने माथरबाट कहिले नगर ए रोसीमा खोलामा तर्ने माथरबाट कहिले नगर अरूले देखेमा क्या भन्ला है आफूले देखेमा ज्वाइँ भन्ला अरूले देखेमा क्या भन्ला है आफूले देखेमा ज्वाइँ भन्ला
घरि जो बनाउँदैन दुई दिने माया लाउँदैन जो बनाउँदैन दुई दिने माया लाउँदैन आफूले देखे क्या भन्ला है तलमाथि परेमा चाहिँ जानला आफूले देखे क्या भन्ला है तलमाथि परेमा चाहिँ जानला
ए बानको ढुकुर पैगुनी तलमाथि परेमा मैसुनी ए बानको ढुकुर पैगुनी तलमाथि परेमा मैसुनी छोरीको घरबाट रुखैमा है बितौल जीवन सुखैमा छोरीको घरबाट रुखैमा हो बितौल जीवन सुखैमा
माछा त मर्ने जोभनमा माया त लाउने जोवनमा माछा त मर्ने जोभनमा माया त लाउने जोवनमा घर हाम्रो तेमल वरपर है बल्ल पुनिल्यो धौतारा घर हाम्रो तेमल वरपर है बल्ल पुनिल्यो धौतारा घर हाम्रो तेमल वरपर भइ जाला तेरो मेरो घरबार आफूले देखे क्या भने होइन चङ्बा वरपर 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 आफूले देखे क्या भने
A huge thank you to all the performers for such a great, astonishing performance. Kumari dance, that was first, symbolizes purity and the divine grace of the living goddess. And the Tamang dance is a joyful expression of rhythm, energy, and the cultural spirit of the Tamang community. I'm happy to announce that we have been graced by our honorable chief guest, the Health Minister of Nepal, Professor Sudha Sharma Gautam. I request our chief guest to kindly come on to the dais. I request our president, Dr. Romeo Kansakar, to kindly offer the token of appreciation to our chief guest. I would like to request Professor Sudha Sharma Gautam to kindly share a few words with us.
Namaste and good evening to you all. President of the Society of Surgeons of Nepal and the executives, all the distinguished guests who are here, all our seniors. I can see right here from Dr. Bhattacharya to Dr. Vaidya and so many others and executives in the front row, all the young surgeons and their families. It's wonderful to see you here. First of all, I must apologize for being late. There were two important meetings which were unscheduled but had to be done. So I got delayed. And then tomorrow I'm traveling out of Kathmandu. So there was a lot of pending work on my desk and the traffic of Kathmandu. So sorry about that. But anyway, they say better late than never. And right now I'm here. I don't know what will happen. I've just arrived and I'm supposed to speak. So I don't know what I'm going to speak. But whatever I speak will be right from my heart. And to all the international guests, it's welcome to Nepal. I hope you get to stay here. You must have seen the scientific progress that Nepal has made. I usually keep telling people that when I was studying, we did not even have one medical college in Nepal. And there were just a handful of doctors, not even a handful. You could count them in, like this, 1, 2, 3, 4, not even more than that. But now we have thousands of doctors, hundreds of surgeons, all sorts of specialties. And we have beautiful hospitals. The quality of care is really big, better. So I really feel proud to be leading this, the ministry and the whole health sector, because Nepal government follows a policy of public-private partnership. So our government hospitals and the whole infrastructure, right from grassroots of health posts up to the tertiary care hospitals, owned by the government and the private sector, private big hospitals in urban areas. I think we work hand in hand, and I'm so pleased to see that there are so many young doctors sitting out here trying to learn and share experiences. So whatever discussions happen here, I'm sure will be enriching to all our young doctors, and they will be learning the state-of-art, surgical skills. And I bet there are some pre- and post-Congress workshops to really teach them what goes on. I myself, as some of you may know, was and is an obstetrician gynecologist, but one of the wise people of the Asia Oceania Federation, a professor, he told me, you know what? Whatever comes inside the hospital is just a tiny fraction of what happens out there in the community. And he was so right. I've seen hundreds of women suffering, men, falling from the cliff, fractures, all surgical, cases out there in the community. So I chose to become a public health professional and gradually shifted from becoming a clinician to a public health administrator, like a secretary in the Ministry of Health. And now, some of you might know already, Nepal is in a critical stage. All our young generation, so-called Gen Zs, they want to see change. So in that change process, the country is going through tough times. And now I've got the responsibility of leading the Ministry of Health. Although I'm not a politician, but it's a political work. And I got to be carefully treading and making progress. And I just have 4 months to make all the progress that needs to be made. So I'm working full time and making my team work hard. So, and I'm sure the doctors who are here, they will see a visible difference in the next 4 months. And I don't have very many priorities because the time is short, but I have 4 priorities. One, I have said, is mental health, because now is the time where we really need to look after people's mental health and integrating that in the public, service delivery system of healthcare. That's important. Secondly, in Nepal, because of the geography and because of various other issues of marginalization, the 4 of the provinces are kind of a little behind in terms of making progress for maternal newborn health and other interventions. But me, being an obstetrician and a public health professional, I have prioritized intensive interventions in these 4 provinces which are lagging behind. And the third is the health of the migrant population. So these are the 3 areas of clinical priorities that I have set. I already know surgeons are doing great, so that I did not set as a priority. It's always a priority. But on the other side, the drug distribution system, the procurement system, the medical laboratory system where quality of drug is assessed, and then the health insurance program. I can see Dr. Pradeep, who's right here. Nepal government introduced the social health insurance scheme, and although it's a decade long, we still have many teething problems, and we really need to, understand the issues and make it right. So that is another priority. And as clinicians, we have to provide good quality services. So I visit the hospitals. I've done a tour of few Kathmandu hospitals. Now I'm off to the Pradesh. Tomorrow I'm going to Kapilvastu, to Lumini area, seeing some more hospitals, and then I have scheduled others. And in this forum, since you are here, some of these you Nepali doctors already know, but just to give a comprehensive picture of Nepal's healthcare and the priorities of the government, in a short while I've said this, but now I want to talk exclusively to the young population and also the leaders who are the role models and who should be the role models. Let us not forget how badly we communicate with our patients. Communication continues to remain an issue whenever there's a tussle between the people and the hospitals. So I think at every step we need to improve that. And Nepal Medical Council's election is coming up, and ethical practice is another issue. When I sit in the chair of the minister, I see a lot of patients, poor men and women, come with all sorts of complaints about how medical council did not listen to them, and maybe they have to go to the consumer court. And if they do, it's going to be very bad for the doctors. So yes, the doctors are our brothers and sisters, but let's not forget, we are all here to serve our patients. So when it comes to taking sides, don't take any sides. Just look at scientific evidence, be honest with yourself, and give justice to those who have suffered. So that will be my second request, especially because the council elections are coming up. So whoever is standing has to make that as the first thing that you would like to do. And there are some other things, but time is short, and I don't want to keep you away from all the entertainment. Thank you for having me and to come here. My husband is a surgeon, and I asked him to come, but I couldn't go and pick him up, and he said, maybe I'll come later. So that's how life is, And so now the time has come for me to say thank you again for having me here. And I hope I'm not taking too much of your time. So wish you all the best, all success to the Congress. And surgeons shine in Nepal, and they continue to do well, but let's do even better. So with these few words, I want to say goodbye. Namaste, dhanyabad.
Thank you so much, ma'am. We now move on to one of the most significant highlights of this evening. The presentation of honorary fellowships to distinguished surgeons whose lifelong contributions continue to inspire the surgical community worldwide. These fellowships are received by the fellows and conferred by the Society of Surgeons of Nepal. We now request the following esteemed surgeons to kindly step forward in alphabetical order of the names. Dr. Abdullah Ubaid, the President of Maldives Association of Surgeons. Dr. Duminda Aryaratne, the President of College of Surgeons of Sri Lanka. Dr. Igor Kharkov, the Director of Moscow Clinical Scientific Center named after A. Loginov, and the Chief Oncologist of the Moscow Healthcare Department. Dr. John Camilleri Brennan, the Vice President of Royal College of Physicians and Surgeons of Glasgow. He is an acclaimed colorectal surgeon and academic from the University of Glasgow, renowned for innovations in pelvic floor and minimally invasive surgery. Dr. Kalpesh Jani, the President, Association of Minimal Access Surgeons of India, an innovator in laparoscopic hernia repair, an esteemed academic contributor with over 55 publications and 250 conference presentations. Dr. Kushal Mittal, the President, Association of Colon and Rectal Surgeons of India. Dr. London Lucian, Senior Surgical Oncologist and Professor of Surgery at Singhal Duke at Singapore. He's one of the most pioneering surgeons in Singapore. Dr. Prashant Rahate. Dr. Prashant Rahate is a renowned minimally invasive and robotic surgeon at CMD Nagpur and an international academic leader with an extensive global teaching experience. Dr. Praveen Suryavanshi. He is the President of Association of Surgeons of India, a pioneering hepatopancreatobiliary and transplant surgeon known for performing the first liver transplant in central and eastern Maharashtra, and for his transformative leadership in surgical education. Dr. Satish Midha. He is the president of Indian Association of Gastrointestinal Endosurgeons. Dr. Tashi Tenzin, Consultant General Surgeon and Neurosurgeon from Bhutan, known for his surgical excellence and his humor. Dr. Tim Michel, the President of Royal College of Surgeons of England, a distinguished ENT surgeon from the University Hospital Southampton, and a global advocate for surgical education, inclusion, and professional excellence. Dr. Vijay Kumar Mittal, Associate DIO for Medical Education and past Chair and Program Director of Surgery at Henry Ford Providence Hospital, USA. Dr. Vinay Kumar Kapoor, Senior Professor, Department of Surgical Gastroenterology, Mahatma Gandhi Medical College and Hospital, Jaipur. A Fulbright, Commonwealth and UICC Fellow, recipient of the Dr. B.C. Roy National Award, and one of the top 2% scientists in the world in the field of surgery. A huge congratulations to all our honorary fellows for this well-deserved recognition. We now present a short documentary that reflects on the remarkable journey of surgery in Nepal, from its early beginnings with limited resources to the growth of structured training programs, specialized units, and modern tertiary centers. A pivotal figure in this evolution is Professor Dr. Anjani Kumar Sharma, honored as the father of modern surgery in Nepal and an early pioneer of oncological services. His leadership and foresight, including the establishment of Department of Surgery at Bir Hospital in 1962 as the first. It laid the groundwork for the organized surgical practice we know today. We are following his footsteps. We would also like to express our sincere appreciation to Dr. Sujan Regmi and Mr. Adam Yanupani from Genito Software for their invaluable contribution in preparing this documentary titled History of Surgery of Nepal. Ladies and gentlemen, we now invite you to join us in watching this documentary, a tribute to our heritage and the spirit of surgical excellence in Nepal.
My dad was a fantastic father. Young surgeons, you have to be very careful about this, right?
मैले त्यही बेला लेखेको थिएँ कि I am not a pessimist, I am an optimist.
म एमबिबिएसमा जाने बेलासम्म खालि एमबिएस ग्रेजुएट मात्रै पोस्ट ग्रेजुएटहरू कोही थिएन।
मैले चाहिँ सर्जरी गर्ने बेलामा चाहिँ हामी त्यस बेला धेरै कम सर्जनहरू भएको बेला जम्मै हामीले नि गर्नु पर्थ्यो।
सर्जन नभए पनि म जिल्ला अस्पतालमा गएर सर्जरी गर्थेँ।
They used to call me knife in doctor.
What would I be if I was not a doctor? Probably nobody or nothing else. I don't know.
So म चाहिँ अब चिकित्सक कसरी बन्यो त्यो पनि इन्ट्रेस्टिङ स्टोरी छ।
अनि हामीले टेन्ट राखेर छेरेर भेटनरीको चाहिँ सामानहरू युज गरेर मैले पोस्टमार्टम गरेँ।
अब सबभन्दा ठुलो समस्या चाहिँ थोरासिक सर्जरी डेभलप गर्दाखेरि धेरै जुनियरहरू इन्ट्रेस्टै थिएन।
त्यो अपरेसन गरेपछि you know the word he used, bladder stone, which is 5 minutes of 15 minutes. I have done the very major operation of my life. This was Beer Hospital.
एसएसएन को जुन एक्टिभिटिज छ त्यो चाहिँ हाम्रो सर्जन्स को एउटा अम्ब्रेला हो।
Society of Surgeons has a legacy of many years. र अहिलेको जुन आएको यङ जेनेरेसन छ नि यस्तो डाइनामिक छ नि देखे पनि आनन्द आउँछ आफूले। So what I would like to say to my predecessors and my future surgeons is
give an energetic effort. यो बिरामी मेरै फ्यामिलीको मेम्बर हो भनेर उनले हेर्नुपर्छ।
त्यसले मेडिकल सर्भिस या मेडिकल डक्टर भन्दा चाहिँ तिनटै चिज उनीहरूको चाहिँ डेभलप हुनुपर्छ। त्यसमा नलेज पनि हुनुपर्छ, स्किल पनि हुनुपर्छ, एटिट्युड पनि।
I hope you all enjoyed seeing the history of surgery in Nepal. We will now move towards the felicitation of senior surgeons of Nepal. We now honor the surgeons of Nepal for their lifelong contribution to surgical practice and service. We call upon the following prestigious individuals who will be giving the felicitation as well as those who will escort the honorees onto the stage. I request Professor Robin Joshi to come forward for the felicitation of Dr. Jagdish Lal Baidya.
I think everybody knows him very well. He needs no introduction, as we all know him as a great, passionate, lovable teacher and father figure to us. Professor Jagdish Lal Baidya, born in 1945, 25th November, from Kaski, Pokhara, and he is a managing director and co-owner of BNB Hospital, and he is the chief of surgery and urology. He did his MBBS in Amritsar, Punjab, India in 1971. He received his FRCS 1977 from Edinburgh, Scotland and England, FCPS 2002 from Pakistan, and he is a visiting professor to Royal College of Surgeons of England. You can see, I don't need to explain his experiences and his work, but apart from that, the major experience he has is he's involved in teaching and training of surgeons and urologists through FCPS programs since 2013. And he has been the professor of surgery and urology, KISS Medical College, 2015. Professor of Surgery and Urology, Kathmandu University, 2001 to 2006. and he's been the managing director of Kathmandu Nursing Home in 1985 to 1997, chief of surgery, Patna Hospital, Nepal, 1985 to 1998, surgeon and urologist, Sant Bhavan Hospital, Nepal, from June 1982. So we have his lifetime achievement are many. So he's got Lifetime Achievement Award by Surgical Society of Nepal in 2012, Lifetime Achievement Award by Department of Urology, Bir Hospital, 2019, Lifetime Achievement Award for Urology Development in Nepal by Sri Birendra Hospital, 2020, and he's the founding president of Nepal Association of Urological Surgeons, now 2005 to 2010. Please give a hearty welcome to Professor Jagdish Lal Baide.
Thank you, sir. Now I request Dr. Pranil Rai to kindly come forward for the felicitation of Dr. Mahavir Krishna Malla.
Good evening, everyone. It is my honor to introduce respected Dr. Mahavir Krishna Malla, who was one of the founding members of our dear Society of Surgeons of Nepal, and my preceptor during my MS residency days in 2001. He is a highly respected senior consultant surgeon who, throughout his distinguished career spanning several decades, has played a pivotal role in shaping Nepal's healthcare landscape through his surgical practice, his dedication to medical education, and leadership in public health. He was born on the 25th of December, 1944, at the beautiful town of Tansen, Palpa, from his parents, Mr. Shyam Kumar Malla and Mrs. Ratna Kumari Malla. He did his schooling from JP High School in Kathmandu and studied ISC at Public Science College, which is at present known as the Amrit Science College, and is happily married to Mrs. Bhagirathi Malla, and his 50th anniversary recently in 2022. His son, Amrit Prakash Malla, and his daughter, Reena Malla Pradhananga, they are both engineers by profession. He finished his BSc in Science from TU in 1962. He then went to Moscow and completed his Bachelor in Medicine in 1969 from Friendship University. He came back and worked as a medical officer in our country's oldest hospital, Bir Hospital, and several district hospitals over a span of 6 years. He then went to the same university in Moscow and completed his master's in surgery in 1978. After returning back, he worked as a surgeon at various district hospitals and Janakpur Zonal Hospitals till 1982. Then, for the next 10 years, he worked as a consultant and then senior consultant at Kosi Zonal Hospital. He then came back to Bir Hospital as a senior consultant, and later he became the head of the department from 1997 to 2002. I mean, this was the time where several of us who are here today, including me, were doing our residency there. Then he became the secretary-level special class officer under the Ministry of Health and Population in 2002 and was instrumental in leading normal policy initiatives, medical workforce planning, and healthcare reforms. He represented Nepal as an official delegate in the Ministry of Health at several global forums, in the US, the UK, France, and several South Asian countries. Then he moved to private sector, and he was the hospital director at Norvik International Hospital from 2004 to 2012. And after that, he contributed as the medical advisor at Norvik International Hospital till 2018. At present, he is a visiting senior consultant at Himal Hospital. In 1994, he was awarded the Fellowship of International College of Surgeons, FICS. And in 2003, he was awarded the Gorkha Dachin Bau Class 3, which is a national honor for his distinguished medical service that he has contributed for our country. So, ladies and gentlemen, let's put our hands together for Dr. Mahavir Krishna Malla.
Thank you, sir. Now I'd like to call upon Dr. Rupesh Mukhia for the felicitation of Dr. Bishwaraj Joshi.
So it is my honor and privilege to introduce Professor Dr. Biswaraj Joshi. He was my mentor during my residency days. Dr. Biswaraj Joshi was born on April 1st, 1947 in Balkhu, Kathmandu, Nepal. And he holds a MD degree, honorary, from Kharkov University Institute, USSR, in 1974. PhD in Urology, Kopic Research and Scientific Institute of Urology and Nephrology, USSR, 1983. He held numerous positions in the past: Nepal Medical Associations, Society of Surgeons of Nepal, Nepal Association of Urology Surgeons, Rotary Club of Pokhara Midtown, Rotary Club of Pokhara Midtown. So he was honored by Mahendra Vidya Bhushan Gold Medal in 1988 for his noble work in the field of surgery and urology, and Prabal Gorkha Dakshin Bahu in 1997 for his academic excellence. He was the chief urology department, Bir Hospital. He was a registrar, NAMS Bir Hospital in 2009 AD, chairman, Human Organ Transplant Committee from 2011 to 2013. He was president, NOWS from 2016 to 2018. He was member of Service Commission NAMS and worked as consultant surgeon and urologist in different zonal and regional hospitals of the country. He was the ex-vice chancellor of Madan Bhandari Academy of Health Sciences in 2020. He has attended many international and national conferences and workshops and symposium and chaired by many national urological conference. He is happily married by Dr. Santi Joshi, and as a son, Biplav Raj Joshi, and daughter, Elita Joshi. So, ladies and gentlemen, let's give a big hand in the honor of Professor Dr. Biswaraj Joshi.
Thank you, sir. Now I'd like to invite our General Secretary, Dr. Anip Joshi, to read the special tribute dedicated to our former Secretary of the Society of Surgeons of Nepal, Mr. Keshav Ghimire.
Thank you very much, Sneha. Honorable Chief Guest, Minister of Health, Chairperson. So this is a special occasion for us because we are going to honor our friend who's very close to the society, Mr. Keshav Ghimire. A big round of applause to Mr. Keshav. So speaking of Mr. Ghimire, he has been involved with the Society of Surgeons of Nepal for almost more than a decade. And his role has been instrumental in building the society to where it is today. From moving on to our new settlement or office at Nepal Medical Association building, or getting our thing registered with all the bureaucratic thing at Central District Office, CDO Office, and all the taxes office. He has been instrumental to make our society in the line with all the laws and rules and regulations of the country. He has been our friend, a good friend of our society. And the most important thing that he has done is because of his own personal commitment, he could not be with us. But he was very much generous enough that he used that transition period to make a clone of him, I would like to say, because we have now Mr. Kamal Sherpa. Please, Kamal, please stand. Yes, now he's the clone of Mr. Keshav Ghimire, who's supporting us. Thank you, Mr. Keshav, for all the work you have done for the society. We, the Executive Committee, and all the members of the Society of Surgeons of Nepal are highly grateful to you. We present to you, ladies and gentlemen, Mr. Keshav Ghimire. Thank you.
Thank you so much, sir. We now proceed to the award segment, recognizing the excellence to the Best Resident Paper Award. It is my pleasure to announce that the Best Resident Paper Award is presented to Dr. Dakshata Shakya. A huge round of applause, please. We now proceed to one of the most symbolic moments of the evening, the medallion handover ceremony. This marks the formal transfer of responsibility and leadership to the incoming president for the tenure 2025 to 2026. As the medallion is handed over, we honor the continuity of service, the legacy of stewardship, and the vision that guides our society forward. We extend our best wishes to the new president and the incoming executive committee for a successful and inspiring tenure ahead. Now, we extend our sincere gratitude to our sponsors for their invaluable support. Goal sponsors, we have DJPL and we have Mr. Vivek Acharya representing. Kindly come forward, please. Mr. Ranjit Sharma from SSI Mantra. Mr. Ranjit Sharma from SSI Mantra. Mr. Jitendra Kumar from Fresenius Kabi, who has already received and had to leave earlier. Mr. Sanjeev Adhikari from Medtronic. Mr. Suraj Kafle from Yatichem. Mr. Sabine Karki from Max Healthcare. Now to our silver sponsor, Mr. Manoj Nupane from Asian Pharmaceuticals. I request Dr. Robin Joshi to formally conclude the inaugural ceremony. But before that, we will have a Nevari dance to enlighten the evening even more. What an amazing performance. I now request our President-elect, Professor Robin Joshi, to kindly come forward and deliver his vote of thanks.
Good evening. Thank you very much from my heart. So respected Chief Guest, Honorable Health Minister, Professor Sudha Sharma Gautam. On behalf of the organizing committee, I extend our heartfelt gratitude to everyone who made this program a success. Our sincere thanks to our advisors for their guidance, to our patrons for unwavering support, and to our executive team for their dedicated leadership. My very warm welcome to esteemed foreign delegates and to national delegates and faculties and different national and international societies. A special appreciation to all our volunteers who had worked, whose hard work ensured everything ran smoothly, and to our sponsors for their generous contribution. I'm very hopeful that with all your support and love, we as SSN will grow further. Thank you all for your presence and encouragement. And I would like to thank, without thanking my family members, the things will not end. So I would like to thank my son, who was very enthusiastic to come over and see this whole procedure. Please, can you rise, my son, please? Thank you very much for coming. Thank you. And thank you all. Thank you very much.
Now I request the chairpersons and our dignitaries to kindly come down to the floor. And on behalf of the Society of Surgeons of Nepal, I extend my sincere gratitude to all our dignitaries, esteemed fellows, respected seniors, and international delegates.
We will go back in procession. Executive Committee, please. Kamal, can you take the scepter first, and then we'll walk behind you.
जीवनको मूल्य बुझ्दै सच्याउने जिन्दगी सजाउने हरेक क्षण हामी डटेर जुने जीवनको रक्षा गर्न सधैँ सधैँ अघि बढ्ने I'm sorry.